flexion effect. So when you stretch and you pull your spine apart and you pull the disc apart, you actually create a negative pressure in the disc, and that sucks nutrients into the disc. It's critically important. And this is the domain of physiotherapy because it's physical. End of range movement, which we get to. And I keep saying it over and over again because it could not be more important. And it's particularly important with back pain because people are often told when they have a bad back to not move their back, to not bend, to lie in bed, to wear a corset, which of course couldn't be more wrong because it's actually denying your discs, particularly the sicker disc. It's denying the disc the added benefit of that physical squash and suck effect to get nutrients in, to get health-giving nutrients in to help some repair processes happen. So this proteoglycans stuff, it's complex, but it's critical, and that's in the center of the nucleus. It's manufactured in the mid-annulus, which bears the greatest load after the nucleus. But there's another reason why it's very important to move a lot when you've got a bad back or when you've got a healthy back even, because proteoglycans synthesis is stimulated by pressure changes. And the more you bend over and the more you stretch up, you've got a steep pressure changes, and they are highly stimulatory on the production, on the synthesis, on the ongoing synthesis of health-giving proteoglycans. And proteoglycans' greatest production range is at 2.5 megapascals. Now that's quite a lot, and that's something for you to bear in mind when you're rehabilitating your patients, which if you come to my masterclasses, you see it's why I like you to get your patients lifting as well as bending, because lifting a 20-kilo weight invokes in your discs 2.5 megapascals of pressure, highly stimulatory, highly healing. Another reason why it's so important to have movement as part of your therapy. So let's get to the first of what happens when things go wrong. My stage 1, stiff spinal segment. I believe this is the fundamental pathology or neopathology, because it's actually not that, it's not pathological, it's pre-pathological. By the time you get to the end of the range of stiff spinal segment, yes, it's a degenerative disc, but we hope nothing ever gets that far, because we know with 90% of our cases of low back pain, they can't find the cause, that it really is just something that's not working properly. They've given that this, the powers that be, the wisdom has labelled this either simple back pain, the name incidentally of one of my websites, non-specific back pain is another name for it, or back pain of unknown etiology, meaning that we don't know what's wrong. Well, I think this is what's wrong. Here we go. So we know we've got this precarious disc nutrition. It's quite a long way to get 8 millimeters to get nutrients into the heart of that disc, either from the periphery, the annulus at the side, or the end plates, the upper and lower end plates. Equal nutrients come in equal measure. What's this? Can you not hear me there? Is the video not working?
Yes, yes.
It is working?
Yes, yes.
So I just keep going. Okay, good. Sorry about that, folks. I'm glad I can see myself on video.
Yes.
So precarious disc nutrition, or a critical issue because it's such a big avascular, but it's about the largest one can get to a bloodless structure remaining viable, but also one of the reasons that a disc does wear out so quickly. And one of the forefathers, if you like, of the theory that disc nutrition was really a contributing factor in degeneration was the Scandinavian Alf Nackhamson. Way back in 1970, he was saying that deficiency of nutrient supply is a contributing factor to disc degeneration. So my premise as a treating physiotherapist, which I'm trying to imbue you with, is my premise is that what you need to do to help fix back pain is to help get the discs nourished. And the way to do that is to improve the fluid flow to and from, in and out of the discs. Another leading researcher, Jill Urban, a British researcher, discs degenerate much earlier in life than other tissues, and this is again because of this precarious nutritional supply, no blood supply, relying a lot on movement. Here we go. So I believe there are these 4 factors that really precipitate discs breaking down: sustained loading, fear of movement, churlish gatekeeper, which I'll get to, and then subsequent injury. So let's go through those. Before I get to that, let me just say this, that even without any of those factors, even without the fact that you sustained loading and the churlish gatekeeper, etc., discs also just have normal age changes. Over time, the proteoglycans fragments, which means it can't hold its water as well. You get type 1 collagen concentration increasing, especially in the nucleus, and just the normal metabolic activity of discs starts to wane. So here we've got this beautiful, juicy, young, there's a lot of water in the nucleus, and here by the 30s and 40s it's starting to dry out. You can see much less water in the nucleus there. Wonderful photos of Professor Mike Adams from Bristol University. But when we start to get to sustained loading, now there's an awful lot of sustained loading in our Western lifestyles. There's an awful lot of sitting. There's a lot of bending over at the kitchen, cutting up things at the bench. Even unsupported sitting isn't great. Slumped sitting loads the discs even more for reasons that I talked about earlier, when you have a greater kyphosis than a dual lordosis. Just sitting forward on your seat and sitting slumped in a C-bend increases that loading of those discs by 50%. So you're throttling down the metabolic activity of the discs just by not letting them breathe, literally not letting those disc cells in the discs breathe. It's not much better when you sit bolt upright with no support at the back, because the muscles are working so hard that they too compress. And also we know, incidentally I should say, we know that in the first 2 hours of sitting, we lose 10% of our discal fluid. So we lose 20% through the course of a day. But with sitting, we lose 10% in 2 hours. So that's one of the reasons you always say to your patients, always stand up within 2 hours, walk around, touch your toes. One of the things that I love patients to do is to touch their toes, pulls water in. It gives the discs a drink by pulling the water in, but it also G's them up metabolically. It stops them getting, it gives them a breath of fresh air and metabolically keeps them moving. This lovely bit of research by Mark Adams, slumped sitting, you can see here, lordotic postures in extension, and flexed postures in kyphosis. You can see 10 times the fluid loss within the first 4 hours of sitting from the nucleus, less than that from the annulus. So sitting slumped like this is so critical. In my masterclasses, I have a big lecture on sitting and how you have to keep the lordosis with sitting. You have to keep that beautiful serpentine S bend, not a C bend. You want the S bend, because that stops you overloading the discs. So discs degenerate from the inside out. Now this is critical. A fall in nutrient supply reduces the number of viable cells and leads to degeneration. The nucleus degenerates first because it's further away from the nutrients, and it's hard to get the nutrients all the way in. And if you're not moving enough either, it's hard to push out all those metabolic waste products. And then you get the rising acidity of the discs, and that too chokes down the metabolic activity. So all the repair processes just stop happening as effectively. But even though the nucleus degenerates first, so that in effect the disc degenerates or breaks down from the inside out, I have this ongoing discussion with Mark Adams, the actual dysfunction goes from the outside in. The outer annulus loses compliance. So instead of the outer annulus being this lovely, stretchy outer wall, this mesh that stretches up when you bend, it becomes clamped down. And that means that you can't pull away. When you go to bend over, you feel stiff. And that creates what I call a churlish gatekeeper. It's not opening and closing properly, that back wall of that disc when you're bending. So you're not creating this suck, what we call suck imbibition, and hardly opening at all. Churlish gatekeeper, look up the word churlish, it's a great English word. And that means that the dysfunction is from the outside, not letting the disc suck and squirt properly. So instead of having this really steep pressure gradient of low pressure, high pressure, when you can hardly open the disc, it's hardly anything. Low pressure, just slightly lower than, just slightly higher than low pressure. So you've got this low pressure gradient instead of a lovely steep one, which is so stimulatory. Here we go, next slide. So what happens is that with what happens as discs degenerate, remember that one of the important things to say is that one of the first signs of the disc losing water or degenerating is that the disc loses water, disc dehydrates, the nucleus goes down like the sun going down over the horizon. This means, and this is critically important for your understanding of this stage 1 of my 5 stages, the first sign of a disc degenerating is this transfer of load from this lovely ball bearing, this squashy ball at the center of the nucleus, out to the annulus. Because, as I say, the ball shrinks. So the nucleus can shrink by 50%, and then all the load is taken by the annulus, this mesh wall at the side, both sides. And that, as the nucleus becomes 50% smaller, the annulus runkles and bunches down and becomes 80% thicker. So it's much more stiff, you can't pull it apart, but it also much thicker, what we call diffusion pathway. You can't get the nutrients through it. So this decrease in this stretchy compliant outer annulus and these reduced pressure changes, and you get the starvation of the nucleus. It's a beautiful process that's for you to understand. I hope you can. It's critical to your understanding it. So just what am I saying here? So great team of German researchers say it this way. All the papers that I'm quoting from, by the way, are here at the bottom of the page, and I have a reference reading list that you can download. Goering et al. Say it this way. Compression leads to moderate disc degeneration by affecting the active pumping mechanisms of nutrients into the discs. So you have a little mingy pump, hardly anything when a disc is really stiff. And that, I believe, is it's stiff because the outer annulus is shrunk, and the outer annulus doesn't want to stretch because it's like a ligament that's shrunk. And I think that is the cause of your non-specific back pain. I think that is the cause of so many back pains. So much, 90%, remember, are non-specific back pain. And then once you've got this stiff link, this shrunken outer annulus at one level, it's really easy to keep on hurting it. And this is why back pain can become so ever-present and recurring. And, you're okay for 12 months and then you have another terrible period and you don't know what you've done. But the trouble is that if you've got this lovely fluid spine moving, but you've got one stiff link in the middle of it, it's like a slab of concrete in the middle of a suspension bridge, and you keep on, that's a target for further trauma. The annulus, Bogduk says this in another good paper, the lumbar disc and low back pain, the annulus may be injured and become symptomatic as a ligamentous injury. It's a really simple notion. It was first of all put out by Bogduk years ago. It hasn't been taken up enough by the physiotherapy profession. I've taken up the cudgels, and here we go. I talk about it in my masterclasses. So you get this stiff spinal segment, and we physios feel these all the time. Even masseurs can feel them all the time. We've got the patient laid out in front of us, their spine, they're prone on the treatment table, and you're playing back and forth along their spine like playing a piano. And you feel the stiff link and it hurts. And I use that expression, it feels like a plug of cement in a rubber hose. You can feel it. So often physios don't know why it's stiff. They just think, oh, well, it's just got stiff. This, I tell you, is why it's got stiff. And when you find that, when you feel that stiff link, the patient says, oh, yes, that's it, that's sore. It feels as if the bone itself is bruised, and the patient will corroborate by feeling that bruised sensation. The patient feels what you feel when you feel that. It's literally, another analogy to use is it's like a key, a piano key on a keyboard that won't go down properly. All the rest of them do, not the stiff one. And that stiff one is sore, and that soreness is like a bruised bone. And it's simply stiff. There it is there. And there's no better way for it to be picked up when MRIs show nothing, when X-rays show nothing, when blood tests show nothing, when all the movements are normal, they don't show anything either. Yet human hands can feel it. As I say, even unqualified people could feel it, and physios should be really taking that role back. So I hope you can see that. I'm actually, can I move that? Yeah. Yeah, much better. Is non-specific back pain simply a stiff spinal segment? Well, yes, I think it is. Again, non-specific back pain or back pain of unknown etiology. So many cases, 80 to 90% are phenomenal, really, that this is what it is. Now, a very rare end stage of a stiff spinal segment is this total disruption of, so instead of this, you know, I should say, as this dehydrates and dehydrates, if you're plain unlucky, then you can go right to the end of the line of stage 1, where you develop what I call degenerative disc disease. Now, that's a very sick disc indeed. You do not see that very often at all. You can see here that the end plate has many disruptions in it. There are clefts in the nucleus. You can hardly see the nucleus. You can see that there are clefts here. You can see that blood has gone into the disc, that it's been totally squashed, the lamellae are being forced down here. That would be a very painful disc. And Professor Mike Adams describes this as the nerves growing along these. Wherever there's blood, nerves will grow. And that's a very painful disc indeed. And that is one of the few instances, incidentally, where I believe that disc resection is indicated. Now, again, you'll know, if you know anything about my work, that I'm very anti-surgery, but that is a back that really can't be fixed by conservative means, by physiotherapy. So let's get rid of that. Here we go. So we do not want you developing that awful degenerative disc disease with those clefts and those nerves going in. Mike Adams describes it as nerves going in looking for trouble, as I just said. But the good news is that there's been some lovely work done and on healing of the outer annulus. The outer annulus here, this bloody bit, is just like any other ligament. It does have a nerve supply. It does have a blood supply, much more important. And where there's a blood supply, healing can happen. A third of the annulus is sealed over. Some work done on young sheep where they caused injuries with a stab wound, and then scar tissue. It didn't happen quickly, but the mid-annulus here never bridged. No blood there, nothing happens. But it doesn't matter, because unless you've got this disruption, which I showed you earlier, most degenerated discs you don't. If this never heals, so let's go to second stage, stage 2, facet joint arthropathy. Much less common than the stiff spinal segment, but nevertheless the second most common cause of back pain. And that's because as the fluid flows out of the disc, and the load is transferred to nucleus and annulus, the disc thins here. And not only does that bunch down and make that wall much more fibrotic, I often describe it as like a jumper that you washed in a washing machine with the water too hot, and instead of it being lovely and stretchy, it's sort of crinkly and you can't pull it apart. That's exactly what the wall gets like, and that's, as we saw, phase 1, stage 1, stiff spinal segment. But what also happens when the disc thins is that you get overriding here of the facets. The facets are taking load at the side. The disc's the pillow in the center, 2 facets at the side. They are not meant to take load much at all, only 16%, as you already know. And because they're wired for pain, they've got such a sophisticated nerve supply, they let you know immediately. you know about it. That gives you pain out to the side. So movement controllers, they complain madly when they have to bear weight. They should only take 16% of load when you're in standing. So what happens then is because they're so vascular, remember I told you they're a great blood supply as well as their nerve supply. They really are wired for pain. As soon as they're unhappy, and they would be because they're shouldering load and they're not meant to, their load can be increased by up to 70% when you've got this marked discing. If you've got a disc that's meant to be this high and it's this high, then the facets take load and they don't like it. They're not meant to. They're movement controllers. And here are, so this is a cadaveric, again, courtesy of Professor Mike Adams, my colleague, letting me use these slides, all his lovely work. So this is a healthy facet joint, getting less healthy, getting even less healthy, more bloody. And you can see here really end stage, lumpy, red. You can see hardly any cartilage there, worn out, very painful. Even so, it's easy to mobilize it, and I show you how to do that in my masterclasses. I'm not showing you in these lectures. I'm not showing you any anyway. So what happens when you got you got to remember that facet joints have very big capsules. They're very baggy. They're very vascular. They like the shoulder capsule, for example. If that capsule is very inflamed, then it weeps. And one of the legacies of that oozing of sort of edematous fluid is that over time you develop adhesions and scar tissue. Now that's much more common than you might think in backs, where there's been inflammation of facet joints over a period of time, and then you repeat traumatized because it's called claggy and not elastic enough, and you can hurt it when you stretch. You get more adhesions on the old adhesions. That embeds the spinal nerve, which is coming out. Here it is, equidistant disc on one side, facet on the other, big baggy capsule of the facet joint here. But then the nerve literally gets choked, embedded in this scar tissue. And you can see it at operation. You don't want to see it really. It's a horrible, looks like cobwebs, horrible. And you can see the nerve is often really shrunken and very painful, embedded in the capsule on the disc wall. Difficult to treat. I'm not a great fan of flossing and nerve stretching techniques because nerves hate it. And it takes weeks for the back to settle down after you do that sort of treatment. So much better to mobilize, to try and get pressure in, mobilizing pressures in on that scar tissue to get that scar tissue to reabsorb. Very, very important. Most sciatica is referred pain from the facet joint. And how common is sciatica? How common? Again, it's not as common as non-specific back pain, the stiff spinal segment, but referred pain down the leg from the facet joint is extremely common. And sciatica is rarely from intervertebral disc prolapse, which we get to, the slip disc, really very uncommon, which we get to in a moment. Now we're going to talk about acute locked back, because as a sequel to the stiff spinal segment, this condition can usher itself in, and I'll explain why. Here we go. So we've got this stretch reflex in your interspinous ligament here, apart from others. But what happens usually when you have an acute locking episode, your back has been, it's usually after you've done some exertion a couple of days before, you've been laying pavers or painting the ceiling or had a long car trip or sat in a theatre seat, which is really uncomfortable. And then the back is stiff. Erector spinae, the long cable muscles switch on. They become overactive because you're holding your back rigidly. You're not bending properly. And that means that by not bending, you are not eliciting this stretch reflex, which is embedded in your interspinous ligament. And that does not switch on your multifidus, which are the sort of facet joint protectors, if you like. Multifidus fibers insert into the capsule of the facet joints. So multifidus stops you doing anything wrong to your facet joints, if you like. Here is a diagram again from my book. This is what multifidus looks like. It's like thatches. It goes from every like thatches on a roof. holding each segment to the next but one vertebra. So they pay out. They're the ones that control bending and control straightening, especially, only if you unfurl in an undulating way. If you unfurl like flipping, you're using a rectus spinae, you're not recruiting multifidus. But in the presence of low back pain, really good research done by Julie Hydes and another Australian researcher some time ago now, good little study that showed that in the presence of low back pain, there was often multifidus remained underactive. And when multifidus remains underactive, your facet joints aren't as well protected opening and closing. Remember, multifidus controls the opening when you're going down and then hauls you back cog by cog, each one level at a time as you come up. If multifidus is switched on, things move around a bit. So the stiff spinal segment can predispose you to an acute locking, or you can have a virginal acute locking if you're getting around with a rigid back because you've been painting the ceiling, as I said before. Another way you can suffer an acute lock back is if you're unfit for any reason, or you're put on a bit of weight, or you've been in bed for a couple of days with the flu, your tummy tone lets down, and if you just don't brace properly, and you wouldn't believe the number of times I've had patients over the years, bear in mind I've been in practice for 40 years, you wouldn't believe the number of times when somebody said, look, it was one of the reasons this condition is so dumbfounding to patients is that they say, well, you know, it wasn't as if I was lifting a bag of cement. I reached to get a coffee cup. It's usually a very unloaded movement in that, what I call the window of weakness in my masterclasses, where the spine isn't braced properly. You haven't prepared yourself by switching your tummy on properly because it's such a tiny movement. And then I think you suffer this acute locking. We don't really know what the locking is. We don't know if it's a trapped meniscoid inclusion or a trapped fat pad. Whatever it is, it's a crisis of coordination. And it's a crisis beyond words, where there's this massive gust of this sort of global clench of muscles that literally takes your breath away. Patients say that they're nearly sent to the floor, their knees buckle, and then thereafter their body sets in stone. They really can't move. They can be in agony. They can't move a toe, and they can often have to be taken to the emergency department by ambulance. You can hear patients 20 years later can describe that crisis in minute detail. I think it happens because multifidus has remained switched off for whatever reason. And if it's left unresolved, then you find you've got a chronic arthropathy because it amounts to trauma. It's like a little injury of that facet joint when you get this minute subluxation, and you've got to deal with you've got to mobilize that facet to get rid of that and to make it fully compliant again, because again, like the disc wall, you're needing to restore compliance. You also have to restore compliance of that facet capsule. Stage 4, prolapsed intervertebral disc. Really important to talk about this because it may follow from a stiff spinal segment, but Nick Bogduk says that disc prolapse is but one possible end stage of internal disc disruption that represents the culmination of a series of destructive processes. Again, he's the scientist, I'm the clinician, but we're saying we're concurring with each other. Disc prolapse just doesn't happen because it feels like it. It happens because that first stage has predisposed other things going wrong in that segment. Now, in the case of disc prolapse, it's because the wall's been loaded up. Now, I'll get to that in a minute, but there's a massive amount of confusion about this business of a slip disc, a PID. Again, not a slip disc itself is a very misleading expression because patients over the years, I can't tell you the number of times patients come in and they say, oh, well, you know, once a year I slip a disc and the chiropractor has to put it back in again. And, you know, this notion that it's like a sort of saucer slipping out from a stack of saucers, it's most misleading. It's not what happens at all. There's nothing as strong and bonding as that outer layer, that ligamentous layer of your annulus fibrosis, binding bone to bone, highly elastic, highly tensile. That's the bit that's sensitized, of course. It doesn't let anything slip anywhere. In fact, they've done fantastic studies on pulling spines apart and squashing them, and the bones break before that outer annulus will let go. Nothing slips anywhere. But there's so much confusion. There's confusion within the profession. Confusion is rife. You know, what's a herniation, what's a prolapse, what's a protrusion, what's an extrusion, what's a bulge. Sequestration and fenestration are a bit easier. Mike Adams talks about protrusion and extrusion, but, you know, we clinicians know that there's a very, very lazy, jumbled, non-consistent use of all those terms. We really need to understand it ourselves before our patients can. So true disc prolapse is extremely rare. I see patients with bad backs all day, every day, have for decades. I think I would see 1 or 2 cases a year. Nikolai Bogduk says, epidemiologically, disc prolapse accounts for fewer than 5% of cases of low back pain. I probably do see more chronic unfixable backs than I see the acute backs, so that figure may be slightly higher in emergency departments and outpatients around the world. But they're vastly overdiagnosed and much less common than you would think. So I really want you to change your mindset on that, because true slip disc is actually quite hard to treat. You can't do much yourself as a physio at all. But then again, most cases are not true slip disc. Nikolai Bogduk says, I mean, you know, this is again the MRI reports you get, the radiology reports talking about disc bulges. I'm not the slightest bit interested in disc bulges. Not the slightest bit interested in disc bulges. The only thing I'm really interested in MRI is how thick the disc is, because I know if it's thick, if it's thin, I should say, it's dehydrated, it's lacking pressure, it's loading up the wall, that multifidus will be switched off. I couldn't care less if it's bulging, because all discs bulge more at the end of the day. And as Nick Bogduk said, discs are meant to bulge, they're shock absorbers. This is him, he and I talking on the phone. But anyway, discs lose 20% of their water through the course of the day. All discs bulge at the end of the day. It's like a car tire. If you don't blow it up enough and have enough air, then the car tire, how are we going for time here? How are we going? Are we all right here? So MRIs frequently confuse us with these false positives. There's been lots of studies done about MRIs with asymptomatic individuals, but they do have disc bulges on X-ray, on MRI. Again, protrusions with people may be frequently coincidental. Some disc prolapses are associated with low back pain, but the majority are not. Important you know that. But when the disc dehydrates, as I said before, you get these stress concentrations in the annulus. Here it is fully hydrated, before creep, after, and you see that the front and back walls taking a lot of load. And when that happens, the disc wall cracks up and fissures appear. But the nucleus has to be rendered expressible, because the proteoglycans is holding the nucleus at the center. Now, if the proteoglycans concentration is high enough, then you won't get any squidging out of that nuclear material, because the osmotic pressure is too high. But if there's degeneration there, and if the proteoglycans concentration starts to reduce, and that's one of the first signs of degeneration, then it can get out, and you've made these cracks in your wall because you're loading up the wall by the transfer of load from nucleus to annulus. Also, you can get the lamellae separating in these sort of bucket handle separations here. That will be painless though. Here, you only get pain when that outer disc wall becomes stretched, because remember, that's the sensitive bit. Here it is again, all through here. It doesn't matter how many cracks there are, how wide they are. It's only when there's a stretch here do you get pain. Only painful when it stretches the nerve as well, and it can do that. It can be tightly stretched around what I call a focal bulge, again, very rare. One of the best things that can happen is if it fenestrates. So it actually, fenestrate means out the window, when the nucleus actually bursts out, because that relieves the tension on that bulge, on that sensitive part of the wall, and your back pain disappears. You might get much increased leg pain because you've got this toxic nuclear material irritating the spinal nerve. So final stage, the unstable segment. Now, this is really very important. We did go through a stage when instability was sort of diagnosed willy-nilly. It's really very, very uncommon. And Nick Bogduk says in his book, it's perhaps lamentable that for such an entity that's attracted so much attention, there's so little valid reason for diagnosing it. People just sort of willy-nilly pick it out of the air. You'll see from our masterclasses that instability is very, very detectable. There are very, very obvious signs. The patient can't bend properly. They fold up like a broken reed. But it's also very difficult to palpate manually. It's really on the clinical picture of the patient unable to bend. So this is really the core to this hypothesis of mine, that the main features of stages 1 to 4, so stiff spinal segment, facet arthropathy, acute lockback, prolapsed intervertebral disc, all of the features that are the hallmarks of those stages predisposed to instability. Go back there. Predisposed to instability. So, sorry. So with the stiff spinal segment, you've got reduced, that's dehydration. So it reduces the disc pressure. It reduces the disc height. You get inhibition of and a multifidus. You also get inhibition or delay in transversus abdominis when you've got a stiff spinal segment. That reduction in disc height, remember, predisposes you to loading up the facets, and the facets then knock around because they're not burst. They're taking more than their 16% of load. They can take up to 70% more load. That predisposes you to, also you get delay in multifidus, unable to control the segment. So instead of the segment tipping when you bend, critically what happens with instability is that you get shear as the spine bends over and goes forward. The spinal segment, instead of tipping, just slips forward, which is agony, and the patient folds up. So, and then, but PID is when the wall breaks down, and because you're taking too much load. So all of those things in combination render that segment unstable. Weak wall, delayed multifidus, weak intradiscal pressure, dehydration, all mean that the segment, now usually you've got stability of your segment because you just sit down on the wall and that makes it stiff, and the stiffness is your safety, but every now and again you break through that. And instability is very common with people like weightlifters, people that lift weights in gyms because they lift so badly and they lift with an arched back. Again, lifting is a very important part of my masterclasses. Main way of controlling shear is by active spinal compression through the muscles. And the main way to do this is to recruit multifidus. So you have to re-educate multifidus. And not that we're going into treatment of, but it's a good starting place to know this. The main way to recruit multifidus in a day-to-day way is bending over normally and then unfurling back to vertical. You can do that off a Roman chair. You'll see in my masterclasses I have stages 1 to 4 because if somebody's unstable, their back doesn't get better easily. Remember that, but instability, as common as a stiff segment is, a loose segment is uncommon. And this is the thing, is massive amount of stiff segments, very few come through to the final stage of instability. Although a stiff segment at the top is common, it's very easily treated. I'll talk about that tomorrow in a lecture. By the time you get to instability, there are fewer of them, but they're much harder to get better. It's a much longer process to get them better. And stage 6 is ankylosis. Well, I haven't written stage 6, but one of my scientific advisors said, you know, Sarah, you really should write about stage 6. So maybe I will, but not yet. So how are we going there? What can be done tomorrow? We talk about what the way to treat it when it's in that 90% of cases. And there we are. So this is just an excerpt from a back care proposal at Bristol University for a grant. If you just like to read this, you can see Mark Adams and my name there. Intervertebral disc degeneration progresses from the nucleus outwards and is often asymptomatic. Discogenic back pain, however, originates in the disc periphery. where the nerves are often present and mechanical loading is high. Therefore, we believe that treatment should aim to promote healing of the annulus. And there we are. We'll be doing that tomorrow.
Yeah, doctor.
So,
excuse me, doctor. We have more 10 minutes.
okay. Well, I'm finished now. If there's any questions, that's the final slide.
Okay, it's fine.
Don't know if there are any questions. Otherwise, we'll have the second lecture tomorrow. What do you think?
Yes, we will let you know after end of this today.
Yeah, sure. Okay. Now, did you record that?
Yes.
Okay. All right.
Any questions to Dr. Sarake? Any questions?
Don't be shy.
Any questions?
A lot of stuff there. There is a downloadable handouts of that slide, 3 slides per page that you can that I'm sure you can take delivery of. And as I said earlier, there's a reference reading list of all my
doctor,
references.
You have got a question from number 370. Thanks a lot. I have a question. Please carry on your question.
Maybe you should type it in.
Hello.
Hello.
Yeah, hello. I can talk.
Hello.
Yes,
I can hear you.
Yeah. I want to ask which type or in which stage, like you would say, it will need more surgical intervention than BT intervention.
Good point. Surgery. I'm not a great fan of surgery at all, because the results are so poor. You know, after several years, the results are 50-50. I think you're very lucky to get you get away with that. The indications for surgery are really either for instability, where the patient can't bend, and that's and very rarely do I recommend instability if I can't if I can't control the instability by doing graduated intrinsic exercises, re-educating the strength of multifidus, or if by doing those exercises I'm stirring the patient up too much and causing too much pain. Sorry, that's fit. So I only recommend surgery for 3 cases, 3 types of conditions. 1 is instability. 2 is insoluble degenerative disc disease, where you saw the clefts and the blood going in and the nerves growing in looking for trouble. That's a very painful disc, and you probably have to use an artificial disc in there, which we know the results aren't great for that, but you do need a sort of spacer mechanism so that you're not loading up the facets. You just can't whip the disc out and leave nothing. Again, and the only other indication is for true disc prolapse, where you've got loss of reflexes, loss of bladder control in the leg, and drop foot, and it's not getting better. So you would certainly do some physio, and you'd be mobilizing, using your hands, mobilizing the level, because a little bit of mobilizing does work. You would also be getting the patient with that true slip disc or true PID to do his or her own spinal decompression at home, and we'll be going through that tomorrow by using a back block, where people actually do their own traction, basically pulling the spine apart, because that actually sucks fluid into the disc, and it helps take the pressure. It helps take the bulge away. When you can bring more fluid into the disc, you get rid of a bulge. This is important. I know this is the opposite to what you've been thinking. So those are the indications: loss of reflexes and loss of bladder control for a true slip disc, loss of muscle power in the legs, absolutely insoluble low back pain from a degenerative disc, where you've got the nerves growing in looking for trouble, and that has to be diagnosed also by MRI. and in cases of incurable instability. And I had one patient last year who I did want to be fused, and I have recommended fusion for my cases of instability. I would do about once every 5 years. I hope that answers your question.
Thank you. Thank you so much.
Any other questions?
Any other questions?
Thank you. No more question from my side.
Any other questions from participants? Thank you very much, madam. Thank you very much for speaking up. Yeah, thank you very much for speaking in this meeting and providing a unique perspective. Thanks for
that's been great.
Yeah, thanks for sharing your tips with us. Looking forward to looking forward to meet you again next time.
Okay, thank you.
Yes. So now we asked Dr. Lindley Leothard from New Zealand hands-on group, as well as Dr. Alan Gary Aston from Mignon, Ontario of Canada, to join the event and start presentation.
I can't just see how to get my video working. Can you just tell me how to get the screen working?
Just you can upload your video.
No, it's a screen, so you can't see me.
Just you can go to screen share and yeah.
Okay.
Yes.
All right. Thank you very much. Sarah, it was great to hear you speak. Really interesting to hear what you had to say. I have heard of you for about 10 years. Sorry.
Yes, you can just start your video. It's comfortable.
I can't see where to do that. No, it's not happening.
Okay, no problem. You can continue your talk.
Bottom left?
Yes, you can continue your talk.
Bottom left there, Lindley.
Bottom left. Oh, left.
Yeah.
I can't see anything to click on the bottom left.
Just hover your mouse around it. It might work.
You mean right at the bottom of my screen?
Yes.
Oh, I see where I can do it.
Yes, it's fine.
Right up the top. Okay, thanks, Sarah. It's wonderful. Anyway, as I say, it was great listening, really exciting listening to what you have to say, and interesting what you were talking about with multifidus, because with Trigenics, we've got a way of actually switching that on very, very quickly, neurologically. So thank you for that and really appreciate your wisdom. Okay. So, hello everyone, my name is Lindley Leothard. I'm a New Zealand and Australian registered physiotherapist, and I'm also a registered manual osteopathic practitioner. I lecture in Trigenics, in kinesiotaping, acupuncture and natural facial enhancement. And it is my great pleasure and privilege to be able to introduce Dr. Alan Gary Aston, Olo, the developer of Trigenics functional, muscle neurology and myoneural medicine. Our workshop is focused on shoulder muscle imbalances assessment and the treatment utilizing Trigenics neurosame protocols. So it's quite a mouthful. Okay. Trigenics is a multimodal neurological treatment system that resets the way the brain communicates with the body. It increases mobility, increases strength, and reduces pain measurably and immediately. It also accelerates healing. The concept was clearly described in the book Assessment and Treatment of Muscle Imbalance by Dr. The Yanda approach by the three eminent physiotherapists, Phil Page, Claire Frank, and Robert Laudner. They stated that most shoulder conditions are due to functional imbalance in the pulley mechanism and the movement planes of the shoulder joint. And where we tended as physiotherapists to use strengthening exercises, except eccentric loading, etc., we've found that the muscle's never as strong as the contralateral side. But when we reset the brain communication, then we get the desired changes and the results. The nervous system controls the motor response and the resting tone or the gamma bias of the muscle, which in turn controls or restricts movement. Research indicates the musculoskeletal injury or the dysfunction affects the afferent input on the segmental and the suprasegmental level by altering the function of the nociceptors and the mechanoreceptors found within the joint and the related tissues. And the musculoskeletal stress or dysfunction leads to dysafferentation, which is an imbalance of the afferent input with an increase of the nociceptor input and a concomitant decrease in the mechanoreceptor input. Dysafferentation causes functional, muscle strength and reflexly contracted muscle imbalances. Dysafferentation leads to inappropriate signals to the lower brain, which in turn responds with inappropriate efferent motor control signals, which leads to excessive or deficient signal patterns, either of shortening, hyperfacilitation, or weakening, inhibition, with a resultant neurokinetic malfunction and excessive stress in the overloaded areas as dysafferentation. So the majority of shoulder conditions are thought to be caused by functional imbalance. The shoulder tendonitis is almost always secondary to persistent imbalances with the muscular strength and length, and the sensory motor imbalances must be corrected. For healing and recovery to occur, these imbalances have to be corrected to remove the excessive stress on the affected holding and moving elements. So Trigenics provides the solution by first correcting the aberrant proprioceptive neurology for a relative reafferentation effect. As I've said, Trigenics is a sensory motor restoration system. The myoneural procedures change or correct the dysafferentation through reafferentation. And this is achieved through the Trigenics myoneural protocols. The changes in the afferent input lead to changes in the efferent output. Restoration and optimization of efferent communication is the ultimate goal of Trigenics procedures. The neurosummative effect of the three procedures, or the three sensory motor techniques, is far greater than if just one is used. So what we want to do now is look at how Trigenics actually works, which Dr. Orlo will discuss.
Unmute. There we go. Sorry, I had mute on. So, hello everyone. And Sarah, I want to say to you, compliment you on the fantastic lecture that you gave. It was captivating. It was wonderful. It was a review for me of many things, but also some new information that was really, really useful. Thank you very much for that. It was a really great lecture. You're fantastic. So how does Trigenics work? Trigenics really combines three treatment techniques that are applied simultaneously for a synergistic effect on the nervous system that's much greater than if you simply apply one. It's Hegel's dialect basically, and it's you know, three is greater than one. The three components that we apply simultaneously to essentially bombard the lower brain with afferent information that it would not normally be receiving are what we refer to as PDM, or proprioceptive distortional myoneural manipulation. We do that either with our hands in a specific protocol that we use to distort the mechanoreceptors. There's actually a lot of research behind this that we quote in the Trigenics theory book, which we can't get into here, but mechanoreceptors are affected by distortion, obviously, of the strength and length relationship that changes, and they're monitoring that constantly. We can actually change that by not only employing certain reflexes like reflexive reflex neurology, where the patient is contracting against resistance, and at the same time a load is being applied to the mechanoreceptors externally, but we can also facilitate it using a third component, which we refer to as autogenic or biofeedback breathing. So we combine these three components, the PDM or proprioceptive distortional manipulation, with the resisted reflex neurology, where the patients are moving against resistance with certain amount of pressure for each different protocol that we have. And then we also simulate the autogenic component or the parasympathetic nervous system on a systemic level using the biofeedback breathing. Okay, next slide. It's a little bit easier when we actually show it, I think, if we talk about it. So the three components are what I've just spoken about: neurogenics, autogenics, and myogenics. One is approaching from the muscular perspective, and the other one is from the neurological perspective, and the other one is from the autogenic or systemic breathing perspective. And the next one. So trigenics is also used quite effectively in pain injury management, because the change, as Lindley was talking about with respect to the nociceptors being really a type 3 mechanoreceptor, is quite instantaneous, because trigenics is consistent with the principles of neuroplasticity and cortical neural reorganization of the somatosensory and sensory motor system. So the change, with it being neuroplastic, is very, very instantaneous. And the change with respect to pain, when we increase or decrease the nociceptive input, increase the mechanoreceptor input, when we change when we overload the nociceptors, almost the gating theory, I guess you would refer to it to some degree, when we overload those and the nociceptors, we decrease the nociceptive input by overloading the mechanoreceptors, essentially, and that's how we are able to make very, very significant and very quick changes with respect to the patient's pain perception. Okay, next slide. With trigenics, one of the things that really sets it apart is that trigenics are not passive recipients, and they're not just active participants, but in fact they're active, interactive participants in the treatment. The patient actually interactively participates with the therapist while the treatment's being applied to generate specific reflexes that we want to generate, and they also help from an autogenic level with a breathing biofeedback and visualization. So the patients are moving and actually exercising during the treatment as the treatment is being applied to the target area, and they're also focusing on the outcome of the treatment as well. We're directing the patients to interactively participate, and we have to actually teach the patients how to interactively participate in the treatment. But with interactive participation, we're really drawing upon a higher level of neurological input, and it really makes a significant change in the results of the treatment when the patients are included with interactive participation. So they're not passive recipients, and there's a learning process that takes place where we actually have to teach the patients how to participate in the treatment. Next one. So the fascia is a big sort of key word these days, and as we all know, fascia is a dynamic and densely innervated tissue that can contract and contribute greatly to proprioceptive input. So, just passive stretching of myofascial structures doesn't really stimulate mechanoreceptors like the GTO, but with trigenics lengthening procedures, for instance, the GTO stimulation would occur on an augmented level, because we're actually also stimulating the GTOs externally with the PDM. And when the muscles are actively contracting and we're applying an additional load that makes the brain really think that there's more of a load than actually really is happening, then we get that afferent bombardment. And so we can also affect the fascia this way, because fascia is, a dynamic muscular loading pattern in which the muscle is sort of briefly activated in its lengthening position, causes the most comprehensive stimulation of fascial tissues as well. So that's important to note, I think. And as we, again, talking about increasing proprioception, we decrease pain simultaneously. Next. So we won't, I mean, everybody knows this already, but we generally use reciprocal inhibition, the reciprocal inhibition reflex in the TS procedure. I'll teach a lot more detail about this in the actual courses that we teach. We don't have time to get into the neurology of it right now, but we do teach all of that in the course. But this is sort of a quick synopsis of it, that there are specific reflexes that we engage during the procedures. For the strengthening procedure, the TS procedure in trigenics, which causes an instantaneous change in strength ability or functional strength ability of the muscle that's inhibited and weak, we incorporate using the reciprocal inhibition reflex. We start the muscle in a shortened position, and then we engage the antagonistic muscle, and then we have the patient apply a minimal amount of resistance, maybe 10 to 20% of resistance. If we apply too much resistance, we get co-contraction, which we don't want. And so that is the way that we initiate the TS procedure. And then we apply the PDM as well as the autogenic breathing to get the three components in there. Next one. The trigenics lengthening procedure is exactly the opposite of that. If you're thinking about it from a physiotherapy perspective, you'd almost think of it as enhanced PNF. You could call it enhanced PNF. You get an increase in the PNF effect, really. You are applying PNF with PDM and autogenic breathing, essentially, is what we're doing. So we contract the muscle, as I was talking about just a minute ago, we contract the muscle maybe at least 80% of its maximum contraction ability. Then we apply an external force from outside the muscle in a way to maximally distort and further the GTOs and the mechanoreceptors. And then we start the procedure, of course, in the lengthened position, which is opposite to the TS. So everything is kind of in a state of balance, and we start our TS procedure in exactly the opposite way that we do the TL. With the TS, the target muscle is the antagonist, and which is being reciprocally inhibited. And with TL, the target muscle is the actual muscle that's contracting, the agonist. And with the TS, we use maybe a very light resistance, 10 to 20%. With the TL, we use a heavy resistance, about 80%. And so everything is working in this kind of harmony in the body. And we just facilitate that harmony and get the muscles to normalize with respect to their function and with respect to their gamma gain, or gamma bias. Really, even the resting gamma bias has changed significantly when we employ these techniques. The strengthening procedure to muscles that are functionally weak, found to be functionally weak after specific strength testing protocols are made and assessment protocols, and the lengthening procedure with muscles that are found to be functionally contracted or functionally short. And that's kind of the basics of how trigenics works in 5 minutes without being able to try to go into it in great detail. Next. This was just an internal study that we did, which I refer to as resistance loading reflex, which was kind of interesting. So when we contracted the biceps, for instance, if we contracted it at 17 to 20 with normal active contraction at 17 to 20 millivolts, the triceps would be at 45. And conversely, when we use trigenics, we would get a significant change in the amplitude of the sine wave, which actually this slide is a little bit too, it'll take a while to explain it. So suffice to say that with trigenics, really what this slide is trying to explain is that, and what we're trying to prove here is that when we apply a small load to the antagonist, to the agonist, I should say, the amount of reciprocal inhibition in the antagonist is significantly increased. That's kind of what this slide is all about. And that's why we apply resistance during the procedure. Next. So a lot of people ask, is trigenics permanent? Because with trigenics, the effects that we get are really astounding and dramatic, to be frank, and these are with conditions that are chronic, that have tried a lot of other different methods of treatment, And patients are finding that, they have, often maybe an 80% recovery within literally one procedure with, non-complicated conditions. And so people ask, is this going to stick around? Is this going to stay this way? And the effects are very, very sustainable because trigenics is a multimodal stimulation approach that is consistent with the principles of neuroplasticity and enhanced cortical neural reorganization of the somatosensory and sensory motor system. So what that really means is that there is a change that takes place on a brain-based level that is sustainable as long as there are no other deleterious influences on the target area that you changed or the target areas. So if you put everything into proper balance with respect to the pull patterns of the musculature in the body, and you follow through even the anatomy trains and so on and so forth, and you sort of normalize all of those pull patterns, then you get an extremely sustainable effect. Next. So this is now video, and I guess you're going to play this, right, Lindley, of in my clinic. So
Yes,
now
I am.
we come with the technical stuff here that we've been trying to figure out. Hopefully Lindley can get it. If not, maybe Sarah will help her. Somebody will help her figure out how to get this thing going here. We were practicing it earlier, but technology is not our forte.
It's pretty bad, but the last 4 months have become much more painful constantly, and for Preet, and lots of movement in certain positions, and especially behind his back. Did we video this already before? Sorry? Did we video already or no?
Yes.
Yeah. So we have another video of this which we can attach to this video. Great. Let's just see behind the back right now. Stand up. Let's see how far the other one goes, how far the left one goes. Left arm up behind your back. Behind your back.
Like this?
Yeah. And the right one. Left one up more. Left one all the way up. No. Put the left one as high as it'll go. And now the right one. Okay.
Mm-hmm.
So, but he has to move his whole body there. Okay. He also has a loss of feeling in the legs. I think we're just doing mainly the shoulder procedure. We may do a little bit on that back, mainly the shoulder today. So I don't need to get into that. So basically, what he's really suffering from, also when he comes up the side, is a frozen shoulder impingement syndrome. It looks like not an adhesive capsulitis. So we're going to do the procedure for that right now. So here's the chart on it. So the red is where the muscles are short, and the blue are muscles that are weak. The yellow indicates areas that we'll be doing some magnetic infrared laser for collagen production and the healing response. So basically, we're going to work on this right one. I'm going to look at the left one. If I'm looking at the way my finger is here, my finger's not really coming up. But if I look at the right one, when I hit a certain spot, you see him grimacing. He can't come beyond this spot. It's quite painful. So, and you see how much pain he's in there. Actually, if you face the camera, or if you shoot him from over here. Okay. And you can fit through there as well if you need to, right? So if we look at this, we see he's not happy. He's not happy at that point. He's not happy here. So that's the Ollos trigeminus compression test for impingement syndrome. And it just literally made him sweat. He doesn't like that. It's not good, but by the end of this, that's been like that for years. So we're going to, we also have his pictures here. And there is a bit of a superior subluxation of the humerus here, which means that the humerus, the arm bone, has been very super mildly kind of malpositioned. I won't say dislocated, but malpositioned in an upward direction, so that the socket where it is doesn't have as much space. When the shoulder comes up, the two bones hit together. So we've got to bring that bone down today. We're going to use the trigenics procedures with some osteopathic muscle manipulations as well, and we may use a little bit of chiropractic on the lower cervical neck area where there's some compression of the nerves. If we look at it, we can see there's no movement here, lots of movement this way, very typical in And you can see again where he's jumping there, not on the other side. Very typical with frozen shoulder of any kind, whether it's impingement syndrome or adhesive capsulitis, usually going to get that. And he has very, very significant weakening here. Let's look at this again of the biceps turning the shoulder all the way over. And if I do that, there's no way he can hold his arm up. This one, he's strong as an ox, no problem. And so that's sort of the main things. Now he's got a double problem with this because he also has a supraspinatus small tear. Hold it up there, and it's not, you see the wincing of his arm. I'm just using one finger. This one, I can, do whatever I want. And if we bring it over for O'Brien's test, all the way over here, hold it there, we're going to see that he really gets a lot of pain when I do that. Not happy, swearing, and sorry for the obscenities. But that happens. Okay, it's not the worst that I've heard during various procedures that we've had to do with patients. Okay, so let's get started. We're going to do the latissimus dorsi lengthening procedure right now. Qu'est-ce que c'est?
Okay, so this is the myoneural chart, the assessment chart that Dr. Austin spoke about, you saw in the video. We use these assessment charts for when we're doing our assessments on the patients. There's a lot of comprehensive assessments, and it's helping determine the muscle imbalances and the pattern of the imbalances. And often, in most cases, it's really hard to jot everything down when there's so much to look at and so much to record of the over-facilitated or the under-facilitated or neurologically inhibited muscles. The assessment chart not only serves the purpose of putting down these findings, but it's also a great way of educating the patients as well, as they can see firsthand how much is actually going on with them, how much is actually wrong with them, and they have a much better understanding of what's going on with their body, and they're much more compliant then to follow the protocols and the treatment recommendations that we make. If we on the back of those, on the chart, I should say, not that we've got a slide for that, you can see hopefully that there's some little numbers on the different muscles there, and so it's easy to fill in those muscles, and so you can see exactly what it is. If you're unsure of what a muscle is, you just flip to the back of the chart, and they're all listed in the index. Dr. Orlo talked about the fact that you've got the weak and the short on the chart. We colour in blue for weak. If the muscle is short, we colour in red. And if it's both, we colour in a stripe of blue and red. So the strength tests, we have certain protocols or certain rules that we apply. It's tested in the muscle is tested in a specifically shortened position. The patient also holds them against the resistance of the therapist in a 3-step, 3-second rule. And the pressure applied by the trigenics practitioner or physician is perpendicular to the patient's limb. As you can see in the photo, the forearm is perpendicular to the patient's forearm, and the line of drive is down through the therapist's forearm. For the muscle length test, it's much more of a finesse, and so you want to feel that initial resistance as you're testing the length of the particular muscle. It's not about a global range of movement, and you're always going to test bilaterally to compare both sides. So we're going to get into another video in just a jiffy, but we're going to go through the segmental shoulder length assessment procedures. The first part of the segment, you're going to see more of a global look at the different muscles that are involved with abduction, flexion, horizontal flexion, extension, etc. The hand up behind the back is a combination movement. It's some abduction, internal rotation, and extension. After we've looked at that segment, we then carry on with the strength tests for the specific muscle of the shoulder, and then go on to the length tests after that. hope. All right. Just bear with me a moment. Oops, sorry. Generally, when we're doing the sequential assessment, we should be able to, I'm just going to drop out of that. We should be able to do that in about 2 minutes, and the strength and length takes about 3 to 5 minutes. Okay. Oops, sorry, got the wrong thing. New share, there we go.
What we're going to do now in this segment is do the sequential shoulder assessment for the range of movement. And we're going to start off with shoulder abduction. Normally you would test one side and then the other side, but for the sake of time, if I'm not doing it bilaterally, I will only test one side. So we're taking the shoulder abduction out first, and we could do it just purely, if we wanted to, as the trigenics impingement assessment, or we can just take it all the way up, and we're just going to see how far both those arms go up and compare the sides. And bring the arms down, Lisa. Now take the arms forward and up, all the way up as far as you can go, and you just check to see what both sides are looking like, and if the patient's got any symptoms that they're complaining of, bring the arms down. Now take one arm across your body, keeping the elbows straight, that's it, all right, and then do the other one. Take it there and keep the elbows straight, great, again, checking for comparisons. Now we take her into extension, so the arms behind the back, again looking for comparison with both sides. Now if you can turn yourself side on, and we want the hands up 90 degrees, shoulder abduction. We look at external rotation to see the difference between both sides, what's happening with the head of the humerus, and then she can come down. We look at the internal rotation and check to see what's happening with both sides. And then finally, we have her with her back to the camera, and she's going to put both hands up behind her back. It's a combination of extension and internal rotation. The next part of the sequential shoulder assessment is the strength test, and we're going to go through a mnemonic to help us to remember the muscles that we should be doing. So the first mnemonic is SSIT, which stands for supraspinatus, subscapularis, infraspinatus, and teres minor, the 4 rotator cuff muscles. So you're going to have the 3-second rule that we've already discussed. You're going to have your arm perpendicular, and I'm going to test. Hold that arm there for me, Lisa. Relax. Then I would test the other side. Pop your arm down. But we will move on to subscapularis. Let's have your arm in this position like that. Don't let me push the arm up. Hold it there. Sorry, hold it there. And relax. Great. Then we go straight into infraspinatus. Curly fingers down, make a fist. Again, I want my arm perpendicular to her forearm. Hold that there. Don't let me push the arm down. Relax. And then bring it just about a fist apart down by the side, and don't let me push your fist across to your waist. Hold it there. And she's a little bit weak. And of course, we would test both sides. The next mnemonic is going to be LTT, standing for lat dorsi, triceps, and teres major. Lat dorsi you can do in sitting, you can do it in prone, and you can do it in standing, but we'll do it in standing. So stand up for me. I want you to have your hand so that your thumb's turned in, so just behind your bottom like that. I'm going to try and pull out on a 45-degree angle. Hold it there for me. Don't even move it. Great. And relax. Sit yourself back down. Arm behind your back. Keep your elbows straight. Don't let me bend the arm. Great. Okay. Hold your arm out straight. Don't let me push your arm down. Well done. And then if we put your hand behind your back for teres major, don't let me pull your arm out. Excellent. So I'm trying to flex as well as abduct. The third mnemonic is DCB, standing for deltoid, coracobrachialis, and biceps. Anterior deltoid is going to be in this position, and yes, we know it's an internal rotator, but gravity is assisting in this particular case. So I want Lisa to hold her arm there while I try and break that hold. Hold there for me. Stabilizing the shoulder and relax. Then she comes into neutral for mid-deltoid. Hold there for me as I push down and relax. And then posterior deltoid coming into extension and some internal rotation of the humerus. Hold there for me, Lisa. Don't even push. That's it. Excellent. And relax. If we come for coracobrachialis, it's an adductor and a flexor. So I can come in there and try and push the arm down into extension and abduction, or I can come across and hold the arm there. Don't let me push you down and across. That's up. Great. And relax. Biceps we like to do in 3 planes or 3 positions. You want the arm in full external rotation. You want the elbow straight. My arm has to be perpendicular. Hold your arm there for me. Don't let me push down. Relax. Hold your arm there again, elbow straight. And then bringing it out. Hold there. Excellent. And our final mnemonic is PP, which stands for pec major and pec minor. So if I can have you lying on your back for me, please. It'll be easier, obviously, if I do the other side. The elbow is straight. The thumb indicates the fibres that you're actually going to be looking at. First one, we'll look at the clavicular fibres, then the sternal, and then the lower fibres or the abdominal fibres. So just hold your arm there for me. Don't let me pull your arm. Hold there. Okay, relax. Sternal fibres now, hold there. And relax. And then thirdly, the abdominal or the lower fibres, hold there for me. And relax. And then it's easy to go from there just to check pec minor. And the arm goes across the body, elbow straight again. The shoulder's coming up. You're putting some pressure on the shoulder to try and push that down towards the bed, and then trying to lift that arm off the body. Hold there for me, don't even pull up. Excellent. And if you had someone that was really big, you could get underneath and then push up that way. Finally, we're going to look at the length for each of these muscles. Again, we go back to SSIT, supraspinatus. We want to look at the length. It's a feel, it's a finesse, your initial resistance. So we take that arm, so it's just off the edge of the bed, and you're pulling gently down towards floor so that you feel that first line of resistance. And of course, it's bilateral. Swing your legs around so that you're facing the doorway again, all the way around. Subscapularis. It's like one of the length tests that we had before. And again, you're feeling for the first initial resistance. Infraspinatus, you're dropping the arms down. You're letting them just hang there. And you can see that my hand's further forward on the right-hand side, and I can feel that there's more resistance on the right than there is on the left. And then finally, if we can have you with your legs that way, The hand's going to be behind the back for teres minor. So it's adducted, and then you're trying to medially rotate and feel the resistance compared to the other side. Okay, swing around again. Latissimus dorsi, the best one really is to do the trigenics impingement test. Palm is down, and then as soon as you get there and the patient's arm doesn't want to come up any further, you know that you've got a short lat dorsi. Okay. Triceps, the hands are going to be behind the neck, behind the back. Again, if you can swizzle yourself around. And then you're just pulling down lightly on the hands to feel the resistance, having a look to see where the elbows are sitting, if they're the same height as each other in the same position. Come out of there. And teres major, bring it up, flexing the elbow, and then externally rotating that shoulder. Same on the other side. Arm up, and you're having a feel between the two sides. If we look at the length of deltoid, we'll look at anterior deltoid first. We're going to flex the arms, elbows, bring the shoulders back into extension, and then bring the elbows gently towards the midline, so we're feeling that first line of resistance. Mid-deltoid, we can't go through the trunk, so it depends on which fibres feel the tightest, whether we do an anterior deltoid length test or a posterior deltoid length test. Posterior deltoid is coming across the front of the body. Coracobrachialis, very similar to anterior deltoid. Again, you've got the elbows bent and you're extending the shoulders, but you're bringing them up high. You're not bringing it back into the midline, and you're feeling for that first initial resistance. And then biceps, just swing your legs over that way. Bringing the arms back. You've got light pronation, and you're again just feeling, and for Lisa, it's the right one, that I feel the resistance first. Great. Turn around. Pick major, arms are out, palms forward. You're relax, taking those arms back lightly and feeling the resistance. And again, it's the right side. And then finally, let's have you on your back. We'll look at the length of pec minor. And you can just have a feel and see where the humeral head is sitting compared to the other side. You can also just press down and have the feel of the resistance of what's happening over the coracoid process, compare the sides. And then you can also have a look and see, just pop your head down, you all right with that? Yeah. Just relax your shoulders down and see if one shoulder blade, one scapula is sitting more firmly on the bed than the other side. Okay. And that completes our shoulder assessment for range of movement, for strength, and for length. You can sit yourself up.
Okay. When we're doing the test for the biceps, the long-headed biceps, if you suspect that someone has some pathology at the elbow, it's always a wise move just to have your hand further up, nearer the elbow or over the elbow, instead of actually down at the wrist. Now I'm going to pass it back to Dr. Orlo, and he's got a live demonstration with Sergey.
Okay, when Lindley was talking about latissimus dorsi, that when we do this impingement test, that very, very simple impingement test that I developed, where we actually purposely create more impingement in the shoulder by literally pushing down on the acromion with the index finger. So the acromion is kind of sitting right about here, and you've got your hand there, and you're literally pushing down in the entire shoulder girdle and the acromion with quite a bit of a fair bit of force to try to create more impingement, essentially. If there's some impingement there, then the shoulder will not come up above 120 to 180 degrees. So, and the thing that Lindley was saying about latissimus dorsi is that in my experience, and I've also been in practice for just a little over 40 years, like Sarah, my experience with shoulders and having specialized in shoulders for the last almost 20 years is that with shoulder dysfunction, certainly a lot of different rotator cuff conditions and whatnot, when there's an impingement syndrome of the shoulder, I'm almost always finding that latissimus dorsi is short to some extent. And maybe that's just because of the fact that obviously it's not ever going up into its fully lengthened position, and it reflexively shortens. But latissimus dorsi is short. It's just hard to get an isolation of latissimus dorsi doing a test like this. A lot of those length testing procedures that you watch with Lindley, we're still not able to completely and totally isolate, obviously, each muscle, even with the strength testing procedures, but we try to isolate them as much as we possibly can. And so that's why Lindley was saying that when this impingement test, this trigenics impingement test is positive, that we always mark in latissimus dorsi in red as being short, and then we always use the trigenics lengthening procedure on latissimus dorsi, which gives very dramatic results very quickly with impingement syndrome. So here's how the test, this trigenics impingement test is done. Again, using the index finger of over the acromion. And what we'll do is we'll check both shoulders. Now, we'll always check the unaffected shoulder first. Now, Sergey Blinov, who's my associate here, who's working with us, he was a wrestler, top-level wrestler in Estonia and the Soviet Union. And wrestlers' shoulders, after a lot of years of wrestling, don't go up that high like football players and whatnot. So, and maybe rugby players down there. But here, you're going to probably see, again, that, if I create this impingement and press down, he's not going up that far, okay? Now, I can bring him up even without creating that, only this far. That's as far as he goes, unless I initiate some rotation, okay? So, but you don't want to involve rotation. You want to do it in straight abduction. So you can always check it this way, but then also do this impingement test. But Sergey's in pretty good shape, so he's not a patient with an impingement syndrome, so we're not getting a positive test. But if it was positive, you would see a distinctive difference between sides. If we go to another test that's really important, O'Brien's test. Now, O'Brien's test obviously is, everybody knows about O'Brien's test, is we're testing for SLAP lesions and or maybe acromioclavicular lesions. With the O'Brien's test at 90 degrees of flexion, and then maybe about 10 to 15 degrees, let's say, of internal rotation with the thumb pointed down. That's the easy way to remember it. Okay, that's one thing here to do the O'Brien's test in this position. All right, that's fine. And if there is any type of tearing of the labrum, then you're going to get a pain, and you're going to get weakness, and when you just sort of turn the thumb up the other way and it absolves, then it's pretty much a positive test. But what I have found is that if we bend the elbow and we bring it over even a little bit further into horizontal abduction, and we turn the thumb down, this is really sort of my modification or modified O'Brien's test, that I find that we're taking out a lot of the musculature in the shoulder when we get it over to this position, and we're getting down to really just the holding elements, more or less. And so if I do it in this position, compared to the standard O'Brien's test, I'll find that in many cases over here, and I'll just do it with one finger with somebody who's really weak, let it go, drop, let it go. You'll just see that it drops down, whereas O'Brien's might not drop down. So my recommendation is always also modify that O'Brien's, bring it over here. And what that essentially is going to show you is whether or not there's any pathology in the shoulder. And then what we do is with the trigenics procedures, when we rebalance the musculature very quickly in the shoulder using the trigenics protocols, we will retest again that modified O'Brien's test. And if it is strong in that position, then there probably isn't a pathology. Of course, most of the shoulders these days are coming to us with MRIs anyway, so we usually more or less know what's going on. Of course, that also depends upon who's reading the MRI. But at the same time, if you don't have that with your patient and you use these protocols, you're able to rule in rather than rule out shoulder pathologies. Speeds test is another one that we're doing, a couple more here. And Lindley already did this, of course. But the thing about speed test that's really important that I find makes a big difference, and it's not, I don't really find it in the literature, is that, standard speed test is this, everybody knows, where we're testing the strength of the long head of the biceps. Okay, doing this test. But what I find that is if we take the shoulder and I have the patient consciously really rotate the shoulder out, and I will literally pull it over like this, that in many cases, when you do that, drop it down, it'll be positive. But when you just do it without this little rotation here, it's just something to remember, that often it may not be positive and it will be relatively strong. So whenever you're doing that speeds test, always pull that shoulder, put it into maximum external rotation, have the patient do it. And then you'll take out some of the synergists and you'll get really down to the long head of the biceps. The empty can supraspinatus test is just another very important standard test. Obviously, supraspinatus only responsible to initiate the first 30 degrees of shoulder abduction. But essentially, I just do it more or less at about 30 degrees. And with the thumb pointed down, again, that's sort of the easy indicator, perpendicular to the appendage. And in the video, I had my arm up here. Actually, I shouldn't do that because I always teach all of my students not to have any contact with the muscle that you're testing. And so that would be the test there for supraspinatus. Why is that important? And why is speed test important? These are sort of the major things. If you're going to get pain and you get the patient coming in and got pain in the anterior shoulder area, and they ask them to point to it with one finger and they point to this area, then very frequently, very often, most often, you're going to have a supraspinatus or long head of biceps, or both issues in the shoulder that need treatment. So those two tests are always to be left. And I think that, what have I got? Oh yeah, and the last thing I just want to talk about with the middle delta. I mean, in the literature, in the books, it's always this way. I find that if I just extend the arm out as well as doing it this way, I'll do it both ways. I'll do it this, and it only takes a second to do. Sometimes I will get just drop it down, a positive test with the elbow extended and not necessarily with the elbow flexed. So it might be important to differentiate that and to also incorporate a deltoid, middle deltoid test. Now, middle deltoid is important because that's usually the muscle after a couple of months of therapy with your patient and whatnot. I'm sure all of you are familiar with the patient that says, "I still have that pain right here, doc. I still got that pain right down here," and they're pointing to that middle deltoid line all the way down to the deltoid tuberosity on the humerus, and where often there is some inflammation and even fibrosis. And why? Because certainly with adhesive capsulitis frozen shoulder, which is actually basically all I really treat now. And you can see information about that if you go to shoulderfix.com. I have a non-surgical operation that I perform to resolve, which we do in a private hospital, using a whole medical team and staff to resolve adhesive capsulitis frozen shoulder. But that's not what we're talking about here. But if you're interested in that, go to shoulderfix.com, and those frozen shoulder patients, as well as the patients with impingement syndrome and even rotator cuff conditions, will often complain of that mid-deltoid pain that just doesn't go away. Well, if you think about it, the humerus is just hanging in space, literally. And a lot of the time when the other rotator cuff muscles and whatnot are not helping to suck the head of the humerus up into the glenoid fossa, then you've got a lot more stress on that deltoid muscle. And so you have to strengthen up, obviously, all of the rotator cuff muscles that are dysfunctional due to supraspinatus tendonitis or subscapularis weakness or whatever it may be. With Trigenics, you can create instantaneous change, very perceptible and instantaneous and measurable change instantly in the muscle, which will also facilitate the rehab program and the exercises like Sarah was talking about, that you've got to put your patients on these exercises for multifidus, a very critically important muscle in the lumbar spine. But if you can re-facilitate those muscles neurologically, then the exercise protocols that you give them are also going to work a lot better. So we will often treat the deltoid and test the deltoid pretty regularly with our patients. And sometimes even on the fibrotic area, you may need to employ other techniques as well in treating it, whether it's laser or a myofascial stripping technique or something like that, soft tissue technique. But that's basically it. Those are sort of the 5 sort of, I guess, points or muscles and tests that I have time to talk about here today.
Right. Thank you, Dr. Olu. And you might be thinking, all right, what are other uses, or what are the main uses for, or the benefits of Trigenics? As I mentioned, probably in the second slide, the accelerated recovery is one of the things that we particularly notice. Even if you get in something that's really acute, it can make a difference that they don't seem to have the fascial restrictions and the joint restrictions, because you're able to get them to start to rehabilitate, depending on what the injury is, much quicker. Chronic pain elimination. I, like Sarah and Dr. O, a lot of our patients are chronic pain patients. We see a lot of them, they've been to other people, and coming in and getting the benefit of Trigenics, as I said, one of the main things that people say that they get the benefit of not only is the movement and the increased strength, but the reduction of pain. And with the autogenic breathing, even the research says that breathing autogenically for 15 minutes continuous can reduce the pain by up to 50%. So I give that just purely as an exercise to go with the exercises and the other things that I do once the patient has finished their Trigenics session with me. Yes, you can do pre and post surgery, obviously depending on the protocols of the surgeon, especially afterwards. We had a young guy who was a rugby player, and he had damaged his shoulder significantly, and they decided that he needed surgery. So we did Trigenics on him to have him in the best possible condition he could be before surgery. He even came in the day before. Once he was past his passive and then active assisted and allowed to do light resistant exercises, his mother, who's actually been trained by us and done all the courses in Trigenics, she brought him in. I assessed him, did his chart, sent him off and said, here, this is what he needs to be working on. And when the surgeon saw him at a time where most of the patients only had 90 degrees of shoulder abduction, the surgeon's eyes got wider and wider and wider. This is according to the father. And the son had basically full range of abduction. He's now under the rugby academy. He's going back in for some more injuries, hopefully not too soon. And the physio there, who hasn't trained in Trigenics and didn't know about Trigenics, cannot believe how strong his injured side is compared to the other side. And he said he's 5 months ahead of what he would expect him to be. So that just gives you some idea of what you can do post-surgery with your patients. Even to the ones that have had open heart surgery, once they're allowed to actually be worked on with any resisted work, it can make a difference to the cramping sensation or the pain sensations they get with driving the motor vehicle. Injury prevention is another thing that we use with Trigenics. If the athletes decide to take on Trigenics as part of their training, weekly training, then it's very unlikely for them to have injuries, unless, of course, they're a cross-country skier and they happen to plough into a tree by accident or something like that. But it's a way of saving them from injuries and saving them having time off, saving them pain, and saving them losing any performance, which then takes me into the sports performance augmentation. This Dr. Austin has done, Dr. Olo has done for many, many years with the elite athletes. He's travelled with the Estonian Olympic team and performed sports augmentation at the side before the person has gone on to throw their discus shot, and their first throw has been their personal best. And we've been able to reproduce those results ourselves with the beach volleyball girls and other athletes that we've had. And it just makes a significant difference to those athletes, and they all want that edge over the others. It's really, really significant for them. So there's lots of reasons that you can use Trigenics, lots of patients you can use them for. Even with your singers, your performers, you can use that. You can even look at it from a Western point of view or an Eastern point of view with the acupuncture points, because a lot of the myo points actually are acupuncture points, and so they can have a significant difference to the general well-being of the patient.
The specific sports augmentation is very exciting, and I just want to mention it quickly because I've been doing this with athletes for so long. Specific sports augmentation procedures and protocols that we apply for each different sport, where we've analyzed which muscles should be lengthened, which should be strengthened. We've done testing on speed skaters and jump height for basketball players and whatnot. Every single one of the athletes has achieved, and throwers and baseball throwers has achieved a personal best by augmenting the performance of the musculature. Especially with the lengthening procedure, we can take a muscle that is normally a certain length and significantly increase the functional length of that muscle measurably. So, you know, if a discus thrower needs to be back a little farther to get more momentum, we can give that to them. We can give the extra speed to the runner and so on and so forth. And when in the high levels, those little bits make a huge difference. Go ahead. Sorry, I had to say.
No, thank you. All right. We're just going back to where you saw the first video and to see the amazing results with Trigenics for the patient that had the frozen shoulder impingement.
Solo dovresti solo relax. Resting, rotating, solo menopause. Relax.
PM with my hands there, but now we're playing.
It's just watch your fingers. Oops. Relax. Resting. Relax. It's just lightly carrying. Okay, very important. We're gonna have to try to drop this bone down, so we're gonna deactivate the deltoid site and this, gain some resistance, and then I'll be able to try to distort the deltoid, super inhibit it, get more inhibition. There it's starting to go, and then I've got to actually mobilize the inferior direction, the humerus, which needs to drop down, otherwise we won't have enough space in the humeral system. Resting. No, this one. Frontal was damaged. Resting.
Come on, what's this?
You can't believe it. Seriously, you can't believe it, right? Huh?
Can't.
You can't. You were in so much pain before. You're pushing me away. You're pushing me away. What do you think about that?
You know, until now, you know, like this, it's kind of painful here. But these movements, it's just.
I haven't finished yet, you know.
No?
No, we've only done a few things.
I have
We're not finished. We're only part fixed. We're not totally fixed. I'm just testing one part right now. The other parts I still have to fix still. So far, so good, huh?
This is unbelievable, actually. This one.
Unbelievable.
Yes. It is.
Relax.
Imagine how neurological input
Relax. We just finished breathing. And go. Relax. Nice. Hands. Relax. Very nice. Relax. Good. Okay. Yeah, that's so much looser. Feel it yourself. Look at that. Huh?
I couldn't do it in the morning. No way.
No, you couldn't do it yesterday or the day before either. No, you couldn't do it, period. There we go. Let's keep on.
There's the long head of the biceps that we're treating here with the F procedure. Had a long head of biceps problem.
Okay, did you feel that pop in there? That's what we wanted. Breathe. Did you feel it too? Right through his body? Wow. That was what we call a myoneural reduction. You had an instantaneous change in the tonicity of the biceps tendon where it just literally went pop. You felt the pop?
Yes.
Yeah. It just literally went pop, and we had such an immediate change, neuroplastic change in the tonicity that it almost felt like the muscle sort of popping open. So now you got this. Hoya Tugasti. Now you've got this. Hoya Tugasti. Now you've got this. All right, so now we're doing the anterior scalenes on this side, middle scalenes on this side, because the compression of nerves, if I don't fix this now, after I fix the shoulder is going to come back again because the nerves are all being compressed right here. As opposed to this side, he doesn't feel much, but this side, he hates it right there. So
Lengthening the
bring it right here towards the right shoulder as you breathe out when I tell you. Quite hard. And go. And relax. Relax. And let it go. Let it drop. I'll let the 11th cranial nerve a little bit here. Good. 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 Let go. Ah, good. Beautiful. Okay, breathe. Push to the right again. And relax. One more time. I still got a little bit down here. Good. Let it go. So let's look at now the difference in the neck, for instance. Watch. This was before on that side, but remember the other side didn't move? We're pretty much a lot better. Bring the shoulder up.
Now we do the upper as well.
We need a little more work on that because there's some arthritic changes, but certainly a lot better than it was. Now the shoulder is going to be in good shape. Let's move both hands up.
It's unbelievable. It's unbelievable. Maybe I can play tennis even.
Not immediately. For
I can't play this really, guys.
Well, you saw it on the YouTube, right? But you didn't. You still think you thought, is it possible for me?
I didn't think it's impossible, but I didn't believe you could fix me in one time. Really, it's unbelievable. Really, it is.
Yeah. Well, you know, we just finished the procedure with Preet now, and he's got his shirt back on. And tell us what you experienced during the procedure, or what you were thinking beforehand. How did you saw some videos? What brought you here?
You know, I saw the videos in your homepage, and I saw you fix people, but I don't believe this. It's in one time. I feel like new.
Mm-hmm.
Really, it's kind of free.
Uh-huh.
It's kind of free.
Mm-hmm.
It's moving free.
Uh-huh.
No pain.
Uh-huh.
It's unbelievable. Really.
It wasn't that painful to do it.
No, I was really afraid, you know. I was really afraid in the beginning. I thought the needle in the back, I saw in the video, you know.
You thought I was going to do the needle today.
Yeah.
No, we didn't do that. That's right.
I'm really happy.
Yeah?
I'm really happy.
I'm glad. What do you think for all the other people that have got any type of frozen shoulder out there?
You know, I think you should come here one time and that's it.
Estonia.
Really.
Yeah, good. That's great. Well, there you have another success story with the frozen shoulder impingement syndrome. This is Dr. O and the Dr. O Show. Can you do this?
So Trigenics is patient friendly because when we, it's not that painful, as he said, to apply it, certainly to a condition like this. Adhesive capsulitis is a different story, but it's patient friendly because when you think about it, when we significantly increase the mechanoreceptor input, we're causing a reflexive decrease in the nociceptor firing. So that's why Trigenics is, when it's being applied properly, is quite patient friendly and not painful for the patient. Yeah, and if there's a difference between, we showed you shoulder impingement syndrome, and many people call that frozen shoulder. Really, frozen shoulder should be referred to, should be in the adhesive capsulitis category, but you can call it a type 1 and a type 2 frozen shoulder if you want. But the impingement procedure and how to fix shoulder impingement, frozen shoulder impingement syndrome is what we teach in our courses. We also see patients for adhesive capsulitis frozen shoulder from all over the world. You saw the website there, frozenshoulderclinic.com or shoulderfix.com. You could go to if you want to see the non-surgical operation that we perform. Patients fly from all over the world, literally, to either see myself or Lindley in New Zealand, or myself in Estonia or Canada, where we have 3 clinics, frozen shoulder clinics for adhesive capsulitis. And that might be something of interest. And Sarah, you might want to take a look at it too. It's quite a different approach. And we do use a lot of medication. We use an anesthesiologist and registered nurses and physiotherapists and assistants. There's a whole team that we use and we conduct it in a private hospital. There's a lot of medication. There's a lot going on to resolve it in one visit, literally, or one day. But we do resolve adhesive capsulitis in one day, and I've been doing it for almost 20 years. So it's perfected now, more so than ever. So if you're interested in that form of frozen shoulder, go to shoulderfix.com, and otherwise trigenics.com will give you the information on what we're teaching here today. Go ahead, Lindley.
Thank you. Can I just ask how we're going for time, please?
Yes, it's already time up.
Time up? Okay.
You can go for more 5 minutes. You can go for more 5 minutes.
Okay, we've just about finished. Dr. O, do you want to just quickly talk about the arthrostim vibrocutter, and then I'll just wind up.
These are the heads for the instruments that I developed. They're called Trigenics multi-probe heads, and they just increase with the pulse, vibrational pulse. We increase the amount of mechanoreceptor stimulation using these instruments. One is for TS procedures, and one's for TL procedures. Next.
Great.
So those are the instruments. That's what it looks like when we're applying it. Next.
Okay.
And these are the practitioners that we have, some of the teachers placed all over the world. Next. And that's it. Yeah, so we finished in our 5 minutes. If you want to have a question and answer, if you're interested in any, well, actually, Lindley, you want to talk about your course? Go ahead.
No problem. You can take more 5 minutes more. You can talk.
Oh, okay. Go ahead, Lindley.
Okay. All right. Thank you very much. Over the years, the courses have developed quite a lot, and even this year we've had some new advances because we've been forced into doing online courses. And one that we actually have for the Dubai conference participants is we've got a promo for you over the next 3 days, and that will be the first of 3 of the shoulder courses. There's 3 that we normally do, and that's on the trigenics.com website, and you can just go into courses there. When I did the Trigenics course for the very first time, I did the full full body in 4 days. And at the very end of it, I went on record saying this was the best course that I had done since I had graduated. And it is a while since I have graduated. Like Sarah, I have been practicing for near enough to 40 years, and I still feel the same way. So it's been our really great privilege to bring something that we're very passionate about to you, and we hope that you have enjoyed the presentation and also to see the effects. They're not doctored, they're just, that's what we see all the time with the patients, and it's very exciting to be able to bring this to people.
You're teaching the course. You're teaching the course, right? When is the course that you're teaching? When is it? So they know which one to go to.
The 25th of November. We're actually having a New Zealand time of 7 o'clock till 9 o'clock. It's a 2-hour first part. So yes, please go to the website.
That's on the website, trigenics.com. Yeah. Do we, Lindley, I want to thank you for an amazing presentation, and I want to thank our host for
yes, thank you so much.
For us. Really, really great.
Any questions? Any questions to Dr. Lindley Liathod as well as Dr. Alan
Olo?
Sorry. Any questions? Actually, we have more than 50 participants, doctor. They are coming. They are joining only when they are going to give their talk.
Sorry, say that again.
Actually, we have more than 50 talks, 50 speakers. So they are joining when they are presenting their talk only. Remaining,
okay.
That's the drawback. We have only at present we have only 13 members in this event.
Okay.
Well, it's great that we're going to be able to have the recording of this conference.
Yes.
As for me, I mean, it's nearly midnight, and knowing that I've got a full schedule tomorrow, I won't be sitting up to hear the rest of the speakers. So now that I know it's going to be recorded, I know I won't be missing out. So really grateful that you're going to be doing that because of the caliber of the speakers that you do have. Thank you.
Yes, within a couple of days, we will send you all the recorded content to your email ID officially, both proceedings as well as e-certificate.
Okay, thank you so much.
Thank you so much.
Thank you very much, sir. You have given a wonderful speech. It was excellent. Different way you have given. Yes, thank you very much for speaking up in this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet you again next time in physical event if everything goes well in 2021.
Fantastic.
Right.
Okay.
Yes, we do. Yes. Thank you so much.
Yes, okay. Thank you. Now we ask Dr. Henna Sai from Austin, intervention therapist from University from India, to join the event and start presentation.
Hello, everyone.
Yes, ma'am.
I'm very delighted to be part of this event, and I hope to share some knowledge with you. So I'll begin my screen sharing. So I just want to know if I'm audible very clearly and you can see my screen as well.
Yes.
Okay, so I'm a pediatric physiotherapist practicing in India. And the title of it's a case study report, and the title of my study is The Effect of Vision Therapy Based Exercises on Eye Teaming, Tracking and Visual Attention Skills in a 5-year-old boy with the diagnosis of autism. So, as is physiotherapy for the body and muscles, vision therapy is for eyes, and it's beyond that. It's basically a practical method of reprogramming the brain as well as the body to work together as a team. Now, I hope we are very much familiar with what autism is. It is usually taken as a developmental delay with communication and socialization concerns, and there are definitely certain sensory concerns. But most of the time, we are not able to understand that the child or the individual is having a concern. Is it because of a sensory overload? And the exact cause does not get shaped up, or it does not get very clear. And most of the kids with autism or individuals with autism, their concerns are overlooked as it can just be a behavior. We don't think about the visual problems, we don't think about the visual skills here. So visual problem, visual skill here does not mean that the child is having delay in the vision or cannot see. These are basically a visual motor system skills that are going to help an individual. So these visual skills are which can be interrupted in a person with ASD are listed like there's lack of eye contact, but still this is very controversial. Now we don't take it as a very huge concern with lack of eye contact. Then there is staring at spinning of objects, at spinning objects. Then there's inability to focus, difficulty in maintaining attention, and there's a lot of hypersensitivity to visual stimuli. And there is peripheral vision also, that is sideways viewing. So vision therapy is going to enhance the neurological connections in such a person, and research has shown that after vision therapy, there is a benefit to such an individual with their gaze fixation, visual attention, central peripheral vision, visual depth perception, visual spatial ability. So that is going to get improved. So vision therapy sessions, they are going to control your neurological system. They're going to reprogram the visual motor systems. And these sessions are non-invasive, very simply designed and age appropriate, different for an adult, different for a child. So they are going to be designed in that way. It's very important to rule out for any child who comes with you with the concern of ASD or learning disability, never to rule out their visual skills, because most of the kids who are not able to read and learn very, very precisely, they have some or the other undiagnosed visual skill inability, which we are not able to track. So even if I show you a simple visual skill test, they all have some cognitive stimulating activity. It's not always that your visual motor system is working on it. There are your higher mental functions also working on it. So whatever exercise, whatever assessment you do when it comes to the vision of the person, to their relating to their visual stimulation, it has some cognitive stimulation. So that's why I'm showing you this picture. Again, if you go for a simple eye test also, what all things are being assessed, that only becomes your therapy. So vision therapy is having that underlying principle. So this is one scheme of activities which is being given. So vision therapy is always in collaboration with a therapist as well as an ophthalmologist. So the case in question here is that the subject came to us when he was about the age of 5 years during September 2019 to our rehabilitation team. And apparently the parents reported concerns that the child has good command on the language skills, but has major concerns with motor planning and socialization. There are certain stereotypical behaviors that needed to be addressed. So during the therapy sessions and our assessments, we were tracking these concerns, and but we also found that there's something else which is triggering in this child, and it is hampering his maximum potential and maximum performance. So during our assessment and during our treatment sessions, we found accidentally that there is poor development of visual attention skills along with limited eye teaming and visual tracking abilities. There is lot of sideways viewing, that is the peripheral vision is very much activated. Although the child is able to perform the partial performance of his self-care tasks, but these things are interfering. So this we gradually came to know as we proceeded with our assessment and therapy treatments. So Also, one peculiar observation was that the child kept on rubbing his eyes. So this further led to the confusion, either this child is very hypersensitive to visual stimuli, or he is developing a stereotypic behavior to escape from the task which the therapist is assigning them. Then we had also presented some visual perceptual worksheets. Visual perception is to distinguish between few shapes, colors. So if we go into the detail, that is a total different domain. So in those tasks also, the child was requiring lot of prodding and coaxing. So based on our entire session based observational assessment, we decided to incorporate something beyond the normal treatment that we give, that is vision therapy exercises, to address these concerns of visual attention disabilities. So this intervention which was provided was given in a child play therapy form with lot of sensory integration, and it was made child led, so that the child can give his full participation and he enjoys it. He doesn't take it as a therapy but enjoys it, doesn't take it as an exercise but enjoys it. So the subject was pre-assessed once we were very clear that yes, there are issues with the visual attention skills, there are concerns which are leading to these problems. We pre-assessed the child on these following outcome measures, and he was then later subjected to 8 weeks of vision therapy based exercise programs, which was given three times in a week for 45 minutes. So the exercise regime for Vision Therapy Institute has been adapted from Vision Therapy Institute located in Australia, and that has further collaborated with the behavior optometrist. So autism is a wide research oriented field, and there are a lot of things which are being employed. So it is not a typical treatment which can be given to an individual with autism. So this is the boon when you treat a child with autism. You can be very, very, very explorative. So these are the part of the therapeutic interventions. These are the set of exercises which are being given in vision therapy. So as you can read along, they are all play based and child led therapeutic activities. Like you can see a picture of a child picking up grains of rice from a tweezer. Then we are using simple dartboard. So one activity is not focusing on just one particular aspect, that is the oculomotor skill or just the visual perception skill. One activity is so multifactorial that it is working on all the skills at one time. So we also adapted the exercises from Brain Gym, typically the earth button, which helps the child to build up the eye teaming and eye tracking ability. So these were the goals which were backing up. So a single play activity, when it is being presented to the child, it is having the goal which is channelizing the peripheral vision, oculomotor skills, eye teaming, and the visual perception skills. So the assessment is very important if you track a child who is having visual attention abilities on account of his ASD condition. So as we proceeded further with 8 weeks, and then we reassessed the child to see the post-intervention status of this of our subject, we found that the first assessment test, that was the gaze fixation, which is again very playful test. You ask the child to look at the experimenter's eye, and then you do the scoring. So that scoring has gradually shot up. So there is not a major difference, but it has shot up in that 8 week span of time. Similarly, the teddy bear's cancellation test, in which is a kind of a visual perceptual task for the child. Again, in the pre-intervention phase, the results were not so pleasing as they were preceding the 8 weeks. So the child has shown some marginal improvement in his skills. The main test which has led to a confirmatory sign of positive trend of improvement is the TVA, and as you can again see the graphical representations, it has definitely highlighting that vision therapy plays role in visual attention skills. So what do we get out of this case report of a single child is that it has proved that vision therapy does wonders. It is a set of exercises, not for the body basically, but for the eyes, and it is very useful in individual with ASD. And it is not only working on the visual attention skills, but also the visual processing. If the visual attention skills improve, definitely the child's comprehension will improve. And in our case, the child already had good development of language skills, so he was a high functioning autism child with certain streak of Asperger's, as we can say. Now, the most promising result was, I had mentioned that the child kept on rubbing his eyes, which was very strange, which made us confused also. But this also had shown some decrease. Along with this, as the visual attention skills improved, we also now could see some improvement in the visual perceptual abilities, the distinguishing abilities, and unknowingly the motor planning ability has also improved, because when the parents had reported only the concerns about his motor planning disability and about his disordered way of socialization. So his motor planning has actually improved. So when your vision gets better, when you're able to visualize and when you're able to process better, obviously a motor planning and problem solving ability is going to as well as step up. So it was a 45 minutes thrice a week session for 8 weeks, and it has shown positive trend of improvements. Now, again, there have been improvements in the eye teaming as well as in the visual tracking abilities. So there is also some change in the peripheral vision which the child was showing. So there has been a different alteration which can be seen before therapy and now post therapy. This is like ongoing, still we are working on this child and we are seeing so many bright movements with him. So definitely vision therapy has a functional role and it needs to be researched more and more. And if vision therapy can produce significant improvement in a single subject with autism, as I practiced it in India by adapting a particular exercise regime, now this should be included as a assessment as well as a treatment. If you do a good assessment, you will be able to produce the right amount or the right goals, and then you're going to able to implement it well and you will surely get results. So this is an important therapy in terms of visual skills. If it is happening, if you see any kind of concern in an autistic individual, so if his visual attention, visual spatial relationships, the depth perception, the motor planning gets improved for such a child who has concerns with socialization, which is always a red signal in autism, that can also be worked on. So this vision therapy can indirectly be a very instrumental in improving the socialization also. So the basic clinical implication and conclusion of this case study report, it's like just like a very fruitful story, that vision therapy needs to be researched and practiced more, and it is still unexplored. We just got to know about it, and in our case we have practiced it for 8 weeks in a evidence based way. It can improve the performance of autistic individuals and make them great readers and writers, because we often forget that if a child is tracking problems with reading and writing, we never think about it as a visual attentional skill problem. We always think it's a behavior, there's some learning disability. So through my study, I just want to spread this word and I want to uplift this vision therapy theme. So thank you for inviting me to this particular conference, and I hope my thoughts and my research paper has been somewhere or the other meaningful to you, and it has added some knowledge to your platform. Thank you so much.
Sorry, any questions? Any questions to Dr. Hina Sai? I have a question from the presentation. Yes, madam. You can. Yes, you have a question from Dr. Mahesh Javari, madam. Just you can be online. Yes, madam, you can have, based on the case study, any implementation to add eye examination as a standard care for patients with antivism?
Yes, post the study, I feel being a therapist also, we overlook at that fact and we get concerned about other things. But it should be added and it should be implemented. So somewhere or the other, indirectly, I have tried to convey it, but I will convey it in a more clearer form that the assessment part, the examination part should be wholly done. It should not be based upon their socialization or gross motor skills. Definitely, the eye examination can also be done for them, but it should be proper in-depth eye examination. It should not only be checking the oculomotor skills, that is the 6 cardinal signs we have for vision. That is what I want to convey. I hope I am quite fulfilling to your question. Thank you for the question anyhow.
Any questions more? Any questions? Yes, yes. Thank you very much, madam. We want to compliment you on your topic. Thank you for sharing your tips with
Thank you
us.
so thank
Yes.
you so much, sir. Thank you.
Sir, looking forward to meet you again next time in physical event 2021, if everything
Sure.
goes well.
Thank you, sir. Thank you.
So we'll be sharing you the certificate as well as conference proceedings by within couple of days, madam.
Thank you,
Yeah,
sir.
thank you very much.
Thank you. And
Yes,
all the best, everyone.
yes, yes. So now we asked Dr. Khadga Singh Gurang from Green Pasture Hospital from Nepal to join the event and start presentation.
Namaste and good evening. This is Khadga Gurung from Nepal. I have been working in Green Pasture last 33 years and I'm a physical therapist. I've trained in master degree in a community physiotherapy from Manipal. Now I'm presenting burden of spinal cord injury in Nepal. Hello everyone, have you seen the screen?
Yes, yes, sir. You can continue.
This is Pokhara, where I've been working last 33 years. So Green Pasture is located in this area, and this is very, very beautiful place. Nepal is landlocked country, China in the north, India in the south, east and west. The population distribution in Nepal is 6.7% Himalaya, 43% in hill, and 50% it is a plain in Tarai area. The almost 23.94 million people is our population. And then this is land of Yak and Eti country. Spinal cord injury rehabilitation service in Nepal. First spinal cord injury rehabilitation center in Nepal is Green Pasture Hospital. We have been started 1997. Second, spinal cord injury rehabilitation in Kapre in Kathmandu started in 2002. Then 2015, we have a huge earthquake that also we have started a small unit of spinal cord rehab in different part of Nepal. Then after that, we have a lot of challenges. I'll be discussing about it. This is Green Pasture Hospital from front view. This hospital was opened 1957 for leprosy. As a prevalence of leprosy fell down, new area to be used our expert and a facility where we serve. Then we accept our first spinal cord injury patient in 1997. Then while we have been working, we did a small study long back. I just shown you that the distribution of topography and everything where the population is located. Fall from height is 96, which is fall from tree mostly, ladder and cliff. Then road traffic accident is 29%. large group of the accident are between 21 and 30. It is a 34%. It means the young people who is going to start their career, these people got injured. This is the major group, large group of our population. The male are were admitted in a spinal cord injury rehabilitation center in Capre, almost 2.3 times more than female. This is study was done 2015 August to 2016 in Capre. The topography was 15% of Himalaya and mountain region, 68% is hill area, the 17% is plain or it is a flat area in Nepal. So you have seen the trees, most of the people are fell down from tree and become a spinal cord injury. Then you have seen the village, most of the villages are located in a mountain and hill area. So we live, even I am also from that area. So 49% of population live in hill area in Nepal. So now you have seen that 29% of road traffic accident in Nepal. This is done in 2015 and 16. And you have seen this is in Kathmandu road traffic. This is a road. Because of the spinal cord injury, most of the people, they arrive in our center with a huge life-threatening situation, bed sore. These are different type of bed sore we have receiving those kind of patients. This is very young lady. She fell down from tree while they're walking, getting a grass from tree. Then she fell down. When she arrived,
بس اجي بس اعمل البرزنتيشن تبعي.
pardon? This is most life-threatening situation arrive in our center. These are the bed sore. So we have done a lot of work on it. Then we did a small study. It is in 2007. And we just
حبيبي اسمع ولا عليك أمر، ممكن تفتح لي، ممكن أعمل من عندك من هون الزوم أحسن عشان أكون جاهزة، بلاش ما أنت تكون وأنا عجب. والهاي بدي إياها تكون على الديسكتوب المحاضرة اللي بعت لك إياها.
The follow-up study was in a part of our small area, which is just 1 year gap discharge from green passer. Within them, there is 37 follow-up after discharge from our center. When we find out that 80% of wheelchair users could not enter their home independently. 74% of those who were using a mobility aid could not access the community independently because of the physical terrain. Of all those who were interviewed, half of no accessible toilet, access to water source, or road access to their home. These are the conditions we get from our study. Then we started change our strategy. We've been working in a center, then we try to link in a community, then we provide a holistic care. It is a multidisciplinary approach. We include our caregiver or patient and occupational therapy, physiotherapy, even we have a peer counselor and counselor. Then we provide a multidisciplinary approach treatment for them to minimize opportunity to further spinal cord damage. Most of the time, patients come without any brace. Example, the patient, they come with a spinal cord injury, but nobody come with any protection. They don't have any protection while they are transferring from injury area to our center. So we try to educate their family member and community to prevent other complications such as a pressure source and UTI. These are the main complications after discharge while they are being at home. So the damage that we try to manage bowel and bladder care appropriately. So we try to make accessible their home to make a ground mobility device for those who are actively involved in a school, participate in activities. So we make a ground mobility device for them. So these are Hello device we make ourselves in our center. We have a tilt table. We try to make up them in a, put in a tilt table. We have a small school where they are arrive in our center. Nobody can read and write. So we try to educate them while they are in our center. So this is a part of exercise. We have a counselor. And you have seen the last one. He never been after injury in any rehab center. It is 21 years being locked inside home. So we try to bring those people. Then these are the young boy. He is a young boy. He got an accident. He got a cervical injury, and he got a paraplegic. So there was nothing in our center. We send in Kathmandu, refer them. This is his home. Then Kathmandu, they have done a surgery. Then refer again back to our center. We make them. Then he is still working in a cycle business, a repairing center. This is a lady. She fell down in a tree. She got a cervical injury. We make ourselves hello brace, and we make a custom voice, and she got a improve. So slowly she is independent. So after that, we got a 2015, we had a huge earthquake. We learned from that earthquake, rehabilitation need assessment in a person to following spinal cord in disaster setting, because nobody has thinking what will happen after disaster. So we learn from there, expanded community-based rehabilitation through capacity building, access to capacity building initiatives such as course, conference, telemedicine, library, and upskill staff, caregiver training, better communication, improved link with a acute hospital, refer and post-discharge follow-up in community. It increase use of information technology, enhance continuing medical. This is, we got a study from another center, Dr. Raju Dhakal, who is based in Kathmandu. So we got those lessons from there. But still there is a lot of challenges are there. In Nepal, everybody knows that political instability has affected the entire health system of the country. Lack of policy, major center or hospital with rehabilitation we need being located within the capital city or major city, inadequate service center across the country, only 2 rehabilitation centers in Nepal. The lack of rehabilitation specialists. The foremost financial constraints has always been key independent to successful completion of rehabilitation among patients in Nepal. This also we got a small study and barrier to rehabilitation in India. There are still a lot of challenges. Over the last few years, number of spinal cord injury patients are increased in Nepal. Some of the injury were preventable with a simple precaution like using safety measure at the workplace. Still people are working in a village. They don't have a scientific way to keep their cattle in a village. So they have to go in a forest, climb a tree, and still they are getting a lot of problem. The trauma patient often reach to the hospital without any neck or any spinal immobilization. This is the major part. Few years back, there was a big disaster in a neighboring district. People, they are able to move their leg and hand while they are got an accident, but while they are transporting from accident place to the hospital, he become totally quadriplegic because of nobody care about neck. While they're transporting, they have to put in a braces. Nobody cares. Still, people, they have to hurry to take them in a normal way to the hospital. Then from injury place to hospital, people get more worse. The study from the Eastern Nepal that revealed that 81 of cervical spinal cord injury patients were brought to hospital without neck immobilization. So still people are practicing same thing. So management of spinal cord injury extremely difficult in resource limited country like Nepal. So when the poor people live in a village, they got a injured, it is very expensive for surgery, and it is very expensive to treat come to the center in a big city and stay in a hospital. It is quite expensive. So people, even they are not willing to continue this rehabilitation service from center. That is, economic constraints are still there. Many of management of those patients are lack of trained personnel. Still, there is a very less rehab center and very less rehab personnel in our country. Even though there are well equipped, but when we talk in a different center, very few centers are well equipped. Most of the centers are not well equipped for rehab. Awareness among patient and family members are very, very poor. Hospital are, first of all, they are very uneducated. Make them to educate, it's very difficult. Most of them, they cannot read and write. So we train them here. We want to send them with a voucher, but they cannot read and write. We want to follow up them. They are very, very, even they, socially, they are very isolated and they cannot access any activities in a village. Still, Nepal government has not a bring up standard policy for rehabilitation. Absent of standard treatment protocol, there is no proper protocol in Nepal. So we have been trying with the help of ICRC and Handicap International to bring up those proper protocol for our nation. But still, it is on a process. The surgery is very, very expensive. That's why when they arrive in our center, we need to immobilize quite long time, 4 to 6 weeks. They are totally immobilized in a bed. So most of the place, the surgery is not available. Only few surgery are available in a center, which is very costly. After surgery, they don't have the money to get the service for rehabilitation. Very costly for them. So spinal cord injury rehabilitation, in a conclusion, SCI rehabilitation can be successful in Nepal, in spite economic and geographical challenges are there. So we try to make it accessible for them, but it takes a lot of time to travel to reach over there. Then their house are so in a hill area. It's very difficult to make a wheelchair accessible, toilet to bed, bed to kitchen. It is still, it's a geographical challenges are there. Use need for caregiver and population education in order to provide a timely SCI rehabilitation. The most of the people after spinal cord injury, they stay in a home. We try to educate them to bring, but still it is an unreached area where they don't know the treatment for spinal cord injury. So they keep inside the home and they got a complication and they die. Most of the people, even they are not reached in a center for to get a rehabilitation center. Need to improve in a country infrastructure to allow higher level of independent at home. Independent at home. Still, this is a huge challenge for that. We need to make them a useful member of family, useful member of society, so they could have most time activities at home level and they can have a participate in their society, in their village. But first of all, accessible are very, very difficult for their home. Second, wheelchair are still very difficult to get uh, them, because once we provide a wheelchair, after 2 or 3 years, somebody need to replace it. Wheelchair is so costly and appropriate wheelchair is not possible to get for reach to them. So it is very, very big challenge to make them independent at home for spinal cord injury in Nepal. Thank you so much. Is there any question?
Any questions? Any questions to Dr. Kadgabrang? Thank you very much, sir. We enjoy your speech. Pleased with your topic. Looking forward to meet you again next time.
Thank you so much for giving me such an opportunity. Thank you, sir. Thank you so much.
Thank you very much. So now we ask Dr. Arthropathy from Physio Studio Food Balance India to join the event and start presentation.
Hello, good evening, everyone. I hope I'm audible.
Yes, madam.
Thank you. I am Dr. Arthropathy. I am primarily dealing with trauma and sports injuries in India, and I am also the head physiotherapist at the institute.
Yes, madam. Just 1 minute, madam. We have question from Dr. Mahesh Javari. Yes. What are the safety measures are you used to decrease the number of falls from the trees? I think this questions to Dr. Kadgar.
Mainly the people, those who live in a village, their income is they have a, they have to keep the animal like a goat, buffalo, cow. There is a seasonal, in a winter seasonal, they don't have any grass, everything, and the grass, all those things are not available. So they have to go in a forest, they have to climb in a tree. There is no any scientific things to take a measure to climb up a tree and go down. So they have to climb, they have to go in a forest, climb in a tree, they get all the grass to feed their cattle. So this is the way still most of the people, the main income is provide a kid, that animal at home, like a poultry. So we thought sometime people, they need to switch to change their professional like a poultry farm or more agriculture, all those things. But this is not a accessible market for them. So they have that poultry, these are things they have to sell in a market, but it is still long way to get in a market. That's why it is very difficult to change their lifestyle, those who live in a village. So government has to think what is next. This is very important in our country. 68% still fell down from tree. This is challenging our country.
Any questions? Thank you, sir. Yes, madam, you can continue.
All right. Hello again, everyone. So I'll be talking about prehab in revision ACL ligament injuries and why it is the need of the hour. We have seen prehab in normal ACL conditions or say before cuff repairs or any other surgery. But when I was going through the review of literatures, I barely found any literature which says that you have to do prehab in revision ACL ligament injuries. So in the coming slides, I'll be telling you all about ACLRs, why do they actually fail, and the need of doing prehab, the goals of prehab, and a case study that I've personally done. So we'll be seeing videos of my patients. Everybody knows that ACL stands for anterior cruciate ligament, and it is one of the major ligaments of your knee, which helps you to control the anterior translation of the tibia, as well as it adds to the rotational stability as well. And according to research, it is one of the most commonly injured knee ligament with the highest incidence of tear and also the highest incidence of re-tear. If you see the demographic data of US, more than 2 lakh ACLRs are performed every year there. And if you see the demographic data of India, roughly say 2.5 to 3 lakh ACLRs are performed every year. Because of the active involvement in sports and recreation and fitness industries, the chances of injuries automatically go higher. And because of newer forms of fitness that have been introduced, like CrossFit, power yoga, etc., the chances of injuries have gone up really high. Now, even though a person has been diagnosed with ACL, he's operated with the ligament reconstruction procedures, there are still chances that he or she may end up in a re-tear, and the chances are approximately 6 to 9%, which is more than any other ligament in the knee. What happens is when a person like an athlete or a fitness enthusiast gets a re-tear, one, his confidence level really goes down. The athlete may actually low down on his career or his functional status. He may not be able to play the tournament, or he may not be able to go back to his sport immediately. So that is kind of depressing. And this also occurs if the injury is delayed, if the management of the injury is delayed. So it is really important for us to get back to the pre-functional status of the athlete or the individual before his surgery and after his surgery. So we'll be seeing about the causes of ACLR failures. Why do these ACLs actually fail? So I have enlisted number of causes. The most common cause is, of course, instability. So like I said, the primary function of the ACL is to give good stability to your knee in terms of anterior translation of your tibia and also rotational. So instability could happen due to a lot of internal causes such as fixation failures, impingement of the graft, or local infection in the joint. So what happens is whenever you have any local infection in the joint, there is some capsular distension, which further adds to your instability. And there are multiple reasons again for your instability and pain. Say if we talk about failure of fixation in this case, the weakest link in your graft, that is the weakest link in your ACL, is the point of attachment. So wherever it attaches to your femur and wherever it attaches to your tibia, that is the weakest link. And whenever the person does an ACL reconstruction, the fixation initially needs to secure the graft tissue in place where the graft will automatically incorporate itself. So be it a hamstring tendon graft or a bone tendon bone graft, it takes some time for the graft tissue to actually get incorporated into your bone, in your tissues. So usually the fixation for BTB is with a metal or bioabsorbable screws, and for hamstring tendon is by crosspin or endobutton. So there can be loosening of these implants in the fixation. The second reason could be because of trauma, which is causing a re-injury again. So if the athlete has gone back to play without doing a proper or without doing adequate post-op rehabilitation, or he's gone to play in his phase 1 or phase 2 of rehabilitation, and he's doing a lot of perturbation activities without brace, without a controlled environment, so he will end up in a re-injury, and the re-injury might give him a re-tear. The graft impingement, which is the third point, it may happen when, say, your graft impinges into the intercondylar notch of the tibia. The reasons could be anything. Say that the graft while healing has hypertrophied, or everybody has a different intercondylar notch size and shape. So that is why it is important that when the surgeon fixes it, he needs his dimensions absolutely correct. Other intrinsic causes of failure can happen from trauma or again from graft impingement, and secondarily causing instability. The second primary reasons are pain and stiffness. Pain and stiffness can arise if the person has done an inadequate post-op rehabilitation, if the person has not really been very compliant when he's coming for physiotherapy or when he has to actually consult with the surgeon. The third reason in pain and stiffness is he has a lot of arthrofibrosis. So whenever there's arthrofibrosis, there are a lot of biomechanical abnormalities that take place at your patellofemoral joint, at your tibiofemoral joint, because there is a lot of stiffness and pain, and this can again cause some instability. The fourth cause in pain and stiffness is missed or untreated associated injuries. So say if a person is coming with an MRI and there is a grade 3 ACL injury, but there has also been some MCL or some other meniscus injury which was not initially treated, and that could be another cause of instability in the long run. And the third main cause is loss of function. If the person has some inability to return to sport or any functional activity, if his rehab is so delayed that eventually there is a lot of static instability and dynamic instability, and of course, inadequate prehab. So this is a video of my colleague demonstrating the Lachman test. So you see he's bending the knee in minimal knee flexion, and you can see that there is so much of anterior tibial translation that is taking place. I'll play the video again. So this is one of our revision ACL patients who went back to play without the consent of the surgeon and the physiotherapist, and he ended up in a re-tear. Now, the importance of prehab. It is said that you need to really put in efforts in your prehabilitation program so that you get good post-op outcomes. So the time between your confirmed ligament tear and the revision surgery is really crucial. The rationale is simple. We need to maximize the function and health of your knee prior to your surgery. Now, prehab is not only a physiotherapist domain. There are multidisciplines involved in the prehab program. So one is your physical therapist, the other one is your sports nutritionist, if especially when an athlete is involved to look after the nutrition status of the individual. Then you have the sports psychologist or normal counselor. These people are essential, especially for the athlete, because it could be quite disturbing. One, when they have to plan, people have to plan another surgery. Already they've been through a lot previously, and then they have to go through another surgery. Second is, like I said, because the person may have to lose his tournament, which he is actually preparing for since years. So that is why it is a multidisciplinary approach. Along with the surgeon, you need to have a lot of people, the entire team, the entire sports medicine team, to get in and give a very good post-op outcome to the patient. Now, the goals of rehabilitation are primarily to reduce inflammation, that is your pain and swelling. So for pain and swelling, we usually use the cryopneumatic cuff, that is 3 to 4 times a day, say for about 15 to 20 minutes. We can use kinesio taping to reduce swelling, and you can use elevation, you can use a different pillow elevation, or you can just use some bolster elevation. So all of this will give you, and of course, along with anti-inflammatory medications that the concerned person has advised, all of this will help you in reducing the inflammation, which is really important for you to go in the next step of your prehab. The second thing is to improve the range of motion, primarily symmetrical knee extension. It is said that whatever knee range of motion you have before, especially in your knee extension, research has proven that probably you will get somewhere similar knee extension after your surgery. Then the third is you optimize your strength and develop neuromuscular control. Now, because you have an ACL tear, and because the ACL is primarily responsible for your proprioception, so automatically you start getting functional deficits in the knee and in the balancing ability, because your neuromuscular control has been lost because of your ACL tear. Fourth important thing is psychological and nutritional counseling. Fifth important thing is you have to normalize the gait pattern and improve the functional status. You normalize the gait pattern by looking for abnormalities. If it is a revision case, probably the person hasn't completely recovered from the first surgery, and there are some functional deficits he's carrying from that time. So you need to train all of these. Now, prehab specifications, what are the 4 important things that we look into before we start our prehab? One is it should be graft specific. Second, it should involve your health related physical fitness. It should involve your skill related physical fitness. And you should understand and take into account the reasons of previous failure. Now, graft specific, usually in revision cases, we go in for the central quadriceps tendon or the patella tendon bone harvest, and not really the hamstring graft. But there are certain cases where the hamstrings may also be preferred, the quadruple hamstring graft. So graft specificity is important, because if you already know that, okay, now I'll be taking the CQT or I'll be taking the PTB or the hamstring, you will automatically try to focus and strengthen those muscles more. You will try to maintain the extensibility of those muscles by doing soft tissue release techniques or some stretching exercises for that particular area. It is also proven that whenever you strengthen the muscle before you harvest the graft, the muscle quality is much better. So that is why your prehab should also take into account the graft specification. Secondly, your prehab should cover all the components of health related physical fitness. For cardiorespiratory endurance, you can do upper and lower body ergometry or simple walking. Then you look into the body composition of the individual. You have to keep the BMI in check. To keep the BMI in check, the person, if he is overweight, he may not be able to do a lot of exercises or a lot of weight bearing exercises or cardio exercises. So he better lose his weight with the help of a nutritionist or a dietitian. Third is you maintain the muscle strength or improve the strength in your hip, knee, ankle, and core musculature. And if you see any muscle atrophy, you can also use the blood flow restriction therapy, which puts less stress in terms of resistance on your muscle, but still gives you a good quality muscle bulk. The fourth important thing is your muscle endurance, wherein you do low resistance and more repetitions. And the fifth thing is you maintain the flexibility. Like I said, you know what graft is to be taken, where the tightness could be associated. So it is important in all our patients, we do make sure that we stretch their quadriceps, hamstrings, ITB, gluteus, calf, and the spinal musculature while they go in for their surgery. Then it should also involve your skill related physical fitness, because in your post-op outcomes there are so many patients who have recovered but they do not have an optimal functional recovery. So on clinical testing you may see that their knee is quite stable, but there is still some functional instability which comes because of lack of the skill related physical fitness. So you need to do agility, balance, coordination, and reaction time exercises. Now, again, agility does not mean that the person has to really run around. Everything has to be done in a very controlled environment, wearing the ACL brace. Balancing can be as simple as balancing on a stability trainer or doing a single leg stance or balancing on the BOSU. Coordination, simple exercises can be given like tandem standing, heel to knee, alternate leg raises, etc. And reaction time is you need to check and you need to train the hamstring reaction time to check for anterior tribal translation in your because of your quadriceps contraction. So at multiple angle you can give the hamstring contraction and you can give a visual or a verbal cue that quickly contract your muscle, quickly pull the knee inward. So while you slightly give an anterior translation or you replicate to give one. Now the role of bracing, most of the people that we see, they come in with a simple hinge knee brace for ACL, but what we recommend is that you wear an ACL brace which limits your anterior posterior translation as well as your mediolateral translation. Now this brace, the brace in the photograph is going to check for it has bells and attachments in the front and back, and it is designed in such a way that it is going to check your anterior tribal translation as well as give you rotational stability. So both your functions of the ACL are covered, that is the AP translation and the rotational translation. Now other methods that we use in the clinical setup are the blood flow restriction therapy, wherein you tie a pressure cuff and accordingly you manipulate the pressure. All these things are done under a controlled environment and you give low resistance. Second thing is if your quads are really inactive, you can use muscle stimulation along with movement. to do the activity of the quadriceps. Also, if the static contraction is poor, you may feel that the person is not really walking well. So you can use a pressure biofeedback as a visual feedback mechanism for the patients. Other creative things that we use are exergaming or virtual reality training. In fact, we've also done a study on virtual reality in post-op ACL cases, and it has definitely helped us to reduce the incidence of kinesiophobia and improve the athletic performance. So here is a case of a patient who has done her prehab with the brace on and in a controlled environment, and the next video will be her post-op outcome. So she's still doing the perturbation training. She's still doing it in a very controlled environment. We also gave her some strengthening gym program, but it wasn't a very heavy gym program. And everything was done with the brace being on. This is her post-op outcome at 4 months. So she is able to do bilateral knee extension, unilateral knee extension, hamstring curls, single leg hamstring curls as well. So we focus on the calf muscles. You see her posture and form is absolutely very good. That is because we've already trained her in her prehab. This is the glutes and abductor strengthening. So if you see her posture and her knee movements, they're quite smooth. They are non-jerky movements. So simple exercises like just crossing the hurdles without actually jumping on them. Then core exercises can be incorporated, especially for the lower abs, and simple coordinated exercises. So if the person is not able to do a full squat completely, you can do some resistive or body weight assisted squats as well. So the summary is that it is important that we utilize the crucial time period between our confirmed ligament tear and the surgery. And during this period, the focus should be on reducing the swelling, gaining full range of motion, building up strength, improving proprioception, and normalizing the gait pattern. The prehab program that we do, it definitely minimizes the effects of injury, and it ensures that you have a very good post-op recovery. And studies have demonstrated that the effects of prehabilitation were even sustained up to 12 weeks post-op. So it is very important. This is the take-home message, that whatever surgery it is, whenever possible, whenever it is safe, always do a prehabilitation program, especially in elective cases like a re-injury of the ACL. These are my references. Thank you very much.
Sorry. Yes. Any questions? So we have got a question from Dr. here, from Dr. Mahesh Javari. What is the sensitivity and the specificity of the grading system for the ACL injury? Question mark. What is the inter-rater and inter-rater reliability for Lockman test?
Hello, can you go again?
Yes, just be online, madam. Just be on. I'll be sending you. This is the question. Yes, this is the question.
What is the? So we really need to, I am not too sure of the exact number of the inter-rater and the intra-rater reliability, but it is definitely the most sensitive test out of your anterior draw test and the other test for your ACL ligament injuries. So the Lachman is definitely the most sensitive test. And for the exact numbers, there are different research articles which give you different inter-rater and intra-rater reliability. So I'll definitely go through the most recent one and get back.
Thank you. Thank you very much, madam. Any questions? Sorry. Any questions more? Thank you. Thank you very much, madam.
So
Thanks for
much.
sharing your tips with us. Looking forward to meet you again next time physical event in
Thank
2020.
you.
So now we ask Dr. Zalak Vaswada from BFit Health Studio from India to join the event. Hello. Yes, madam. Dr. Zalak Vaswada from India. So now we ask Dr. Rinkil Malani from MGM School of Physiotherapy to join the event, madam. Just we can replace her presentation. You can join the event, madam. You can start your presentation.
Should I start with the presentation?
Yes, madam.
Okay, just wait a minute.
Yes. Actually, Dr. Jolak was absent. Maybe she will join later on.
Hello everyone, greetings for the day. Myself, Dr. Wrinkle from India, Professor and Principal in MGM School of Physiotherapy. Today I'm going to give a brief overview on pain and metaphors, as it is more likely, like it is most of the conceptual framework kind of thing. So just having a great concept so that we can understand the basic pain plans and we can give a better treatment outputs also. So before proceeding to the concept part, I just wanted to let everyone know, like metaphors are considered as linguistic, but here we are not as a linguistic, we are the physical therapist and we have to work out on the pain kind of things, and pain is always nowadays it is considered as a complex multifactorial kind of. So we should not being a linguistic, rather than that we should be always go with the concept. So here the metaphor which are really related to pain that we are going to explore. Before proceeding to the metaphor, as pain and metaphor both are interlinked in this session, I just want a brief review on the pain. Why pain has come nowadays in more aversive way. So pain, actually the chronic pain is considered as a difficult to articulate, and many people said that it is not having a voice. That is why always the pain is described in terms of art, poetry and prose. And the basic reason, when you cannot describe certain things, you need some more of metaphors, you need some similes, you need some of stories kind of things, so make your patient understand. And now because of the complexity, this is very first time that IASP has changed his pain definition. From 1979 it was going on same, but on 16th July 2020, they have provided a recent definition, that is an unpleasant sensory and emotional experience associated with resembling that associated with actual or potential damage. So that has changed. Along with that, they also have provided a 6 keynotes with such definitions. That 6 keynotes are related to person feelings, perception, thoughts, past experiences, and some of the psychosocial domains. So the first step to take control of our pain is to understand. That is the basic concept. As being health professionals, we are treating the patients, we are treating many of the sufferers who are in chronic pain with actual or potential damage. So it's our role to make them understand. So we can correlate such kind of pain with one or other examples, but not always we can correlate with examples. So basically, first we have to understand why we are feeling the pain, or especially in this session, we are talking more about the chronic pain, because in acute there is a substantial damage of the tissues, but in chronic it may be or it may not be, it is actual or it is potential. So our brain, our CNS works like a central dispatcher. So if you can see here the three lights, if you block it, there is no dispatch. If you can make out allowing, it is dispatching to the many of the nerves. That is why whenever you go with like for example, if you go with the ankle sprain, or if you go with the you hit your thigh with a hard object and then you started feeling pain, and even a slight movement may increase your pain, though we are aware about that the slight touch or any movement which is really not having nociceptors, not or you can say non-nociceptive factors also may start dispatching a pain. First we have to control or we have to alter this. So when we, in cases of chronic pain, when we enter into this, we can create a overly sensitive alarm system. That is, it is always on guard. Whenever, like even a non-nociception, allodynia, you must have heard about. So this kind of small non-nociceptive things or feelings can create a pain. So this is termed as on guard, a oversensitive alarm system, which has created a disturbance or discrepancy at the CNS level. That is why many of the pain or chronic pain does not give a valuable or positive reports on diagnostic way. You find it there is no X-ray changes or minor MRI changes. So many of the diagnostic tests doesn't show why the pain is there. So it is a kind of invisible things. But invisible pain is really having a power to change your life. That is why in all these things, brain is mainly working as a connector mainly to the emotions, movements, thoughts, feelings, including the senses, to pain to create a memory of your painful event. I just give an example. If you tickle a child, then later on if you just wiggle your finger, a ticklish things may appear in front of a child and child starts laughing, though there is not a ticklish response, it's just a wiggling of the fingers. That is how our pain response occurs. There is no pain, there is no nociceptor in front of you, but the memory, the painful event, if it has come into your mind, the memory has recalled and you start feeling pain. This is how the pain has start working, and it has turned into the chronic and changes the life. Because of these all reasons, we should not ignore pain. We always have to keep check as an engine light in a car. And most important, it is like a computer. As we always reboot our system, we remove the old data, we remove the not required data through the mobile, through the computers. Our brain is also like that. We should reboot the brain, we should reset the brain, we should remove all the memories, past memories or painful events which are bombarding our central nervous system and creating a sensitization. In all these things, metaphors play a ray of sunshine where we can use such kind of terminology where we can make people understand about pain. Basically, pain or metaphor can be considered as a linguistic and can be defined as a directly equate something from one domain with something from another domain. So you just have to equate one or other domain and you just have to explain a patient. Like for example, petrol prices are skyrocketing. So petrol is not going into sky. It is just a metaphor we are giving in day-to-day life. Metaphors are the basically one which helping us to converse on a deeper level. You can go with a deeper discussion and you can explore from unfamiliar to familiar part so that everyone can understand this. That is why the primary and secondary metaphors have come out. A primary metaphor is providing a foundation where you can create a base, and on the basis of that you can create a secondary metaphor, and you can make arise of thoughts and feelings out of that. Just example, a primary metaphor is a love is a journey. There's many of, but according to the experiences of others' life, past experiences, present goings, so many of people can say it's been a bumpy road, it's a hell, or it's a highway to heaven, or it's a time to part ways. But our primary metaphor is a love is a journey, but the secondary metaphor has created from the thoughts, from the feeling, from the emotions of the person or the perception. So if we really think about it, we can use the metaphors to communicate our patient in terms of pain experiences. Our concept of pain is really not completed without metaphor, as there are many things like burning inside, body damage, tearing, ripping. Actually, these kind of things are not happening in our body, but whenever a patient or a sufferer comes to a clinic, they use such kind of thing. A vise on my head, or back pain is forever, a disembodiment. So we can use the same description from the patient, and we can convert that metaphors in more positive way. This is really one of the interesting slide. See, we always been taught via the metaphors, but we are really not aware about. We have been taught heart as a pump. Is it really heart as a pump? But the action is like a pump. The lock and key principle, the pain gate theory. Those who've been allowed, they will go up, not allowed, block. So it is like a large diameter and small diameter fibers. So actually from the beginning itself, we have been taught by the metaphors. Only thing is we are not aware about these are metaphors. So metaphors shape us and they give us the concepts all together, and they gives us a good story version. Everyone likes stories. Everyone wanted to be in that dilemmas kind of thing. Stories make patient understand better. And metaphorical fuzziness is it actually creating a conceptual view where we can link the metaphors from the dims to sims. It is been by the Lorimer Mosley, who has written a great book, Explain Pain. They really have mentioned 7 categories of danger in me and safety in me. Here, the session is more toward the pain and metaphor, so I'm not going to talk about more of the 7 categories, but we should know patient with the comes with a metaphor of DIMS, we have to convert that metaphor into a SIM. So this is like, if, for example, if I give the disc will slip if I bend over. This is a dim metaphor. How we will convert into SIM? I have enough to make a new life plans. Everything inside me is just falling apart, rather than we can say my body is like a well-oiled machine and motion is lotion. So these all are, both are the metaphors. One is towards danger, one is towards safety. So we always have to shift a dim via a sim. These are the metaphors we always encounter in day-to-day life. Time is money, my love is like fire, the clouds are balls of cotton, the lake is mirror of beauty, the leaves are a blanket covering the ground. So these all are the metaphors, and we always use in day-to-day life. For the clinical and for the patient's pain perceptions, there is a clinical classification of metaphors like structural, orientational, invasive, disembodiment, ontological, diagnostic, and prognostic. I'll just give a one review of it, and how patient will come with such specific kind of words and how we have to convert that metaphor. Structure is more related to an anatomical area. So they will give you a rich knowledge of a point. Like patient will come, I am having a pinched nerve, or my shoulder gets popped out. So this is actually good, because patient will tell you, or a sufferer will let you know where my area is actually getting affected. So you can go with a deeper analysis. So structural metaphors are the basic one. They will give you insight towards the diagnosis. In fact, they are good. So, but we always have to take care when a person comes with a metaphor, my muscles are knotted. So for that knotted, the type of sim, what you will use, rather than saying, okay, we'll stretch it, better you use, okay, let's work out how we can relax it. Because if anything is knotted, if there is a knot, if you stretch it, that becomes tighten. And if it becomes tightened, you cannot open it. And person came with a metaphor, I'm having a knot. If person will untangle that kind of things, okay, if they stretch it, my knot will get tightened, then what will be the future? So we always have to take care of the words, the linguistic aspect, the orientational metaphors. It is more related to space, direction, and movement. In this pain, patient complains like my pain is goes up, down, around the leg kind of things. But they are also helping in diagnosis, McKenzie aspect. It should be from peripheral to central. And if they are giving you like my pain is vague, my pain is in this going up, going down, then you can go to that specific area. You can identify that area, and that will help you in diagnosis. The metaphor what we can use is life turned upside down. So you can transform in up. Your life is upright and on track again. So they have given you the orientation, you give them same metaphor of orientation and more onto positive side. Invasive, they are actually more kind of invasion, like it's like a knife in me, it's like a pin in me, needles in me. So these metaphors we can reframe it. If sometimes say if it is a knife, then you have to, it's not a knife, it's a bit stiff and inflamed. Someone says I'm having a burning pain, it's not a burning. And if they will give you burning kind of thing, you will just target them more of the water associated imagery or hydrotherapy. When they will feel a water, the burning sensation may automatic releases. Disembodiment, so this is more like either more attachment or either more detachment. As you always have heard about phantom limb pain, so the limb is not there but person is feeling, that is a kind of more attachment. So like my arm doesn't feel like mine, I'm loving my leg again, I can't find my feet. So these are the dense embodiment metaphors. The next metaphor category is ontological. It is actually more related to feelings, thoughts, or expressions. This can be divided into journey and container. And actually, these ontological metaphors are very good because they will give you more towards the positive sims, that is safety in me. Journey and container metaphors are basically for the goal setting. If someone will come with a primary metaphor, so we can tell them wellness is a journey. Now it is how it is like that, it is up to them how the patient is or sufferer is taking that. So we have to create from the dims to sims, like okay, where can you plan your future, where your new flight plans, how the horizon looks alike. So these are the journey and container metaphors. Now, diagnostic metaphors, actually, we cannot create much of the sims out of the diagnostic because they will give you the freezing or they will give you the specific kind of diagnosis. Whiplash. If you go with the literal meaning, there is nothing kind of whiplash kind of. So if you go with the literal meaning, you will not find a diagnosis. Heel spur. It's actually a nail, but we are not finding a nail at the calcaneum area. So these diagnostic metaphors are actually unhelpful. They are actually incorrect. And this cannot be at the end be landed up with no further explanation. So diagnostic metaphors we have to convert. Actually, this has to be started from the clinicians rather than giving them more of the structural diagnosis, like you have a frozen shoulder, you have a heel spur. We should involve more of the biopsychosocial model so that we can give them a better output. Prognostic metaphors, they will suggest you the future course of the condition. I'm totally stuffed, that is a danger in me, I'm nothing, so I'm totally stuffed means that I can't move ahead. So you are cruising along nicely, so give them a way. So you give them, when you are giving them a way, it is like a you are cruising, so you are going very way along. So this is also one of the prognostic metaphor. I have got mom's knees. Mom's knees, like they're not feeling anything. So in the future they're saying, okay, my knees are not working. This is a kind of prognostic. So convert this prognosis into a good output. Now these all are the clinical classification of the metaphors. So how the concept of metaphors comes into that pain is, use that different types of metaphors, use that same subjective experience of a patient and use the same terminology and convert that danger into safety. Go with the proper discussion, go with the more of the conceptual, so that at least you can understand the patient's pain. And when once you start understanding what is the patient view towards the pain, you can really treat them well. So for the metaphors, we can say it can't be true or untrue. see, these all are the stories based, so you can create any of the stories, but they are good or bad. Along with the good or bad, it is also following the geographical constraint. So we always, like US people can use some different kind of metaphors because the population is different. Africans people, Indians people, according to the geographical location, we have to work out. Finally, why we are using them? Why we are using them? First is to make understand pain, and the diagnostic test is showing there's nothing wrong, so we have to tell them how sensitization works, how brain alarm is work, the use of the medication, because it is also having other negative effect towards the body. So metaphors are the one, they give you the picture, they give you the imagination, they give you overview, prognosis, good lifestyle. So if you really create a good metaphor, you become an Einstein, or really can create it like that. So this one very good metaphor of medication we can explain. There is a hot tub and there is a warm coat. So hot tub, you are using opioids, okay, they will act as a short talking immediate relief, but a large harmful effect. Long acting opioid, it is more like kind of, it's a warm coat, and you will get a better treatment. So, do you really feel that chronic pain needs metaphor with all these pain pictures, complexity, multifactorial? We can always say, because it is all subjective, geographical orientation, we really need a metaphors, region wise, regional wise, to explain patient to understand better about their pain. So, the artistry in all these things we should consider. We have to give them a literal explanation. Humor always helps. So you always give them a good example so that patient laughs also, and they can create their own stories, offer a deeper discussion, and they will give you the track kind of phenomena. And it is always better you give them a mind teasing, brain teasing kind of workout, puzzle, riddling. But at the same time, do not use the dustbin kind of metaphors, like learn to live with it, accept your pain, and don't be ageist. So always you have to show the dynamist kind of, you always have to be active. So this is all about the concept of the pain and metaphor. With all this session, I'm concluding my session with this takeaway message. Metaphors are actually the vehicles which are used to deliver a complex pain message to patients. So these are the metaphors which are helpful in our chronic pain patients, and we can use this as vehicles. And this is my conclusion of my session, that you can use metaphors according to your geography, according to location, according to patient perception, and you can really help out your patients. Thank you.
Yes, yes, ma'am. Thank you very much, ma'am. You have one question from Dr. Mahesh Javari, madam. You can read in the from the chat box. You can read from chat box.
Yeah. Do you think that fibromyalgia is considered as a bad diagnostic metaphor? Yeah. Why I'm saying that? Because fibromyalgia is considered as a psychosomatic disorder. So rather than we should consider them as a fibromyalgia, we cannot tell fibromyalgia as a psychosomatic disorder. And if you give them this kind of diagnosis, they cannot lead their life, because they will always try to find out the tender points. Okay, how many tender points I have? How many? What is my prognosis? What is my future? So that is actually considered as a bad diagnostic framework. Hopefully, I have answered you well.
Yes. You
Yeah.
have one more question, madam, from Dr. Tiwari. So
Yeah.
according to you, ma'am, it's a good or bad to use metaphors?
It is good metaphors, but it is a linguistic aspect very much. So you always have to be clear, be clear with your language, and language should be very considered, disciplined, and it should be very towards fruitful fragrance kind of.
Yes. Any
Yeah.
questions to Dr. Rinkel Malani? Yes, ma'am. You have got a comments from Dr. Sohail. Thank you. From Mahesh Javari. Thank you. From Dibro. Thank you.
Yeah.
Yeah.
Thank you so
Yeah.
much.
Thank you. Thank you very much, madam. We have enjoyed your speech. Pleased with your topic. Looking
Yeah.
forward to meet you again next time.
Thank you. Thank you so much. Yeah. Great.
Yes, yes, thank you. Now we ask Dr. Dipti Wadava from MBPS College of Physiotherapy from India to join the event and start presentation.
sir. Is my PPT available?
Yes, madam. Just you can enlarge your PPT.
Yeah.
Yes, it's fine.
Yeah. So, good evening, all. First of all, I would like to thank Inovine, Kevin sir, Madhu sir, and and it's my honor for me to present the review in front of one of my reference author, that is Dr. Manisha Rathi ma'am, present here for the conference. Good evening, ma'am, to you also. So, starting with my biography, I am myself Dr. Dipti Vadhwa. I am Assistant Professor at MVPS College of Physiotherapy Community Department, Nasik. Okay, I'm also a Sub-Coordinator of Indian Association of Physiotherapy Women's Cell, Nasik District. I'm Maharashtra Coordinator at Sarva, it's an NGO. I'm Certified Yoga Expert. I have done my practitioner courses. I have done publications. I'm reviewer of 2 journals and editor member of 1 journal. And I'm member of American Thoracic Society, professional member of Indian Yoga Association, Indian Association of Physiotherapists, Indian Red Cross Society, WICCI, European Association of Preventive Cardiology, European Society of Cardiology, Institute of Clinical Learning and Research. So today's topic, retro walking, a new approach towards rehab training for osteoarthritis knee, a review article. So starting with, everyone talks of arthritis, but considering its implication, no one wants to suffer from it. Arthritis Foundation of India has cited an interesting chalo chale come we will move test that most of us can understand. 4 simple questions are asked to the individual, and if answer to any one is yes, then it is the possibility that the individual is suffering from arthritis. These questions are: getting up from a seated position or standing for a long time while cooking, a painful experience; are climbing stairs and attending prayers meeting being avoided; and is going to family outcomes becoming more and more difficult. American College of Rheumatology Diagnostic and Therapeutic Committee defined OA as a heterogeneous group of conditions that led to joint symptoms and signs which are associated with defective integrity of articular cartilage, in addition to relative changes in underlying bone and at the joint margins. Exact cause of OA is not known. However, it is strongly believed that it occurs due to aging or wear and tear. According to Robert Salzer, normal joint with normal function will never have OA. Normal joint with abnormal function will have OA. An abnormal joint with normal function will have OA. Hence, it can be added that abnormal joint with abnormal function will have OA. Clinical features of OA are pain, stiffness, tenderness, swelling, crepitus, and loss of movement, deformity, and locking of the knee. Investigations for diagnosing OA knee includes knee radiograph, CT scan, MRI, arthroscopy, synovial fluid analysis. So there is an American College of Rheumatology classification. It is a clinical criteria by using history and physical examination. If the patient has pain in the knee plus 3 of the following. So the age can be 50 years, more than 50 years, less than 30 minutes of morning stiffness, crepitus on active motion, bony tenderness, bony enlargement, no palpable warmth on synovium. Same, using the history, physical examination, and laboratory findings, same 3 more is added, that is ESR, rheumatoid factor, and synovial fluid signs of OA. Okay. Next, as we know, the radiograph is very important for diagnosing of OA. So for diagnosing of OA radiograph, we use Calgaren's and Lawrence classification. So it is 5 points. So step 2 It is definite osteophytes and possible narrowing of joint space. So there are many treatments for OA knee, but the reference I have got from SM Khatri's book. So as we know, the OA knee is acute, subacute, and chronic phase. So different modalities, appliances, different types of movements and advices can be given to the patient who is suffering from OA. Yes. So coming to retro walking, whenever you encounter a difficult situation, stepping backward may boost your capability to deal with it effectively. It is written by Severin Coach. Retro walking is sometimes referred to as backward walking. It has been thought to be used already for several decades in Japan and Europe to get a physical workout, improve sports performance, promote balance, and also to stay mentally fit. Retro walking is a new approach in physiotherapy and rehabilitation. A greater than normal external knee adduction movement is present during walking in patients with knee OA. They walk with increased loads on the medial compartment of knee, and they exhibit a gait pattern with reduced walking velocity, cadence, and stride length, along with increase in stride time and double support time. This patient tend to decrease pain, reducing the knee extensor movement. So we have different references. So Dange et al. From previous research work, it stated numerous performance differences between retro walking against forward walking. Increased stride rate and with decreased stride length is the hallmark of retro walking. In this, toe heel contact pattern is seen, and knee acts as the primary power producer and ankle shock observer, and also the shear force is directed forward during retro walking, whereas backward and forward walking during the initial support phase, thereby decreasing the external compression load. We have the other reference, that is Gondalkar and Dio 2013 studied the effect of retro walking in addition to conventional exercise program in chronic knee OA. They included 3 sessions of retro walking per day for 3 weeks. Patient performed retro walking for 10 minutes per session on a flat surface with conventional treatment involving shortwave diathermy and free exercises. Retro walking as an agent for more was more effective in decreasing disability in knee OA patients than conventional therapy alone. However, pain reduction was seen equally in retro walking as well as in conventional therapy group. We have next reference by Shankar et al. 2013 investigated the effectiveness of retro walking in chronic knee OA. Subjects with grade 3 knee OA underwent retro walking on a treadmill with 15 degrees inclinations since they believed it increased the firing rate of hamstring and quadricep muscles. 1 session of 10 minutes of retro walking per day was given for a total of 10 days. They reported significant reduction in pain and disability, significant improvement in balance, along with time, speed, and distance of forward walking were also seen. Manisha Ratty ma'am et al. 2014 performed a study on subjects with grade 1 to 3 knee OA. They evaluated the effectiveness of 10 minutes retro walking program in combination with conventional therapy for a period of 2 weeks for 6 sessions. Retro walking combined with conventional physiotherapy treatment was effective in reducing pain and disability, and it also improved the quadricep strength. Somesh Shankar et al. 2015, they compared the combination of retro walking with TENS and ultrasound in patients with grade 2 chronic knee osteoarthritis. In both the groups, retro walking was performed on a plane surface in a straight line with great pace for 10 minutes with 3 sessions per day for 3 weeks. A combination of retro walking with ultrasound therapy to knee produced better results in terms of reduced pain, improved functional outcomes, and increased the knee range. Thus, retro walking, a new approach for rehab training for osteoarthritis knee, has numerous benefits, and it also improves the functional activity. So these are the references. Thank you.
Yes. Any questions to Dr. Deepthi Wadava? Yes. Thank you very much, madam, for your participating in this event. On behalf of Physiotherapy Congress 2020, I want to thank you for insight presentation. And also, we would like to inform that Dr. Deepthi Wadava was last year participant, which was held in Dubai 2019.
Yes, sir. Thank you so much, sir.
Yes, yes, ma'am. Yes. Now we ask Dr. Manisha Rathi from Dr. D.Y.L. Patel College of Physiotherapy from India to join the event and start presentation. Yes, madam, you can join.
Okay. Can you see this PPT? Yeah. Okay. The beginning, I just would like to say, Dr. Dipti, that it was good presentation and good to hear you from you that you have quoted my reference.
Thank you so much, ma'am.
Okay. Now, I would like to continue my presentation. It is on the Otago exercise program in elderly for strength, balance, and mobility. Myself, Dr. Manisha Rathi, working as a professor in Dr. D.Y. Patil College of Physiotherapy since 21 years. Over here, I am working. And this being a Pune city as an education hub in India, I would like really to tell you that our college, Dr. D.Y. Patil College of Physiotherapy, has a tremendous scope in the city of Pune. We have attached ourselves with Dr. D.Y. Patil Medical Hospital and Research Center, where more than 2,000 patients are admitted. And we have tremendous scope of research over here, and many patients are getting treated in OPD as well as IPD setup, and it is really a privilege to work in such a institute. I would like really to say thank you to all the management as well as people working in this college. Thank you. Okay, coming to my presentation, it is related to Otago exercises in elderly people. So worldwide, population of older adults increased due to socioeconomic development and better medical services. And that's why we all can see that in the next population over the 60 years, in next few years, by 2050, this population percentage is going to increase to 20%, and then we will be having really a tough time that time, because the aged people will be more at that time. And falls and unstable balance rank high amongst the serious clinical issues, and it constitutes almost two-thirds of the deaths in elderly, because it's not directly because of fall. If fall happens, there are many comorbid factors which are associated with the falls, and that can become the one of the reason for death in elderly. Study done by Dr. Joshi et al. In 2003, 51.5% subjects had fallen, out of which 21.3% had fracture and 79.6% had other injuries. So you can see other minor injuries. So 21 is a huge percentage where almost so many people are getting fracture. And it is observed that 29.4% fracture was observed in urban subjects and 13.4% of fractures observed in rural subjects. So urban population are more prone to develop fractures. So we need to concentrate that they should not develop fractures. And to prevent fractures, definitely we need to prevent falls in these people. So injury rate increases with age. For ages above 65, the rate of fall injuries was 47.7 per thousand population, and as the age advances, even this percentage will go up to 80 if the age of the person is going above 85. Then strong association is existed between the fear of falling and the measures of balance and mobility. because if you have fear and fear of falling, you will not be able to go out, you will not be socializing, you will not be doing some certain task which causes imbalance or which causes mobility. So they are very strongly associated. So more the fear and more the balance loss or mobility loss. So we have to work on fear of falling also. So, and general changes associated with ambulation due to aging are there is slower in velocity of the gait, increased time spent in double support, decreased step length and stride length, decreased cadence, heel off and arm swing decreases. So all these changes which are associated with aging occurs, they causes difficulty in the gait or difficulty in ambulation, and that's why there is a maximum gait speed declines. If you tell them to walk speedily, they will not be able to walk, or if you tell them they just some certain things have happened and they have to walk very fast or run from the situation, they will not be able to, because it declines very steeply than that of the normal speed of walking. So as the elderly ages, aerobics capacity, joint flexibility, muscle strength, bone mass decreases, and all these changes in the aging, they leads to changes in the ambulation, changes in the gait pattern, and that results to unstable gait pattern, and ultimately this becomes the one of the major cause of fall. Because many people, if you have seen, they are walking on a road and they suddenly get fall, or if they are in certain slippery areas, they are crossing, and because of this they fall down. So this is major reason for the fall in elderly. Apart from, there are many visual or vestibular changes which are responsible for fall. Then we need to tackle this fall, and that's why exercises has many beneficial physiological effects in older adults, including their effect on strength, aerobic capacity, flexibility, and bone strength. And there are many other effects I'm just talking about here related to the musculoskeletal management only. So there are many effects on cardiovascular and respiratory system, as well as the central nervous system. A comprehensive program of strengthening, balance, and or endurance training effectively reduces the fall and fall risk in older adults, and that is what we need to achieve here. Exercises alone are effective in reducing fall rates in older adults in community and subacute settings, whereas multifactorial interventions are more effective in long-term care settings. Traditionally, balance and lower extremity resistance training counters the age-related impairments in the neuromuscular and skeletal system, which contributes to an increased risk of falling. To maintain stability and balance, a complex mechanical neurological mechanism must work in synchrony, and that will lead to the stability and balance. Many health professionals educate older persons about how to prevent falls from happening by improving their synchrony in mechanical and neurological mechanisms. Advice recommends older people to attend exercise classes specifically such as Tai Chi, Pilates, Yoga, which is a complex phenomena to improve balance control. One of the very good exercise program, that is Otago exercise program, has encompass all these aspects, and that's why this is a new field of research and new field of program which you can implement for the older people. Otago was developed and tested by New Zealand Falls Prevention Research Group in New Zealand. It is a muscle strengthening and balance retraining program delivered at home by a physical therapist through a minimum of 7 home visits, as well as monthly phone calls when there is not a home visit over the course of a year. Because the Otago exercise program is such a simple and combination of many things together, is a program developed which you can perform at home very easily once you understand. So there is a time required to understand these exercise program, and then elderly people can practice all these exercises at home. So there is no need to come to a physical therapy department and then practice these exercise every day. They can do it at home also, and that is what is the main benefit of these exercise program. So Otago is one of the few fall prevention programs that improves strength, balance, and reduces falls and falls related injury among the older adults. So I have done a research using this Otago program on older population, and the results of this study I would like to put it over here. The objective for this research was, since older people require long-term care, preventing falls will help them to maintain their independence. Fall prevention program have potential to reduce hospital admission and long-term care cost, the major cost which is associated with fall injuries. So many fall prevention programs are implemented in communities without regards to evidences of its effectiveness. Otago has only been implemented on an individual basis in home settings, but its effectiveness in group is not yet proved, as well as adherence and long-term effect is less studied. Hence, our objective was to check the effectiveness of this program in improving the balance, strength, and gait speed in elderly in the long-term care settings. Nowadays, many people practice Otago exercises, and researches are also going on using this Otago exercise program in elderly. So in this experimental study, a randomized control trial, which we have conducted in D.Y. Patil College of Physiotherapy, we studied 30 participants at physiotherapy OPD of Dr. D.Y. Patil College of Physiotherapy, Pune. There was inclusion criteria to include in the study was persons having 60 years of age and above. Persons had fallen at least once in a past year because of the imbalance loss, and then person who can walk in their home independently with or without using any walking aid, and person with mini mental scale score of 24 and above are included in the study. And exclusion criteria: older adults who had fall due to syncope, vertigo, severely impaired vision were excluded. Disabilities in auditory sensation and vestibular organ were excluded. Neurological conditions like stroke, Parkinson's, and the fractures in the past year and severe deformities in the lower extremities were excluded from the study. And outcome measures we have considered here is 30 minutes 30 seconds chair to stand test, 4-stage balance test, timed up and go test, and 10 minutes walk test. These 4 tests we have used to find out whether they are improving their balance or not. And after these 4 tests of 4 weeks program, we have again took the feedback from all the participants regarding the adherence of the study. Now, how the study was going on: first, ethical approval was taken from Institutional Ethical Committee. Written informed consent was taken from all the participants who participated in the study. Screening for inclusion exclusion criteria were done, and 30 participants selected. Pre-assessment using all outcome measures were done. Random allocation of subjects in 2 groups, group 1 and 2, were done. 15 participants in each group, and interventions were given for 3 days per week to both groups. Duration total was 40 minutes. The intervention was for completely 8 weeks, 4 weeks under supervision, where 3 days per week they had come to the physiotherapy department, or physiotherapist had gone to their house, and the supervision was done in their home settings. And 4 weeks of training they did at home alone, with just follow up by phone calls. And the post assessment after 4 weeks and 8 weeks was done and then this is the exercise protocol which we have used. Group 1 experimental group Otago exercise program was given, where flexibility exercises, strengthening exercises, and balance exercises, which were quoted over here, were given. Group 2 control group intervention, it was a control group totally, and then participants who are doing all their activities were continued in this group. And then apart from that, their regular practice, Theraband exercises for hip flexors and all these exercises were given as a strengthening. Mobility exercises were also given, and balance exercises were given. So total of 40 minutes exercises were performed in control group. Precautions was taken during exercise was where they should wear appropriate footwear and clothing while doing exercises. They must drink water enough, so dehydration will be avoided. Pace out exercise session at regular intervals to avoid fatigue. avoid exercising in extreme temperatures, immediately stop exercise if they felt dizziness or lightheadedness, or there is a pain in lower limb, upper limb, or any kind of chest pain they develop during exercises. We stopped the exercises and that patient was terminated from the study protocol. Then they were informed that they should avoid exercising if they are having any kind of illness. And then progression was given every after 2 weeks for both the groups, and feedback was also taken at the end regarding the adherence of exercises at home. Then the analysis was done using 95% of confidence interval, and level of significance was kept at 0.05. Repeated measures of ANOVA was used to do the analysis, and this is the result: gender-wise distribution and mean age of both the group 1 and 2. Then when we studied 30 minutes, 30 seconds chair stand test, both groups showed improvement. You can see the parameters over here, how the improvement was shown. But group 1 showed, where the Otago exercises were given, that group showed significant improvement more than the group 2. 4-stage balance test. This was done pre and post, and post 4 weeks and post 8 weeks. And here also group 1 showed significant improvement in the 4-stage balance test parameters. 10 meters walk test was also improved, and gait speed was also improved a lot. Then coming to discussion, why there was so much of improvement observed. Performance on 30-second chair stand test, a measure of lower extremity strength, improved significantly with the use of single leg exercise using the ankle weights as resistance. The other researchers have demonstrated that targeted lower extremity training resulted in improved lower body strength. So when lower body strength is improved, definitely there is improvement in the other parameters also. So increase in strength and size were associated with the clinical significant improvement in gait speed, balance, and functional independence. The observed improvements in balance were likely attributed to specific exercise protocol. Balance activities which were given, including single leg standing, tandem walking, heel raise, and all these, which have contributed to a significant improvement in balance as measured by 4-stage balance test. A Cochrane review reported that multi-component group exercise, typically including resistance and balance training, reduced the rate of fall by 22% and fall risk by 70% in the adults aged 60 years and above. The Otago exercise program showed a significant increase in all these parameters in elderly, which are improved by backward walking. Now, just now, Dr. Dipti has already mentioned the effect of backward walking also. Hill to toe walking, stair climbing, and all these factors are important predictors or causes of falls in elderly, which are improved. Subjects worked on muscle tone and strength while walking, and in addition to this, though the stair walking and the subjects through the stair walking, the subjects practiced with fixed foot support, acceleration, balance control, extension, and contraction of lower limb and ankle dorsiflexion muscles, which is very important, and to move the center of gravity to control the efferent and contractions of the lower limb muscles, and that causes improvement in the balance. As a result, coordination, weight shifting were learned through a movement of the lower limb, and this improvement resulted in increase in the mobility or gait parameters. Thus, by improving the parameters, there can be reduction in the rates of falls amongst the elderly, and that's why Otago exercise program was found to be very effective in long term, and even adherence, which we observed with the feedback, was very positive, and elderly patients would like to perform these exercises even at home also regularly, and they find it very easy and convenient to perform at home. So coming to conclusion of my study concludes that Otago exercise program was effective effective in long-term care by improving strength, balance, and gait speed in elderly, and thus reducing the risk of fall in the elderly. It also concluded that adherence of these exercises was very good in the elderly. Limitations: it was a small sample size and unequal number of males and females were there in the study. Later on, further study can be done using these limitations, considering these limitations. And duration for intervention can be reduced. Now we have given 4 weeks. If under supervision, we can do supervision only for 2 weeks, and remaining further unsupervised training can be studied, so that we will come to know whether they can have a good adherence till there at that time also or not. Study can be conducted with some modification in the program with neurological condition like for Parkinson's disease or for stroke patients also. And the effect of exercise program can also be studied in various age groups separately, like for the age of 60 to 70 or 70 to 80 or 80 onwards also. Thank you very much. And I would like to say thank you to the conference organizers for giving me opportunity to share my views over here on this platform. Thank you very much.
Thank you very much. Any questions to Dr. Manisha Rathi? Any questions? Yeah.
Thank you so much.
Yeah, thank you very much, madam. We want to compliment on your topic. Thank you for sharing your tips with us. Looking forward to meet you again next time. So as due to currently internet problem to Dr. Julia Ramal from USA, she's unable to join the event. Maybe after 1 or 2 hours she may join the event. Just now we got information. So meanwhile we asked Dr. Mahesh Jawari from Sheikh Shakbat Medical City from UAE to join the event and start presentation.
Hello, everyone. I am very happy and pleased for the invitation. So basically, my name is Mais Jawhari. I work as a senior physical therapist in Sheikh Shakbout Medical City in United Arab Emirates. And I am a musculoskeletal outpatient physical therapist. Today, my presentation will be about the facts and myths pertaining to fibromyalgia. So basically, the first myth is that fibromyalgia does not exist. So many patients diagnosed with fibromyalgia by a rheumatologist or a pain medicine specialist report having another healthcare professional state that fibromyalgia does not exist. And basically, this is one of the most important obstacles that fibromyalgia patients perceive. Because if they will go, for example, to a neurosurgeon or to an orthopedic surgeon, and they are suffering from widespread musculoskeletal pain, and they are suffering and rooming for years, and they don't have a perfect label for their diagnosis, then they won't have a perfect management or a treatment. So to agree if fibromyalgia exists or does not exist, we need to differentiate between two symptoms. So is fibromyalgia a disease or a disorder? The disorder is used to imply the existence of clinically recognizable set of symptoms or behaviors associated in most cases with distress and interference with personal functions. In this context, fibromyalgia meets the criteria of a disorder. To understand the fibromyalgia disorder, we need to understand also a difference between two models used in medicine, biomedical or biopsychosocial approach. In the biomedical model in medical practice, diseases as a condition caused by external pathogens or disorder in the function of organs and body systems. If we will just think about fibromyalgia from this perspective as biomedical, then fibromyalgia does not exist because till now, we don't have an objective measures to say that fibromyalgia exists as a disease or a disorder. Objective findings such as laboratory tests, imaging, or pathology findings, all it will be normal or negative when we talk about fibromyalgia. At this time, the diagnosis of fibromyalgia cannot be based on an objective findings. As for most mental disorders, the diagnosis of fibromyalgia requires a history of a cluster of symptoms that define the disorder according to expert consensus and clinical studies. So basically, for fibromyalgia, for the diagnosis, a cluster of signs and symptoms should be observed within the patient. One of the most important signs or symptoms is the cognitive impairment fibromyalgia fog. What does that mean? Most of the patient will have difficulty in concentrating. They will have, for example, problems in recalling events or organizing their day. So they will tend to forget a lot. They will have different types of chronic headaches. Most of the time, they will have migraines. They can have cluster headaches or tension type headaches. They will have morning stiffness, but it doesn't really look like the morning stiffness associated with rheumatoid arthritis. They will have dizziness. Most of them, they will have insomnia. So when we will ask them about the quality of sleep they have, they will say that it's shallow, and they will have many nights, like sleepless nights. Regarding the 18 tender body points, this is incorrect. So basically, according to the latest criteria for the fibromyalgia diagnostic criteria, as per the American Rheumatology College of American Rheumatologists, there is no need to use the 18 tender body points for the diagnosis of fibromyalgia. And later on in my presentation, I will mention the differences, the huge difference that we saw in the epidemiology regarding the males and females ratio when we eliminated the 18 tender body points from the diagnostic criteria for the fibromyalgia. Most of fibromyalgia patients will have sensitivity to light and sound. They will have body aches, widespread musculoskeletal body pain, will have nausea, dry eyes, and other problems related to eyes, like they will have problems in actually seeing, so the functions for the eye. Of course, they will have an anxiety and depression, and that's why another myth from the fibromyalgia, it's that it's an covered depression. They will have weight gain, feeling cold. Fatigue is one of the most important signs of fibromyalgia. Blurry vision, as I mentioned earlier, chest pain, irritable bowel syndrome, and chronic headaches and muscular pain, as I mentioned. So again, going back to the first myth about fibromyalgia exists or does not exist, is it a pain or is it a disorder or is it a disease? We agreed that it is a disease, it's not a disorder. But what type of disorder? Actually, it's a pain disorder. So fibromyalgia is a disorder of central pain processing modulation that can no longer be categorized as a musculoskeletal disease process, but rather as a pain syndrome maintained by central nervous system activity. And this is why fibromyalgia is difficult to be diagnosed, because orthopedic surgeons, they're not trained to diagnose it. Rheumatologists should be trained in diagnosing fibromyalgia, but again, unfortunately, many rheumatologists, they do not believe that fibromyalgia exists because they think of it from the biomedical perspective, and because there is no objective findings for the fibromyalgia, so they don't believe on it. Again, in neurologists, they are not trained to diagnose fibromyalgia, or in neurosurgeons. So basically, I believe as a physical therapist, and we tend to see patients from different disciplines, like coming from orthopedic surgeons because they have, for example, shoulder pain, and from neurosurgeons because they have cervical spine pain and lumbar spine pain. And you will see this patient having a widespread musculoskeletal pain, so you can communicate the dots, and you can you can resolve the puzzle, and you can eventually diagnose patients with fibromyalgia. So pain isn't that simple. I will recall one of the very interesting presentations and talks today by Dr. Ackley, sorry if I pronounced the name by mistakenly, about the pain metaphors. So I will go in details about why using the fibromyalgia diagnosis is very important for those patients. But let's go back to the fact that fibromyalgia is a pain disorder. So pain, is it that simple? We now understand that pain is a very complex and highly sophisticated protective mechanism. It depends upon the brain evaluating a massive amount of information, including data from danger detection system, but also cognitive data such as expectations, previous exposure, culture, and social norms and beliefs. So chronic pain alone, as a solely chronic pain, is a very complicated and sophisticated problem. And all of us as a healthcare practitioners, we are facing problems in like diagnosing, treating, and evaluating or managing patients with the chronic pain. So can you imagine fibromyalgia when the chronic pain exists in multiple widespread musculoskeletal areas? Another myth about fibromyalgia is that fibromyalgia is a masked depression. No, it's not. Fibromyalgia is not a masked depression, but there is an overlap between depressive disorders and fibromyalgia. Actually, 40 to 80% of patients with fibromyalgia will suffer from depression or anxiety or other mental health disorders. So the association between fibromyalgia and depressive disorders can be explained by the symptom overlap, but we don't just like title or label patients with a depression with a fibromyalgia. There is a diagnostic criteria, and there is a way to differentiate between both of them. Fibromyalgia is a diagnosis of exclusion and requires tender point examination by a rheumatologist. Again, this is another myth about fibromyalgia. This is an outdated information about it. The clinical diagnosis of fibromyalgia should be made by the primary care physician, because the primary care physician is the first line who will see, examine, and diagnose the patient. So it's very important to train all primary care physicians about fibromyalgia diagnostic criteria, about signs and symptoms, about the fact that it is a disorder, it's not a disease, about the high complexity of the fibromyalgia disorder with multiple levels of signs and symptoms, including chronic headaches, irritable bowel syndromes, and the fact that 40 to 80% of fibromyalgia patients will be depressed and they will have other mental health issues. So we need to train the primary care physicians on how to diagnose fibromyalgia to save those patients from being rounding around and around for years without anybody diagnosing them and accordingly giving them the proper treatment plan. Although the tender point examination has been embedded in the culture of fibromyalgia diagnosis over the past 3 decades now, it's no longer accepted as a reliable clinical finding. So we need to change this. The 18 tender points is no longer a reliable and accepted clinical findings to diagnose fibromyalgia. Fibromyalgia remains a challenge for physicians, especially for general practitioners and psychiatrists. Lack of training about the fibromyalgia is often cited as the reason of uncertainty. The preliminary American College of Rheumatology in 2010 diagnostic criteria and the modified 2011 and 2012 criteria may be used to validate a clinical diagnosis for fibromyalgia. The 2016 revisions to the fibromyalgia diagnostic criteria fulfill the following points. There should be a generalized wide musculoskeletal pain, divided as a pain in at least 4 to 5 regions is present. The symptoms have been present at a similar level for at least 3 months. In reality, for example, the patients that I am seeing currently and diagnosing them with fibromyalgia, they are roaming around for minimum of 2 years. Most of them 10 years, 15 years, 20 years, roaming around between healthcare practitioners, orthopedic surgeons, and neurological doctors, and rheumatologists. And unfortunately, nobody diagnosed them with fibromyalgia, and eventually they did not receive the treatment or proper treatment plan for them. The widespread pain index should be more than 7. Excuse me? Is there any problem or shall I continue?
Yes, you can continue, madam.
Okay. Sorry, I want to ask you, my video is being shared or no?
You can share from your side.
Okay, so because I wanted to do that, but I don't know how. So how can I do that to share the video? Okay, anyways, I will continue. So basically, the diagnosis of fibromyalgia is valid irrespective of other diagnoses. This is a very important point because when, for example, I diagnose a patient with fibromyalgia, that doesn't mean that I exclude other issues or diagnoses that the patient is having. So the patient might have lumbar radiculopathy, greater trochanter bursitis, cervical radiculopathy, and above of that, they have the fibromyalgia. So we're not excluding any other diagnosis. A diagnosis of fibromyalgia does not exclude the presence of other clinically important illnesses. The 2016 fibromyalgia diagnostic criteria, first, the widespread pain index, WPI, and symptom severity score, SSS, the WPI should be more than 7, and the SSS should be equal or more than 5. And the WPI between 4 to 6, and the SSS symptom severity score more or equal than 9. Generalized pain in 4 out of 5 regions, symptoms present more or equal than 3 months. The fibromyalgia diagnosis can now be made irrespective of other diagnoses. You do not need to rule out all other conditions that could explain the symptoms if criteria 1, 3 are all met. The widespread pain index in the past week, where have you had your pain? The left upper region, it can be left jaw, shoulder girdle, left upper arm, left lower arm. The right upper region is the same. The axial region, that includes the spine, neck, chest, abdomen. The right lower region, the hip trochanter, basically the right lower region. Again, from my experience with the patient with fibromyalgia, most of the time they will have a shoulder problem like rotator cuff tendinopathy. They will have a cervical spine problem also, and like cervical radiculopathy radiating to the same arm that it has, the shoulder joint that it has the rotator cuff tendinopathy or a problem. Most of the time they will have bilateral sacroiliac joint tenderness or problem, dysfunction, bilateral greater trochanter bursitis, or issues in that area. So basically fibromyalgia is very complicated. The symptom severity score for each of the following for the past week, they need to rate it. If they 0 if they have no problem, 1 if they have slight or mild problem, often mild or intermittent, 2 for moderate considerable problem, and 3 for severe pervasive continuous life disturbing. And here is the summary and generalized pain and the symptom present. So this is the new fibromyalgia diagnostic criteria. The diagnosis used to require that there be no other diagnosis to explain the finding. This is no longer valid. So again, as I mentioned, fibromyalgia diagnosis can be done plus the other issues that the patients they are having. Patients are assessed by the widespread pain index, which divides the body into 19 regions and scores the number of regions reported as painful. That assesses severity of fatigue, unrefreshing sleep, and cognitive symptoms. So if you have a patient and you are expecting that the patient is a fibromyalgia, you can ask them these 3 questions. Then later on, you can go into details using the 2016 revisions of the fibromyalgia diagnostic criteria. Do you have fatigue? Do you wake like unrefreshed? Do you have a cognitive issues? And if they answered with yes, then you can go ahead and use the fibromyalgia diagnostic criteria. Another myth is that fibromyalgia is the diagnosis for middle-aged women. This is incorrect. Fibromyalgia can occur in all populations across the world and can affect all ages. So can you imagine how many male patients do we have suffering from fibromyalgia? But unfortunately, because we are just misled by this information, we're not able to diagnose them and we're not able to treat them. Also, fibromyalgia can affect children and kids, and this is very important. In clinical population, women between 40 and 60 years of age are the majority, with a female to male ratio 8 or 10 to 1. This is like based on 2013. But in the epidemiology studies that uses the 2011 criteria, diagnostic criteria for fibromyalgia, without the tender point examination, the 18 tender point examination, the female to male ratio is 1 to 2 females to 1 male. So it's almost equal that males can be diagnosed with fibromyalgia. The differences in gender ratios between clinical and epidemiological studies can be explained by several hypotheses. So, and the ACR 1990 classification criteria are used for diagnosis. A bias toward women is inherent by the tender point examination. In Western countries, women consult the healthcare system more frequently than men. So basically, if we eliminate the 18 tender point examination as a clinical finding for the diagnosis of fibromyalgia, then the percentage for fibromyalgia for like between the genders, it will be equal. And this is very important because it's actually not only in the Western countries, also in the Middle East, the males will tend to hide their problems, or they're not going, for example, to go to the physician and complain that they have pain here and there and everywhere. So basically also it's like a culture problem that we need to address. Our part as a healthcare practitioners is to change the culture, is to educate the people, because I'm very sure at this moment now we have many male patients with fibromyalgia undiagnosed, untreated, left alone because of these cultural issues. This is actually was my question to Dr. Ackley earlier today, that labeling patient with fibromyalgia is a bad metaphor. I agree and disagree, because we need to have the skill of breaking the news. So if I have a patient and I diagnosed her newly with fibromyalgia, it depends how I'm going to tell her that she has fibromyalgia. I am going to show her the 18 tender points, that this will just make her more worried or more helpless in her issue. So basically, labeling patients with fibromyalgia is very important, because those patients, they deserve to have a diagnosis. So eventually they will have a treatment. So concerns have been raised by a representative of psychiatry that fibromyalgia label has a disempowering effect of patient. Again, it's very important and crucial to train our healthcare practitioners or our primary care physicians on how they will break the news, how you're going to tell your patient that you have a fibromyalgia disorder, and how they can manage it. We need to use the good metaphors when we educate our patients. Now, regarding the fibromyalgia updated management, I am done with the myths and truth about it. What about the management? All recent guidelines stress the importance of the non-pharmacological therapies in the management of fibromyalgia. Aerobic exercises was the only treatment that received a strong recommendation by Euler. Here, I need to emphasize about when we prescribing the exercises for fibromyalgia patients, we need to be very careful, because these patients are super sensitive. And once they have the pain or feel the pain, it's really very difficult to stop it or change it. So basically we need to start low, go slow, mechanism with fibromyalgia patient when we educate them about starting their aerobic exercises. In the updated German guidelines, aerobic exercise and cognitive behavioral therapies received strong recommendation. The cognitive behavioral therapy will be done by a trained psychiatrist or psychological analyst, therapist or healthcare practitioner, alongside the aerobic exercises. Conclusion: the advancement in the field of fibromyalgia includes a biopsychosocial model of fibromyalgia that highlights the neurological underpinning of this condition and attributes importance to psychological factors, psychosocial factors in the predisposition, triggering, and chronification of fibromyalgia symptom. What does that mean? If you ask me, for example, now, what is fibromyalgia? I don't have a simple answer to that. It's a pain processing disorder, but it's highly triggered and affected by psychosocial factors. So many of my patients, they have, for example, a life-changing incident that triggered the fibromyalgia disorder or the widespread musculoskeletal pain. For example, some patients, her father died, her son died, her brother died, or there was a car accident, or her son died. So actually, it's not simple. but we need to take in consideration the psychosocial factors playing a predisposition and triggering role in the fibromyalgia symptoms. Interdisciplinary evidence-based guidelines that recommend screening for psychological distress and referral to a mental health care specialist in case of comorbid mental disorder. As I just mentioned, the psychological assessment and the treatment is the most important part of fibromyalgia assessment and management. Interdisciplinary evidence-based guidelines that promote non-pharmacological therapies, including aerobic exercises, cognitive behavioral therapies, and emphasize the need to reduce the over-medicalization of misery. So basically, my take-to-home messages that fibromyalgia do exist. Fibromyalgia is a disorder, not disease. Fibromyalgia is a neurological disorder related to pain modulation. The psychological factor is very important. The multidisciplinary team, interdisciplinary team is the most important factor in having a proper treatment plan. In Sheikh Shakhbout Medical City in UAE and Abu Dhabi, we have a team for the fibromyalgia led by a consultant rheumatologist, by myself as a physical therapist. We have an occupational therapist and psychological analyst. We all together together as a multidisciplinary team, work together in the sake of those fibromyalgia patients. Thank you so much, and I am happy to receive any question.
Any questions? Any questions to Dr. Mas Jawari? Any questions? Okay. Thank you very much, madam. We enjoyed your speech, pleased with your topic. And we would like to inform you that Dr. Mas Jawari was last year participant, which was held in Dubai 2019. And Dr. Mas Jawari was encouraging this kind of events for physiotherapy from initial onwards. Yeah, looking forward to meet you again next time, madam.
Yes, sure. It's my pleasure.
Yes, yes. Thank you. Thank you very much, madam. Now we ask Dr. Deborah Mazzarato from AIFI from Italy to join the event on start presentation. It's a workshop presentation. You have got a comments from Dr. Khadaka, excellent presentation.
You can hear me?
Yes, yes, madam.
Okay. So, okay. Welcome everybody, and thanks to be here. We will talk about the role of physiotherapists in the management of osteoarthritis. We will talk about the definition of osteoarthritis. We will see the clinical practice guideline for the surgical management of osteoarthritis of the knee in particular, guideline for the knee rehabilitation, and then at the end we will talk about the fast track technique, that is a new technique for the intervention of the knee or the hip. What is osteoarthritis? The term osteoarthritis includes a set of diseases that have in common.
Yes, excuse me, madam. Just you can upload your PPT, madam. PowerPoint presentation. We are unable to watch your.
You are unable to watch my presentation?
Yes, yes. Just you can share on the screen.
I'm sharing.
Yes. Yes.
Are you?
Yes,
you can see.
Yes, yes. You can continue. You can continue.
Okay. The term osteoarthritis includes a set of diseases that have in common an involvement of the synovial joints. This disease share common risk factors and characteristic pathological features in the affected joints, which, if severely involved,
Excuse me,
lead
madam.
to, yeah.
Just please share your PowerPoint presentation on the screen. We are unable to see the topic, what you're explaining.
You can't see my presentation?
Yes, yes, yes.
I try to share.
Just go to the share screen. Yeah, it's fine.
Okay.
From starting, you can start from starting onwards.
Starting to the
yes.
initial?
Introduction, from an introduction.
Okay. So we will talk about the role of physiotherapists in the management of osteoarthritis. We will talk about the definition of osteoarthritis, the clinical practice guideline for the surgical management of osteoarthritis of the knee, guideline for the knee rehabilitation in particular, and the fast track technique at the end. So what is osteoarthritis? The term osteoarthritis includes a set of diseases that have in common an involvement of the synovial joints. These diseases share common risk factors and characteristic pathological features in the affected joints, which, if severely involved, lead to radiological lesions commonly used to make a diagnosis. You can see there the radiological lesions. You can see in the knee, in the spine, with this, in the shoulder, with the reduction of the rime, and they use this radiological lesion to make a diagnosis. In some cases, osteoarthritis disease is clinically expressed, making it one of the most frequent causes of disturbance of the musculoskeletal system in the human. You can see there the clinical expression of osteoarthritis with swelling and deformation of the joints. Okay, the classification of osteoarthritis can be made in relation to the affected joints, for example, the hip or the knee, or in relation to the presence or absence of a predisposing disease. There are also clinical variants of osteoarthritis that can be primary generalized osteoarthritis, inflammatory erosive osteoarthritis, diffuse idiopathic skeletal hyperostosis, and patellar chondromalacia. We can see there what is osteoarthritis of the knee. Osteoarthritis of the knee is the most frequent joint disease and one of the most important causes of disability and pain. It involves the bone, the cartilage, ligaments, and muscles. And it is characterized by pain, swelling, rigidity, functional limitation, fear of movement, and reduced quality of life. Pain, so I can find my, okay. Pain and functional limitations are the most evident clinical manifestations. They may be morning stiffness, so morning stiffness or inactivity, even if, unlike rheumatoid arthritis, the morning stiffness or the arthritic patient is localized in the affected joints area. The diagnosis of osteoarthritis often comes to clinical evidence when pain occurs. In the initial stages, the pain is affected by mechanical factors. So we have joint distension of the capsula or the ligament, muscle spasm, periosteal pain, trabecular microfractures. Synovitis contributes to arthritic pain. People that have most probability of develop osteoarthritis of the knee usually have more than 25 years old, more than 50 years old, sorry, are women. They have had an important injury to the knee, and they are obese. An important thing is that not always the instrumental exams are associated with pain. Sometimes you have bad instrumental radiological exams, like the three we saw before, but you don't have pain. And sometimes you have a good radiological exam, but you have pain. So it's important in the diagnosis to see the radiological exam, but not always the instrument, but not only the instrumental exam. It's important also to see the clinical presentation of a patient. With the term osteoarthritis, so we define a degenerative, non-inflammatory pathology, disease of the articulation. In English of the articulation. Okay. That involve one or more articulation that has a chronic progressive way, and that has alterations about of the cartilage, of the bone, of the margini articolari. And there can be signs of inflammation. The term osteoarthritis is used usually in the Anglo-Saxon country because they want to underline the inflammatory components in the evolution of the arthrosic process. In Italy, we prefer utilize the term osteoarthrosis or arthrosis to not confound that with the arthrite rheumatoide or other form of arthritis. So osteoarthritis is a multifactorial disease where we have lesions of the cartilage and alteration of the pression of the synovia, articular capsula, and tessuto bone and the bone. So we can have in the osteoarthritis pain that can be mechanic pain that is more during physical or job activity, that it usually reduces with rests, is daily in the day, and it is worsened in the afternoon and in the night. And it is also a little inflammatory. Then we have a functional limitation that is in the initial phases of the disease linked to the pain, and is important when it involves the more important articulation that sustain our skeleton, that are hip and the knee. Another clinical feature is the articular rigidity that we can see in the morning, and it is not very long, and it disappears with movement. And the sensation of not be sure. So when you walk after a long period of rest, you see that you feel that your joint is not sure. Now we talk about the guideline for the management of the osteoarthritis of the knee, the surgical management of the osteoarthritis of the knee. They are from the American Academy of Orthopedic Surgeons, and they say, for example, that BMI is a risk factor. There are strong evidence that support that obese patients have less improvement in the outcome with total knee arthroplasty. Or there are limited evidence that supports that patients with depression or anxiety symptoms have less improvement in patient-reported outcome with total knee arthroplasty. Other things you can find, for example, is that the tourniquet in the intervention give strong evidence that the tourniquet used in the total knee arthroplasty increase short-term post-operative pain. Orthopedics use tourniquet, but it gives post-operative pain, gives increase short-term post-operative pain. We will see after that in the fast track technique, the orthopedics don't use the tourniquet usually. In this guideline, you can find surgical information for the surgical management of the knee osteoarthrosis, but also for the rehabilitation of the knee after total arthroplasty. You can see that there are, for example, strong evidence that supports that the continuous passive movement after knee arthroplasty does not improve the outcomes. We continues also in the clinic where I worked, we use the continuous passive motions, the kinetech, okay, which you puts the knee or the hip after the intervention. But there are strong evidence that the continuous passive motion does not improve outcomes. Instead, there are moderate evidence that supports that the rehabilitation started on the day of the total knee arthroplasty compared to the rehabilitation started on postoperative day 1 reduce pain and improves function. And in the fast track technique, we used to do rehabilitation in the first day after the day of the intervention. I have a video to share. In which we can see some exercises for the total knee replacement in the first 2 weeks after the intervention. You can see
I'm Brandon, physical therapist at Heartland Orthopedic Specialists, the Department of Douglas County Hospital. Today we're going to motion and reduce surgery. If at any point doing these with the physician,
okay, so sorry,
physical therapist, we're going to start by bringing the toes and the feet up towards the ceiling. Push the foot and the toes away from you.
So
and then repeat
the
at a nice
movement
quick pace to aid in increasing blood flow,
of the heel,
circulation, and helping to reduce your risk of blood clots.
quadricep exercise.
Directly underneath the knee. We want you to push down into the towel roll, tightening up your thigh muscle. Hold for 5 seconds. And after the 5 seconds, then relax.
We are able to watch your video, madam. Just you can upload your video.
You can see the video?
Yes, yes.
Okay.
Here we're going to start by squeezing your buttocks together. Squeeze nice and tight. Hold for 5 seconds.
Gluteus.
After 5 seconds, then relax. When you're doing this on a firm surface, you should see the hips coming up slightly off of the table.
Abduction and abduction of the hip.
Start off by first sliding over a little bit to give yourself adequate room on the bed. We're going to slide the leg out just as far as you're comfortable, and then slide the leg back in again, making sure that you keep both your knee and your foot pointing up towards the ceiling, not rotating out to the side. Just at a nice steady pace. You do not need to hold, just back and forth. If you have difficulty sliding the leg on the bed, place a plastic sheet, a sheet of cardboard, or a cookie sheet underneath your leg to help reduce the friction. Now we're going to slide our heel up towards the buttocks as far as what you're comfortable, and then slide back down, holding for 5 seconds when you get towards the top. Again, with this one, if you're having difficulty or there's too much friction on the bed sheet underneath the heel, feel free to put down a sheet of plastic, sheet of cardboard, or a cookie sheet. For the short arc quads, we're going to place a bolster underneath the knee. This is something that we're looking for about 6 to 8 inches in diameter. Things that you could use for this at home would include rolled up blankets, rolled up pillows, cylindrical Tupperware, coffee cans, anything that's approximately this size. We're going to keep the back of the knee on the bolster throughout the exercise. We're going to extend the knee, kicking your foot up towards the ceiling, tightening your thigh muscle, and holding for 5 seconds. For this exercise, we're going to have you scoot forward towards the front third of the chair.
Another
Then
exercise.
We're going to slide the surgical foot back as far as what you're able to bring it. Hold for 5 seconds. And then slide it back out, again holding for 5 seconds, and then repeating trying to go a little further each time.
Excuse me, madam?
If you're
Yes.
having difficulty,
Yes, we are unable to watch your video, what you are playing.
You are unable to watch?
Yes.
Oh. I try to share another one, but I don't know.
Okay, no problem. You can continue your talk. Just try once. Open with other media player. Just go
You
to the
can
option.
see?
No. Just we can see your only desktop. What all the
in helping to reduce your risk
You can see?
of blood clots.
Just you minimize the folder.
Sorry?
Just you minimize the folder. Just to minimize the folder.
You can see?
Just we can see only on the what all the documents you are having on the desktop only we can see. The folders we can see. We are unable to watch your video, what you are presenting.
Okay.
Just
I
close
don't
the
know why.
just close the folder. Just close the folder.
What is this folder? I don't know.
Just you go.
I can try with the other one.
Yes, you can try. Just open with media player instead of sharing screen. Just to go to with open with
Video
media
player. Okay.
Yes.
You can see?
No, madam. Just we can see only the documents on the screen. That's it.
What? I continue with the presentation. Maybe
Yes. You can go with the
give
presentation.
the. Okay.
Yes. Meanwhile, just you can share to email ID. So lastly, we can play for 10 minutes. You can send to
Okay.
me. You can send to my email ID. We'll play behalf of you.
Okay.
Just you can continue your talk. Meanwhile.
Sorry.
You can continue your talk.
Okay. Okay. Here I wanna make you see exercise, written exercise.
Yes.
You can see.
Yes, we can see the images. We can see the photos, pics of the yes.
So there are exercises for the hip. Okay. Supine exercise. If you wanna, you can make photo of these that are supine exercise after hip intervention and exercise on the healthy side for the hip always. So if you want to make photo, we have the position in which do the exercise and the execution. Then we have the sitting exercise, always after the hip intervention. If you want to make photo, or I can give you the document after.
Yes, yes, you can give your documents after the event. We can share to everybody.
Then there are the how many time I have? How much time I have?
You can continue for more 10 minutes, madam. You can continue for more 10.
Then we have the knee exercise for the knee after the prosthetic intervention. We have supine exercise and sitting exercise. I give you some seconds to make the photo. And that's all. You have it's written how to do and how to execute. So we come back to the presentation. So we talk about the guideline after total knee replacement. So what a physiotherapist have to do after when I have a patient that has a total knee replacement. What the guideline says to us. We have the NHS guidelines of England. I have decided to take them. The goals of the rehabilitation in the early stage after a knee intervention is to achieve 90 knee flexion and 0 knee extension, comparable to the preoperatory status. Because if a patient before the intervention flex the knee only 60, it's difficult to reach the 90, or if hasn't a complete extension is difficult to reach the complete extension in the first week. So we have always to ask what was the preoperatory status. Another goal is to be safe and independently mobile with an appropriate walking aid, the crutches or the ambulators, the rollators. I'd say in Italiano is deambulatore. To be able and safely to ascend and descend the stairs with an appropriate height if required. To be independent with the home exercise program that we will see in the video in some way.
Yes,
To understand.
Yes, you can share your videos to me so that we can share to all the participants after the
by email.
Yes, you can share me after the event, madam.
Okay, I finish this slide and I try.
Yes, you can share me after the event so that I can forward to everybody.
Okay, but the email, okay, the email, standard email, okay, I don't know. The goal are to understand self-management and monitoring, okay. And important restrictions are to do not use the pillow under the knee. Patients always use the pillow under the knee because they think, oh, no pain, I feel better, but in reality you lose the extension. So it's important not to use the pillow only under the knee, but under the whole leg. Ok, I try to condividere to share the video to you.
Yes. It's over. It's time up, madam.
Is
It's time up. Are you going to share the videos to me?
I try to share the video by the mail.
Okay.
We continue
Just
with
we'll do one thing.
presentation.
Madam. Meanwhile, yes. Meanwhile, we
So-
can go with other speaker. So we have more 4 talks. You can send to us the your videos to our email ID. So
After.
by end of this event, we'll try to share your videos to all the participants. Those are
Yes.
joined this event.
Yes. Okay.
Yes,
Perfect.
yes, ma'am. So
treatment for patients after the knee intervention. So pain relief, we have to ensure adequate analgesia, is nurse competencies, but we have to monitor this. Elevation, ensure elevation of the leg with foot higher than the waist, so the leg higher than the heart. Exercises for pain relief and for swelling management, but we can see after but we have this, that is kinesiotaping. You can use kinesiotaping for pain and for swelling management. Other exercise for circulation, the push with the foot and movement of the knee, so move in flexion and extension of the knee. Contraction of the quadriceps, co-contraction of the quadriceps and the hamstrings. Another way to do the treatment, we can do gait re-education, so re-education to the correct step. CPM, continuous passive movement, if indicated, so is indicated continuous passive movement or is not indicated. Guidelines says no. Sometimes people use always this. Education, teach to the patients how to monitor sensation, color, circulation, temperature, swelling, and advise what to do if concerned. Swelling management, teach protection, the protocols price, protection, rest, ice, compression, elevation, and mobility. Ensure that the patient is independent in the transfers and mobility with the appropriate heights. We can see there some exercise after that we can use after the total hip replacement. So you have hip abduction, quad sets to use the quadriceps, strict leg rise, terminal knee extension after the hip replacement, sideline hip abduction, the progress walking with supports with these system with the crutches at the parallel, and some exercise that you can do in the in this position. So at the end, what is a fast track? Fast track, I don't know if you have ever seen this, see this technique, but the obiettivo is to stay in the hospital for the bare minimum and immediately resume a normal life. These are the two main advantages of the fast track recovery, a new patient care model widespread in North America and in Northern Europe, and in some years also in Italy. For be precisely, here in Italy and in San Dona di Piave near Venice, we have this
more
technique.
5 minutes, madam. More
Sorry?
5 minutes. More 5 minutes.
Okay. We can, the characteristics are that it has a rapid surgical time, is safe and effective. We have staff training. Healthcare is it needs great teamwork, but it can optimize the hospitalization, reducing the costs. What is a fast track? With fast track recovery, we refer to a patient's care program created in the 90s by the Danish Celt, which promotes post-operative recovery. Technical and pharmacological measures are applied aimed at reducing bleeding, pain control, wound management, and patient education. Designed for general surgery, today is very popular in the international orthopedics and is finding more and more approval in Italy. The most appropriate application is in the prosthetic field, single compartment, two compartments, hip prosthesis, frequent intervention both in the public and private sector. How does it work? In practice, the fast track protocols is applied starting from the outpatient visit with an educational phase. So the patient in the first visit with the orthopedics is educated in this approach. It starts to do exercise before the intervention. Patient education, a key player, so the patient is a key player, the patient education is a key player in achieving the best results. Surgeon, anesthetist, rehabilitator illustrate all the details of their competence, underlying the advantages in the short, medium, and long term. The patient will arrive at the surgery, therefore, fully aware of each step that concerns him, more serene, with less anxiety, and more motivated for a prompt recovery. Intervention. The next phase is purely operative and consists of a series of therapeutic measures aimed at favoring early recovery. The anesthesia will be loco-regional, the bladder catheter will not be applied, the use of the tourniquet will be limited or avoided. A drug capable of limiting bleeding will be injected in 3 moments: before surgery, during, and at the end, in the case by intra-articular infiltration. During the surgery, the surgeon will practice an additional local anesthesia on the soft tissue periarticular. The surgery will be performed with a minimal invasive technique. This, however, doesn't not mean leaving the operating room with a small incision, but that your surgeon will have had the utmost respect for the soft tissue. Therefore, the disconnection of these structures, which is normal with other types of surgical hatches, will be avoided. At the end of the surgery, the anesthetist will practice a continuous infusion of painkillers, which will last about 24 hours. You leave the operating room with the operating limb inflection. The position allows for further reducing of bleeding and easier subsequent active mobilization. On the other hand, the classic drainage applies in the ordinary management regimen of the prosthetic patient will not be present. Bed rest after the surgery will be limited to 3 hours. Then, with the help of the physiotherapist, the patient will be put on his feet and help in the recovery walking without feeling pain. The day after the surgery, the patient will be instructed to ascend the stairs and will be able, really. So rehabilitation. After 5 total days of hospitalization, the patient will be discharged from the ward perfectly self-sufficient after 5 total days. The third and last phase of the fast track recovery corresponds to discharge, rehabilitation. So the physiotherapist will be of support as educator and supervisor, stimulating the recovery of the patients, also through an education and training work for family members and close people. Also, family members are important. Thanks for the attention, and this is my mail.
Yes, definitely. Thank you very much.
Okay.
Just meanwhile, you can share your videos, madam, so that we can just I can forward to Inovine conference. They'll be sharing officially to everybody your videos what you're having, as well as your PowerPoint presentation also.
Sorry, I don't understand.
You can share your videos to us. You can share your videos as well as your PPT PowerPoint presentation, so that I can forward to all the participants.
If I can share now my video
No,
or
after.
after?
After
Okay.
you can share afterwards.
I can share, yes.
Yes. Any questions to Dr. Deboro Mazarota? Any questions? Any questions?
If you have question, you can write me by the email.
Yes. We will forward to everybody, madam, your email ID. Thank you very much, madam. We have enjoyed your speech.
Thanks.
Yes. So, looking forward to meet you again next time. So now we ask Dr. Sergio Crescano from Samsung Strong MPRPS from USA to start the event with presentation. It's a company, it's a biotechnology company.
With that later. We'll actually, when we've got the presentation up, we'll just lower it, and it has many positions. It's a multifunctional rehabilitation device. Now, where's your presentation? Presentato?
Yes.
Okay. Is that visible to everyone? Can you see the presentation?
Yes, sir, it's going to open.
Great. Okay, then we'll start. I'm just going to move out of the screen, so hopefully you can see the device. Just he's going to show how it works. It's not that brilliant a picture, but that's the mobile phone interface. So now Sergey is just going to lower it into the bed position, but it has many positions, which you'll now see in the presentation. So I'll stay a little out of the way. Okay. Hang on. Oops, a daisy. There we go. So it's a totally pneumatic orthopedic medical care system, which is very compact. It packs down into an 11-kilo, very small suitcase. It's just been patented in the United States, but this process has been very long, the process of development, etc. The developers are in Russia, where actually we are now, but the actual company is based in Houston. So the MPRS is world-class, the world first for several reasons. And we believe that that's in the area of spinal health. It employs patented pneumatic levers, which are under all important parts of the body. And it's for the first time it allows purely pneumatically the ability to manipulate all areas of the spinal and muscular skeletal system in various areas, multiple areas, or in very specific areas. All right. I'm going to the next one. Here, you'll see there's the main controller, but it's obviously more convenient to control it by a mobile phone interface. Actually, we're very mindful of the header on your organizational website saying what are the, how do we deal with physiotherapy in the times of COVID? And we would like to think that this is one potential thing to look at, because it can be controlled from several meters away, as Sergey's doing, or from thousands of miles away by the internet interface. So that's just something to think about. So it means that that physicians, physiotherapists, or even family can remotely administer treatment. There's that shows the parts of the body that are being moved at the moment. Okay, so next part, all right. So it moves people into a variety of postures, and this can prevent a great deal of medical problems. It can be prophylactic, but it's also been shown to help in many medical areas. And the number of combinations are massive. Okay, yes, okay. Yes, I'm sure they can. I hope you can hear me okay, yeah? Sorry, I'm just to the edge of the screen. So it allows for the early mobilization of individuals, even if they're not conscious. So it can prevent the development of pressure sores and hypostatic pneumonia, for example, in long-term bedbound people, or those in hospitals or care homes. It can also reduce the workload on nurses and carers in enabling them to carry out medical procedures, sheet changing, bed baths, etc., with less physical effort. And I've just been reading in the United States how many nurses receive quite serious injuries in the course of their work by having to lift people, etc. You'll see, I think, later on in the presentation, and when we show you a little bit closer, the working example, the air tube cross sections, they can be removed in the relevant area to allow for the use of a bedpan when individuals are prone or sitting. Okay. So it moves the upper and lower limbs. You'll see in the pictures to the left that it can move the knee up the left, the right knee, and this prevents or helps prevent the paresis contractures and joint stiffness. So we believe also that in long-term bedbound people, there are pressure sore reducing beds, which a great many useful and good methodologies, but they can't use postural adjustment, which is the normal way. For example, when you're moving at night, when you're we also say that it facilitates the normalization of muscle and ligament movement in the spine and legs, helping to prevent muscle atrophy and promotes muscle recovery. Yeah. Well, no one does. So. Okay. Okay. Well, I hope they can. So, can I be heard? Okay. Is that okay? Can you hear me? Okay.
Yes. Yes. It's.
Oh, good. Good. We'll keep going. So now, in the background, you'll see that the MPRS is completely lowered. Sergey's getting onto it. And we'll give a brief demonstration just a little bit later. I hope we're still okay on time. So the methodology as well, it moves purely pneumatically. There's not a single piece of metal anywhere near it, okay, apart from the pumping box. So it moves the body in a pneumatically and smooth manner that mirrors the way that the body's own muscles move it. So this lowers the shear effect between the person's body and the bed surface, which is, again, a major surface of pressure ulcers. So it's partly comfort in the movement, but the shear effect is very important, especially in people, older people with compromised skin. It's modular in construction, which means that it can be adjusted to the length of a person, which is important so that you can position them on the pneumatic levers to get the maximum effect. And they can also be removed for repair. They can actually be removed without the need to deflate the bed, which is something I mentioned earlier. So if they're taken out for a bed panning requirement, they can be replaced later. The whole bed doesn't deflate. All the sections work independently of the other ones. Yeah, actually, you'll see a little bit better. This is how you'll see in the lower left picture. That's how the bed started when we just kicked off, and now it's gone down into the flat position. So you can see some of the pneumatic levers. They look like sausages, but they're not. They're multi-layered, and that's the only way the device can work, incidentally, and that's why it took so long to develop, because everything has to be very carefully controlled, and a sausage, simply one, wouldn't lift the heavy parts of the body, or any parts really of the body. So that's something important. You'll also see the head support. Actually, if Sergey can inflate that, which is also a pneumatic lever. What do you mean? The lever, okay. That's at the top, and that's another separate pneumatic lever. So we found that pressure management on the body helps respiratory function and blood and lymph circulation. And it's also very relaxing. It can be, the pneumatic levers are very strong. They have to be to lift some parts of the body, but there's also a relaxing kind of massaging effect from the cross sections. So it effectively means you can carry out passive motion exercises on very heavy parts of the torso and the legs, etc. In fact, you can actually see in the bottom right picture one of the many contortions of the device, which is the torso going one way and the legs going in a different direction, which is unusual. Some people have said, will people fall off? That's been a worry. And the answer is no. You'll see on the side here, quite large supports that stop that happening. So that pneumatic side supports. So they're always held securely, and even when the mattress is turned fully to the right or to the left. It's easily cleaned. We would recommend using an ozone chamber, but it's not totally necessary. We've taken off the cover here, just so you can show it in the working parts, but normally it will be covered. Everything works when it's covered. It's fabricated from ecological medical grade material. And yeah. Okay. So it has a number of set programs. Here's just an example of what? Shucks. Sorry, we missed that. Here we go. So this is in the area of the spine rehabilitation. So you can see raising, lowering, and deflection. These are using all the pneumatic levers in the area from the bottom upwards, as it were. So raising and lowering a deflection with rotation around the axis of the lumbar spine, gradual stretching between vertebrae with turns around the axis, L1, L2, L3, L3, L4, L4, L5, L5, D12. Raising, lowering a deflection with rotation around the axis of the pelvis. And by the way, this is where it's quite unusual, if we may say so, because these are not just airbags that lift people up. They're pneumatic levers, so they're completely controllable, and they can lift, say, from the waist up in totality, horizontally, and then drop the waist down, lower just one side of the waist, left or right, and then down the other way. And that's the same all the way up the spine, hence these combinations. So, so you can see the combinations there. So there's a good number of them. And we've had some, happy people on it. So here we go to the final slide. This shows you the portability of the device, and we don't have enough time to show you how it deflates. It inflates in about 5 minutes, straight out of the box. What you can see, that's literally everything you need. The power box or the pump box goes inside there, and the case acts as its own support, which you can't really see underneath here, but it's there. I think I've mentioned the control and the touchpad. The weight's very important because we believe that there's a great market for in its portability. Portability and also packability, so that if it's in someone's home, for example, it could be stacked away. It deflates in about 7 minutes, but it's very quick to do. The 12-volt power supply, we believe, is important because it could be anything from quality of life. If someone is even paralyzed and they want to be outside safely, that is possible with this device. So we hope that could be a quality of life issue as much as anything. And then also for emergency situations, etc. But I think that, the operating temperature range. But really, just to say, we believe that it's in the area of, we're very pleased to be here, in the area of physiotherapy rehabilitation, because we believe it has many applications that we've yet to find, and it's really for the professional community to let us know what the best options are. So if I may, if we've got 2 more minutes, or do we have a little bit of time? Just to ask. I was going to show now, just to, show Sergey on the device. I'll try and move this just so you can see. He's now going to, what are you going to do? There's the control panel. Okay. So, какое движение сейчас будет? Okay. Poise. Okay. So this is lifting. This is the pneumatic, the waist area. Okay. We still okay on time? Yeah, for a couple more minutes. Yeah. Okay. Okay. Sure. So now you can see. This is the waist being lifted up. It's going. Yeah. All right.
Опускаю левую сторону.
Okay, now it's going to drop down the waist on the left side. Which I think you can see happening.
Опускаю правую сторону.
Also, another important point, he's now letting down the right-hand side of the waist. It's very safe. It's not about to explode. It's working on 0.3 atmospheres, which is important to know.
Поднимаю только левую сторону.
No, why don't you go for the glute? Okay. Yes. Now he's now turning just lifting just the left side. Okay. And now spinal.
Вместе правую.
Spinal.
Сейчас.
Come on. There you go. Okay, he's doing the left and right lift together. Now, делай spin. Да? Можешь? Готов? Okay, now he's raising the spine. Okay, and we're not looking for effect.
Скажи, растягивается позвоночник постепенно.
So yes, this is stretching the spine in a very effective way. People have found it not uncomfortable. Может быть, в голове налево-направо.
Сейчас таз подниму еще.
Okay. Purple. Okay, now he's raising the bottom area. So this is getting pretty much the full stretching effect. Okay. There we go.
Поднимаем попу.
Okay, we've just done it. Okay, you're still going, yeah. Опускаешь.
Да, попу поднимаю, все.
Okay.
Говори.
Okay.
Вот, поднимается.
Okay, he's moving the derriere higher. Okay. So, я думаю, что все. Ладно, достаточно.
Да, и скажи, мы можем поднимать, опускать, крутить как угодно, как живой человек.
So Sergey's mentioning that the ability is, with all the pneumatic levers, to move people in a very lifelike way. Okay. There he is. And your head? Голова? Okay.
Скажи, любые части тела, все что угодно может двигаться, как живой человек. Скажи.
So yeah, I just said that. That's cool. So I think we'll stop there. Sergey.
Сейчас опустись.
Okay. Just he's gonna. So I think that's because obviously it takes a little bit of time to show everything, which we don't have time for. So we'll stop the demonstration there, or the presentation, and if anyone has any questions, we'd be pleased to hear them.
Yes, sir. You have got a question from Dr. Mahesh Jiwari, sir. Just you can read on comment box.
Hold on, sorry, I'm just trying to turn up the volume.
Do you recommend using the system for patients?
Hang on a second. I'm having trouble with volume. Hold on.
Yes,
I can't hear you very well. Hold a second.
Okay.
Sorry. So again, wait, I can't see properly. Volume. Звук. Just. I'm on Sergey's computer, so it's. Это презентация. Звук. Я.
Слышно нас?
Не, просто плохо слышно.
Нас плохо слышно?
Нет, я им плохо слышу. Сейчас,
пока,
1 second.
Не знаю пока.
Come on. Okay. Sorry, can you mention again? I'll get close to the screen. Because he's having trouble turning it. Wait a second. I think we can do it here. Sound, wait. No, he's got. Okay, can we go again? Может быть, отключим здесь. Все. Yeah, we can hear. Could we try? Could you mention that again? Your question?
Yes, sir. You can see from comment box, Doctor.
Say again?
You can read the question from chat box. From chat box.
Okay. So we'll read the chat box questions.
Yes.
Okay, thank you.
Sir, do you recommend using this system for patients in patent? Can it be used for their drainage?
Sorry, say again. I didn't quite hear you there. Sorry.
Do you recommend it using the system for patients in patent? Can it be used for way drainage? Can it be did the changing in the patient with vital signal? How much it cost? You can see the question from this chat box.
Yeah, we'll do the chat box. That's probably easier because it's difficult to hear for some reason. But
Yes.
Thank you very much for having us on. It's been very interesting. We'll listening to the presentations, and obviously we'll stay here.
Yes,
so thank you very much.
Okay, no.
Sergey, we just want to say 2 things quickly.
Yes. Yeah, no problem. You can take your own time.
Okay.
Значит, про нас через нас прошло 300 человек примерно.
About 300. Sergey's saying about 300 people have been treated on the device.
У всех были различные проблемы.
Everyone had different problems, etc.
Проблемы со спиной решались очень быстро.
We found that we could treat the spine, the problems, actually very effectively and very quickly with the device.
Нежное растяжение позвоночника позволяло делать чудеса.
So we had very good results from the smooth and soft movement, but well, I would say firm as well.
С первого сеанса получалось очень сильное облегчение. С первого раза получалось легко.
Often in just a session, we've had very good effects.
В течение пяти сеансов полностью вылечивалась боль.
And within 5 sessions, people feel a lot better.
За счет растяжения позвоночника.
Yeah. So again, we're working with the spine effectively. So yeah.
Кроме этого, мы заметили интересные изменения.
Also, we've seen some interesting effects.
У женщин месячные проходят раньше на 5 дней.
Periods have actually come in ladies 5 days earlier than usual.
Поэтому мы предполагаем, что за счет растяжения позвоночника можно лечить бесплодие. Предполагаем. Ну, мы думаем.
Okay. Well, we're still thinking about the effects of that. Okay.
Бесплодие лечить.
Бесплодие
не может родить.
So we're wondering whether or not that could be, we could look into that or someone could as possible effective treatment on infertility.
Да. При растяжении позвоночника усиливается кровоток и лимфоток.
Blood flow and lymph flow we've seen has improved significantly.
Вчера мы провели эксперимент.
And yesterday in Moscow,
и после сеанса сахар упал в 2 раза. Уровень сахара упал в 2 раза.
A diabetic was treated, and the blood flow was measured, or sugar content in the blood dropped significantly at 2 раза.
В 2 раза. Да.
Twice.
Стал нормальным.
Okay.
Скажи, стал нормальным, норма.
And it became normal.
Очень хорошо воздействует на снижается вес, может снижаться вес за 2 занятия на 1 килограмм.
Also, we found it effective in weight reduction because in a session reducing up to 1 kilogram.
Да. Происходят различные чудеса. Через нас прошло около 300 пациентов. И плюс еще мы заметили, есть такой психологический эффект.
There's also some positive psychological effects we've noticed.
Все пациенты очень хорошо спят.
Lots of patients sleep. We've noticed that.
Практически все пациенты, которые лежат на кровати, 90% засыпают на ней.
About 90% go to sleep during the procedure.
Вот, поэтому мы сделали кровать для того, чтобы любой физиотерапевт мог предложить свой вид движений, и мы могли бы совместно с ними
So
свой
our idea is to work with physiotherapists so that they could make recommendations, and through the device, the relevant treatments could be given.
Okay.
So, once again, thanks for having us on. Yes.
Yes. How much it costs, sir? How much cost of the equipment?
Сколько стоит? Мы не продаем, мы работаем только совместно.
We don't plan to sell it as such. We just plan to work with partners in its use. That's the idea, whether that's a franchise or joint businesses. Yeah.
Yes.
Я, предполагаю, что набор болезней, которые можно лечить, еще все не исследованы. За счет растяжения позвоночника огромное количество болезней можно лечить.
За того, что не может.
Да, потому что позвоночник, когда растягивается позвоночник, можно лечить очень много болезней.
Yes, so work with the spine, stretching the spine seems, well, there are other devices that could do it, but we found this to be very effective. So in terms of treating various medical conditions.
Yes.
Okay. Так что у нас есть желание взаимодействовать с физиотерапевтами любыми.
So yeah, we have a very, very big interest in working with the physiotherapeutic community and in the rehabilitation community.
Okay.
So thank you very much once again. And we'll look at the chat box. Okay, we know, we've already done that.
Any questions to Dr. Sergey Krasano? Any questions? No other.
So look at the chat box. That's fine. Thank you.
Yes. Thank you very much, sir. We enjoyed your speech as well as demo of the equipment that you are using, and supplement made by Samsung Strong MPRS. Sorry. So looking
Okay.
forward to meet you again next time with your
Okay, of course.
one of the exhibitor for the event. One of the exhibitor. If you attend as exhibitor, you can demo your product in front of the audience.
Yes, absolutely. It'll be a lot easier.
Yes, yes. Thank you very much.
We get on a plane with it very easily.
Yes. Now we asked Dr. Sergio Bernano from Argentina, Prospective Neuromuscular Facilitation from Association of Argentina, to join the event and start his presentation.
Okay. Thank you.
Все, thank you. Thank you.
Goodbye.
Bye-bye.
Выходим сейчас.
Сейчас. У нас сейчас отключат.
Okay.
Hello. Yeah, Dr. Sergio Bernino. Just you can enlarge your PPT, so that's fine, sir. Yes, you can start your presentation. Yes, sir, you can start your presentation. You can go ahead.
Please unmute your audio.
Tension out of there. Hello. Yes, sir, you can start your presentation.
Can you hear me?
Yes, sir. You can continue your talk.
Hello, everybody. First of all, I'd like to thank the organizer of the Congress for the possibility to share my experience in this field with all of you. So thanks. The aim of this conference is to introduce PNF concepts, its basic process, and its specific techniques as a different way of approaching the sensory motor system in the process of rehabilitation of athletes who have suffered an injury. PNF was developed by Dr. Herman Kabat and two physiotherapists, Margaret Knott and Dorothy Voss, in the 40s and in the 50s in US. While developing the concept, they observed athletes and workers under stressful performance, and they found out that their movement have special characteristics. The first things that they found was that movement happens in different joints at the same times, and that there were a lot of muscles acting together: agonists, antagonists, synergies, and stabilizers, all of them coordinated by the central nervous systems according to motor programs learned before. They realized that muscles work in pattern of movement, as you can see in this picture, not isolated. Another thing that they found was that this pattern of movement had a diagonal and spiral direction. Pay attention to this picture, and you can see clearly the direction of the movement, diagonal and spiral. It has a relationship with the anatomical characteristic of bones, joints, and muscles. All the muscles in our body have three components of movement, not only one, as we study in anatomy, three components of movement. Think, for instance, in the gluteus medius muscles. Gluteus medius is extensor, abductor, and rotator of the hip, and its antagonist muscles, psoas muscles, is flexor, adductor, and external rotator. So these muscles, when they have to contract maximally, they transmit to the movement this direction, diagonal and spiral. The author of PNF consider that rotation is the most important movement. Pay attention to this picture. You can see how much rotation is in the trunk, how much rotation is in the arms, and how much rotation is in the legs. Why rotation is important? Because it activates more motor units, which is very important in sport. Authors of the method study and systematized this pattern, and then they use them therapeutically. PNF consists of two different parts: basic processes and specific techniques. I'm going to talk about basic processes, and after that, I'm going to talk about specific techniques. Basic processes are maneuvers used by the physiotherapist to give a specific sensorial input to the central nervous system to regulate the movement. Basic processes depend on the physiotherapist, and the patient's collaboration is not necessary. There are a lot of basic processes. I will talk about some of them. The first basic process is the stretch of the muscles. In most of the movement in sports, maximum recruitment of muscle fibers is necessary. In this situation, muscles go from maximal stretch to maximal shortening. If you pay attention to this picture, on the left, the athlete is in complete extension. Because of that, muscles, flexor muscles, are stretched. So, as an elastic band, they are facilitated to contract. So, we can deduce that the stretch is an important proprioceptive stimulus. But how to get it in the practice? When you are stimulating a specific pattern of movements, the start position must make sure that all the muscles which are responsible of this pattern is stretched. For instance, if you want to make the pattern flexion, abduction, and external rotation of the shoulder, the start position must be in extension, adduction, and internal rotation. In this position, muscles which are responsible of the flexion, abduction, and external rotation are stretched, so they are facilitated to contract. Another basic process is manual contact. It's the use of the physiotherapist's hands to facilitate a specific pattern of movements. Manual contacts act on the exteroceptive and proprioceptive systems, giving sensory input to the central nervous system. The aim of manual contact is to guide the pattern of movement in the correct direction. We are talking here about spatial discrimination. This is important to make sure that muscles which are responsible of the pattern are maximally active. There are very specific areas of stimulation of each pattern of movement. Another basic process is verbal command. The verbal commands are the verbal inputs to promote a desired activity response. The voice intonation and intensity cause different response. For instance, a high voice stimulates facet muscle fibers. It is very similar to stress situation. And we can use this kind of verbal commands when we want the maximal response of the athletes. On the other hand, a low voice stimulates tonic muscle fibers. So we use this kind of verbal commands when we want to treat pain or we want to get stability. Another basic process is visual stimuli. The vision could be considered as an important sensorial reinforcement to facilitate movement and posture. Therapeutically, we can use visual stimuli to facilitate the learning process. For instance, in the first stage of rehabilitation of an athlete, and once the patient's conditions improve, we can challenge the patient to do without the visual control. Visual control helps to guide the movements. Eyes looking upwards facilitate the extension, like in this picture. Eyes looking downward facilitate the flexion, and eyes looking sideways facilitate the rotation. Resistance. Resistance is the manual resistance we offer to the movement. It is one of the most important basic processes because resistance is one of the most important basic processes because it is one of the three types of proprioceptions. Resistance increases the demand to the central nervous system. And because of that, will be more motor units active. This, in turn, generates neuroplasticity. Now, I'm talking about specific techniques. Specific techniques are maneuvers used to solve specific problems in the muscular functions, like strength, endurance, range of movements, relaxation, or coordination. Here is important the patient's collaboration. There are a lot of specific techniques, more or less 9 techniques, and I'm talking to some of them. The first technique is repeated contraction. This technique is based on the neurophysiological principle that repeated excitation of one nervous system channel facilitate the transmission of nerve impulse along the same channel. We can deduce that repetition is very important to learn a specific activity. The technique consists in performing a specific pattern of movements, again resistance, and several times. Now, I'm going to show you a video, and there you can see an example of this technique. As you can see, a pattern of movements, again resistance, and several contractions. You can repeat this technique several times. The aim of this technique is to get strength, range of movements, and endurance. Another technique is slow reversal. This technique is based on the successive induction principle, which was developed by Sherrington. According to this principle, when an antagonist muscle contracts, the agonist muscles is facilitated. The technique consists in an isotonic contraction of antagonist pattern, in general the stronger pattern, and immediately followed by an isotonic contraction of agonist pattern, generally the weaker. Now I will show you an example of that in a video. As you can see, we start by a pattern, the antagonist pattern. I change and the agonist pattern. The antagonist pattern, which facilitate the agonist pattern. Once, the antagonist pattern, which facilitate the agonist pattern. Two antagonist pattern. The aim of this technique is to get coordination. Another technique, rhythmic stabilization. Maybe the most important technique. Rhythmic stabilization is based on successive induction also, but in this case, the technique consists in an isometric contraction of the antagonist, the stronger, followed immediately by an isometric contraction of agonist, the weaker. Because of the isometric contraction, we can use to get co-contraction, so stability. The isometric contraction improves the local blood supply. And you can use this kind of technique in the first stage of the rehabilitation of athletes, where pain is present. Now, I will show you an example of this technique. We are talking about isometric contraction. Change my manual contacts. This is very important. I change my manual contacts, keeping the isometric contraction. Important true stability. Well, I would like to finish this conference with a conclusion. Proprioceptive and kinesthetic deficit are known to occur after certain type of injuries in athletes. PNF technique to correct these problems is a natural application. Finally, I would like to encourage to go deeper into PNF. You will achieve rewarding results with your patients.
Yes. Yes. Thank you, sir. Any questions? Any questions to Dr. Sergio Bernardo?
No questions.
No, sir. No questions. Thank you. Thank you very much, sir, for participating in this event. On behalf
Thank
of
you very much.
Yes, on behalf of organizing committee members of the Physiotherapy Congress 2020, I want to thank you for insight presentation. Looking forward to meet you again next time.
Excuse me.
Yes, looking forward to meet you again next time.
Thank you very much.
Yes, thank you very much, sir. Now we ask Dr. Sohail Mansoor Sohani from Iran University of Medical Sciences from Iran to join the event.
Hi everybody.
Yes.
Hi everybody.
Yes.
I'm Dr. Sohail Sohani from Iran University of Medical Sciences. I'm a physical therapist. I want to explain you an introduction to shockwave therapy and difference between focus shockwave and radial shockwave. I can't show you my slides.
You can share your slides.
Yes, I share it. Yes, I share it from my phone.
Just be on.
Okay.
Just be on.
But I can't share.
Yes, just be on.
I don't show, I don't see it. Okay.
So you don't hear your presentation on your.
Should okay. Okay. We know the shock wave is a longitudinal wave, like sound waves, but higher intensity. Can I show you my slide from my desktop of my smartphone?
Yes, just be online. I'll be sharing your slide.
Okay, I try it again. Now I open my slide on my phone. Why don't I can't show you?
ಟೆನ್ಷನ್ ಮಾಡ್ಕೊಂಡು ಟೆನ್ಷನ್ ಮಾಡ್ತಾರೆ ಕೊಂಚ Sir, just again. Sir, I'll be sharing your PPT. We have got your PPT.
Okay, I can't share
Yes,
with
yes.
my
Yeah.
screen, my
Yes.
smartphone screen, and
Yes.
from my
yes.
memory.
You can stop your sharing. I'll be sharing. I'll be sharing from our side. We have got your PPT.
Okay, I will explain you on the device, and
Yes.
I can't show
Yes, yes.
PPT. Okay, I start.
Yes, you can start your presentation.
Do you share my screen?
Yes, it's going to start. Sir.
Excuse me to spend your time. My title is the Therapy. You see my device. You see my device, extracorporal shockwave therapy, focus type, and the difference between focus shockwave and radial shockwave. We know shockwave is a wave, longitudinal wave, and like ultrasound, but higher energy, 50 to 100 bar in a nanosecond time, very short time. Every beat of shockwave, time peak, the first part is a higher part in a nanosecond, positive wave, and after that, a line time in millisecond with low level energy. Shockwave, similar longitudinal wave, need to transport material and from the applicator to the body needs to gel to transport. Yes. Thank you. Thank you. Please show the second slide. Shockwave are mechanical wave and sound wave require an elastic medium for propagation. In this slide, you see simulation of shockwave therapy production and transportation, but it's simulated. Please show the next slide. Thank you. Biological effect of shockwave are a simulation of micro circulation, blood and lymph, and metabolism, nitric oxide, vasodilation, of oxidative stress enzymes, mechanotransduction, means cell matrix stimulation, increase of cell wall permeability, metabolism, release of substance P, antibacterial and anti-inflammatory effect, stimulation of growth factors, neogenesis of vessels, bones, and collagen, especially in focus endorphins and serotonin release, acceleration of substance P washout. Please, next slide. Contraindication of shock waves, hemophilia, use of anticoagulant, thrombosis, tumor disease, pregnancy, children in growth, especially growth plates, cortisone therapy up to 6 weeks before first extracorporeal shockwave treatment. And side effects of shockwave, especially in radial shockwave, are swelling, reddening, hematome, petechiae, pain, and skin lesion, especially in previous corticosteroid therapy. Please, next slide. We use traditional two types of shockwave. Focus shockwave means higher energy density, and radial shockwave for lower energy density. Please, next slide. The level of energy, low level, high energy, we use shockwave therapy for wound healing, cell regeneration, focus type to 0.4 millijoule per millimeter cube per millimeter square for pain therapy, radial and focus shockwave to 0.6 millijoule per millimeter square, and aesthetic, non-union, or lithotripsy up to 4 millijoule per millimeter square energy flow density. Please, next slide. In this slide, animated radial shockwave application for shoulder pain. Please play it. Radial shockwave frequency from 1 to 21 Hertz, energy range from 1 to 5 bar, and pulse transmitter multiple. And radial shockwave, a slow pulse, low energy, and superficial. Please, next slide. You see in this slide, radial shockwave therapy, focus shockwave therapy for bicipital tendinopathy, animated. Please play it. You see production of focus shockwave and propagated in the tissue and concentrated in bicipital tendon insertion to ulnar tubercle. Please, next slide. Focus shockwave frequency range from 1 to 8 Hertz. Energy level range from 0.01 to 0.55 millijoule per millimeter square. Energy level range from 0.01 to 1.24 millijoule per millimeter square, and penetration depths range from 15 to 50 millimeter. And we told you focus shockwave are fast pulse, high energy, and deep. Please, next slide. You see this slide, comparison of penetration depths between focus and radial shockwave. You see two upper type of radial shockwave, focus shockwave without a standoff up to 50 millimeter or 5 centimeter, and a standoff with a standoff to penetration depths decrease to 1 centimeter or 10 millimeter. But in radial shockwave, deep impact, effective penetration depths to 30 millimeter or 3 centimeter, and radial shockwave with a standard transmitter 10 millimeter or 1 centimeter penetration depths. Please, next slide. We show you a range of focus and radial applicator types. Upper part, focus shockwave, and lower part, radial shockwave type of applicators. Please, next slide. Shockwave indications in different fields in medical. For example, in orthopedic, combined radial and focus shockwave for Achillodynia, plantar fasciitis, metatarsalgia, tibial stress syndrome, patellar tendinitis, trochanteric tendinopathy, calcific tendinitis, radial or ulnar epicondylitis, and trigger points. Aesthetic shockwave, we use combined radial and focus shockwave for anticellulitis treatment, body shaping, tissue tightening, scar and wrinkle smoothing, skin elasticity improvement, connective tissue tightening, treatment of pregnancy stretch marks, and treatment of skin irregularity after liposuction. Dermatologists use only focus shockwave for non-healing wound, diabetic gangrene, diabetic ulcer, non-diabetic ulcer, and skin burns, and urologists use focus treatment for IPP, Peyronie disease, CPPS, chronic pelvic pain syndrome, and ED, erectile dysfunction. Please, next slide. In this slide, I show you an example, one session treatment for combined shockwave therapy, for example, in impingement syndrome. In one session, step 1, we use focus shockwave with no standoff first or standoff 2, parameter 1 to 8 Hertz frequency, and energy density range from 0.01 to 0.35 millijoule per millimeter square, and number of shock in first session 500, 200 to 500. And next step, in same session, we use radial shockwave transmitter type and parameters, frequency 15 to 21 Hertz, intensity 1 to 30.5 bar, and number of shock 2000 to 4000. And the last step of first session treatment, use Viactor parameter 25 to 35 Hertz, 2 to 3 bar, intensity and number of shocks 5,000 to 10,000 number. Please, next slide. And in urology, treatment step of focus shockwave therapy, the urologist can use focus shockwave for CPPS, erectile dysfunction, and Peyronie disease. As you see in a slide, for example, a standoff 2, parameter 6 Hertz, and energy density 0.2 to 0.3 millijoule per millimeter square, number of shock 3000. Please, next slide. In the slide, I show you the efficacy and safety of extracorporeal shockwave therapy for orthopedic condition, a systematic review on studies listed in the PEDRO database, published in British Medical Bulletin 2015, reported us shockwave, extracorporeal shockwave therapy is effective and safe, and for certain orthopedic condition based on RCTs is more effective. There was no difference in quality between two types of shockwave. Application of local anesthetic adversely affect outcome extracorporeal shockwave. We should not use anesthetic before shockwave. Application of insufficient energy adversely affect outcome extracorporeal shockwave. No scientific evidence in favor of either radial shockwave or focused shockwave with respect to treatment outcome. This distinct between radial shockwave and focused shockwave is not correct and should be abandoned. And there is no scientific evidence that a certain focused shockwave technology is superior to other technologies. And an optimum treatment protocol for extracorporeal shockwave appears to be 3 treatment sessions at 1 week interval with 2000 impulse per session and the higher energy fluid density that can be applied. I finish my lecture and thank you all. I show my technology, focus shockwave, use my clinic.
Yes, sir. So, any questions? Any questions to Dr. Sohail?
Thank you, sir.
Thank you. Thank you very much, sir, for participating in
Bye.
this event.
Bye.
Hope we expect your presentation next time also. The last of the talk. Now we invite Dr. Tajawuddin Chitrapuri from MGM School of Physiotherapy of India to join the event, sir.
Hello.
Yes, sir.
Yeah, am I audible?
Yes, sir.
Yeah.
You can share your PPT, sir. Yes.
Hello.
Yes, yes.
Yes, it is visible.
Yes, sir.
Yeah, yeah. First of all, I thanks Invites to invite me as a speaker. For today's topic for my speak is communication skill in healthcare professions. Actually, it is very apart from therapy or the technical, it is a soft skill which most of the clinician and the therapist is not focusing. So this is basically the objective for the today's talk will be the define and methods of the communication, the different communication models and the communication process and its elements, and what are the obstacles for the effective communication, what are the verbal non-verbal communication, And at the last, we'll see the therapeutic communication and understand the communication skill in healthcare practitioners. So this is the overview of the today's talk on my communication skill. So communication is a series of experience which in terms of speaking, writing, smell, body language, touch, seeing, hearing, all are these other different aspects of the communication which give certain command or certain instruction to the sender from the receiver. Okay. So what is the communication skill? It is mainly the information sharing, understanding. Once you are educating the patient, once you are telling to the patient that you're something, share your knowledge to the patient. Patient is coming to you as a he is demanding, he is in pain or whatever patient is expecting from as a healthcare practitioner. So he's coming to you. So the as a healthcare practitioners, we are sharing our knowledge to that patient according to the problems. So it can be, the communication can be verbal and non-verbal both. In a physiotherapy or the physical therapist, is most important to see the non-verbal things as well, and the verbal is mainly the your history taking. So communication is a circular flow and it is goal oriented. What exactly patient demands to you and what exactly you are delivering to the patient, it should be have some goal. It involves changes in the behavior. After giving the instruction to the patient, patient should demonstrate some technique, patient should educate, or patient should tell you that I understood the thing. So this changes, or whether it is a temporary or a long-term behavior changes. So it involves the changes in the behavior. It means to influence the others. It is a tool for controlling and motivating people. So it is a very strong skill to someone to influence or someone to give a motivational talk or speak something. Expression of thoughts and emotions through the words and the actions. Okay. So these are the communication. Then major part of the communication skill is the listening. Listening is a major accounts. Then comes your speaking, then reading and writing. So who are the healthcare practitioners who listen to the patient? They will more have rapport, or they will have more elaborative knowledge towards the patient, and the patient will have more comfortably explain or give psychosocial domain to that particular healthcare practitioner. So levels of the communication, mainly it is based on channel. It can be verbal, non-verbal, visual, or based on the purpose, formal or informal. So mainly in our physical therapies, we have the verbal and non-verbal. Then verbal is mainly the intonation of the words or the oral communication with the patient is telling as per the history or the subjective examination, you can say. The extra verbal, the written communication, the reports or the anything which patient is giving, or the charting or the documentation from the previous healthcare practitioners which showing to you. And non-verbal is the gesture, posture and body language, movement, paralanguage, and at the last symbolic signs language. So these are the levels of the communication during the healthcare practitioners and the patient share with each other. So there are different communication models. In previously, what exactly the communication between the healthcare practitioner and the patient, one should understand what the therapist or the doctor is telling to the patient, and the patient also demands from the healthcare practitioner what are the complaint I am telling to the healthcare practitioner. The practitioner should understand. So this is a coding and decoding between the sender and receiver. We say 100% effective communication when the receiver understands complete sending information by the sender. So there are different models. Previously, the first model is Shannon and Weaver model, which is a one way of the communication between the people. It action or the message transfer. Source encoded a message to the send throughout the channel, through the channel, where it's decoded by the receiver, and there is a no feedback from the receiver end. So once it is delivered, the message is delivered to the sender, it is up to the sender whether it is received or not, and it is up to the sender what he want to interpret from that message. So this has some disadvantage. It involves like no face-to-face interactions. It works on telephone and internet. Non-verbal communication is not observable because the sender is sending the message, or you can say example like if it's a physical therapist, if you want to send image or the text of the demonstrating the exercise without giving an instruction on that image, so patient may get confused. So there is a doesn't account for the feedback from the patient side. Imagination for different peoples are the different. Patient may get different imagination for the pictures or the text, whatever you want to send or you have sent to the patient. So second model comes into the picture. This is called interactive model. It is a two-way communication where the message exchange between the sender and receiver. But in this, the receiver gives the feedback. Feedback can be verbally or non-verbally. So after sending a message from the sender to the receiver will give the positive feedback or negative feedback, whether the patient is understand your language or patient is understanding what exactly you want to deliver. So this is called interactive model. And the third model is called transactional model, where the receiver also plays a sender role. So it is a two-way communication and simultaneous communication between the sender and receiver. After receiving the information, patient also educate or patient also tells to the healthcare practitioner and sending the information rather than giving a feedback. Along with the feedback, patient is also giving extra information to the therapist or the healthcare practitioner. So this transactional model viewed as the most realistic model, which helps to build a rapport between the healthcare practitioners and the patient, or you can say between two people. Okay. So a continuous transactional process involving a participant operating within the specific context, whether they create relationship between by simultaneously sending and receiving the message by channel, many of which are distorted by the noise. So both the sides play a role as a sender and receiver. So Paul has said the one cannot not communicate. Even if you're not communicating to the therapist, or if you're not telling or giving command, or you're sitting silently, that also giving a gesture or body language, which is somewhere it is a feedback to the sender. Whether you are happy, you're not happy, you are agreeing or disagreeing. So this is a transactional model which gives both way of communication, which is most realistic. So the communication process may involve what I mean, that messenger has sent the information, the receiver or the receiver should understand what exactly the message is. So it is called effective communication. The receiver meaning divided by the sender meaning is equal to 1, which is a complete communication between the sender and receiver. So what is its process? It is very simple. When the sender is sending the information through the channel, after receiving the information, the receiver will decode the information and giving the feedback through the same channel or different channel to the sender. So it is a closed loop and the feedback will play more important role in this. And the barriers and the noise also plays which obstacle from the sender side or the receiver side, which hamper the effective communication. So what are the obstacles or the barrier to the communication? Anything that inhibits the effective communication can labeled as a noise, inappropriate medium, you can say, or assumption or misconceptions or emotions, or there are the language differences from the region to region. Poor listening skills, as I said in previously, the listening accounts for 45-43%, which is a major chunk of the communication. To have the effective communication, one should have the good listening capability. So both the sender side and the receiver side, there should be a good listening and distraction from the noise or anything which distract from the delivering or receiving the message. So what is the verbal communication? Verbal communication mainly coming from the tone, words, empathy or paraphrase. Use of the spoken words and sound to successfully transfer a message from a sender to a receiver. So it is mainly the purpose of using clear language for effective communication with the patients. When you're asking or you're delivering the patient, the content or the goal should be clear from your side. Whether you want to educate the patient, whether you want to tell the patient, whether you want to incorporate any exercises, or whether you want to give intervention. So this has to be clear from the therapist or the healthcare practitioners while delivering the content verbally to that patient. Then only the patient will get understand. And the second most important in verbal communication is choice of word. You know the famous movie in 3 Idiots, the Chatur's speech. His speech, what wrong in this speech is he used the wrong words in the speech. So the selection of the word which educate the patient, which encourage the patient, which gives the reassurance from the therapist or the healthcare practitioners is most important. We should not discourage the patient. Of course, the truth is truth. We can't change the if the patient is diagnosed as cancer, so we can't change the diagnosis, but we can sure and giving the empathy with right words, which is also important to help an effective outcome in the patient. So say third most important in delivering the speech or the delivering the verbal command, it is the grammar. How you are using language. There are certain language barriers of the grammar from the region to region in India and outside of the India. So that most important there they are. So the right grammar speaking is also most important to have an effective communication between the two peoples or the healthcare practitioner and the patients. And of course the pronunciation of the words, how you are pronouncing the word, that also affects. If you're giving more focus on that pronunciation, you want to give feedback verbally, that you need to pronounce correctly and guide the patient in the right direction, so that you will get the better outcome in your treatment. Understanding the tone and its impact on the conversation, how your tone is affecting. Like suppose if some sentence by saying giving emphasis or pushing more force on a specific word which gives most important while delivering the verbally. If you want to you focus on the each and word, all are, I didn't say you were stupid, these are the same sentence, but the therapist or the person is giving more force on specific word. So which you want to focus more while delivering the speech, you need to have the give more emphasis particular word while verbally. So what are the non-verbal communication? So apart from words, like non-verbal communication is a system of symbolic behavior that includes all form of communication except the words. Your posture, gesture, body movement, to sitting attitudes. So this all comes are the non-verbal cues. So in healthcare setting or in physiotherapist, the non-verbal cues are the most important element of the communication model. This may be unintentional, includes body movements, gesture, and facial expressions. So what is gesture? Gesture is mainly your head, hand, or eyes or other body parts movements. You want to show patient, you're asking the patient to do demonstrate the range of motion, or you want to ask the patient to raise the shoulder. So you need to demonstrate the patient on yourself or the model. So correct gesture and body movement is most important to have effective understanding of the patient. Of course, the patient is not from the medical professional, so patient won't understand your medical jargon words. You need to elaborate or educate the patient in very layman term, or you need to demonstrate the term. So patients who are intubated on a mechanical ventilator are most likely use head nods, mouthed words, or gestures are their primary methods of the communication. Again, gestures are positive gestures or the negative gestures. Some of like thumb up, winks, handshakes give the positive attitudes which you want to deliver to the receiver. Receiver's understanding, or whether it is a negative gesture from the receiver end may include the looking at one's watch, rolling eyes, taping one's foot. So these are the signs of boredom in then negative gestures. Then next is non-verbal communication is facial expression. Of course, the human face provide a complex but rich source of information regarding the emotions for healthcare practitioners as well as the patients. So these expression may also be used as punctuate the message or to regulate the flow of conversation between two individuals. Okay. The next non-verbal is your gaze pattern. What specifically the gaze pattern is important in communication? Like it gives the primary function is the monitoring, it assessing the how others appears or how a listener is responding to the speakers, or regulating, using a gaze to regulate the conversation, expressing the feeling and emotion. So gaze is also one of the non-verbal, strong non-verbal communication. Then comes your personal space. Without saying anything, without demonstrating anything, if you are allowing person or you are invading some personal space into the person, it will also give a threatener or uncomfortable feeling for the patient. Of course, as a physical therapist, we need to have demonstrate, or we need to move the range of shoulder joint or any joint. We need to do the objective examination. So joint examination, in that you need to inform the patient and take a proper distance between the patient and therapist. It may create an anxiety or feeling of loss of control. Okay, so personal space is your mainly personal space accounts for the 1.5 meter to 4 meter. You can say roughly one hand distance, or social distance, as now the pandemic is going on, so everyone is know about the social distancing. So public space is when someone is delivering a speech or talk in conferences or gathering, so it can be a public space. Intimate space is less than 1.5 meter the personal space. So most of the clinical procedures or the therapy we are performing, it is unto the personal space. So personal space, mainly this distance is which personal conversation is soft or moderate voice may take place. The personal distance is commonly used in healthcare setting where the clinical procedure is being explained or the patient is discussing a personal matters. Okay. Then comes your posture. The posture also suggests something, like if the patient is anxious or patient is depressed, the posture is also give a clue to the therapist or the healthcare practitioners from the patient, as well as to the patient from the healthcare practitioner. It is a vice versa. So what are the therapeutic communication? Therapeutic communication is a communication between the therapist or the healthcare practitioners and between the patient to have a good or aim to enhance the patient comfort, safety, trust, and health and well-being. Or you want to deliver a proper service to the patient or the society. So what is the purpose of the therapeutic communication? Mainly to collect the healthcare or related information about the patient, to provide the feedback in the form of healthcare related information, education and training, to assess the patient behavior when appropriate, to modify that behavior. Of course, after delivering a communication or after delivering an instruction, you want a certain behavioral changes into the patient in the form of education, in the form of intervention. So whatever you are giving exercises, you want some change in the patient. So that is why the therapeutic communication is most important. So this is main purpose of the therapeutic communication. So developing a strong communication skill is integral to becoming an effective healthcare provider. In a recent year, doctors, patient communication has been linked to improve patient satisfaction, better patient care, and a decrease in malpractice and lawsuits. Of course. So why communication skill is important? Our history taking mainly accounts for 60 to 80% of the diagnosis comes from the history taking. So once you are allowing a person to explain their symptoms or explain their history properly, that you are building a rapport between the patient and therapist or the healthcare practitioners. So good communication provide the information to the patient. Poor quality of the communication lead to the patient dissatisfaction. Mainly the doctor interrupt patients very early. We never ask the patient, we never listen to the patient. We always have hurry into our OPD because there are lots of patients are waiting outside. So we never give a time proper explaining to the patient. So that is most important. When the patient is explaining, so open-ended question you need to ask to the patient so that you'll get a good idea. The patient do not understand what the doctor is saying, or advice is too difficult to follow. These are the main causes of the poor quality of the communication between the patient and therapist. So communication is a part of your management in order to delivering effective healthcare to the particular patient. As a healthcare practitioner, it is expected to communicate competently both orally and writing with the range of professional manager and patient and families. So you need to have this quality to give an effective treatment. You are best in your practice, but you are not able to deliver what you want to give patient or what you want change in patient. So that will also affect your effective management. Okay. So therapeutic communication mainly the engagement, understanding, educating, sense of partnership. So the engagement is connection between the healthcare professional and the patient. It develops a partnership between the patient and therapist. Introduce yourself properly so that patient will understand. Allow the patient to talk without interrupting. Then what is understanding? Understanding that mainly healthcare professional makes the patient feel accepted. Healthcare professional emphasize with the patient that we understood your problem. We are not feeling your problem. See, pain is very subjective. Pain is very different. Each individual to individual, it varies. So we can't feel individual pain. We can understand. So that assurity comes from the therapist and same from the patient to the therapist. Then educating. To increase the patient knowledge of their illness, we need to educate the patient about the disease, its prognosis, its condition, or its treatment effects, or the outcome which you want from patient. Minimizing the anxiety, uses the language that patient understand. Do not use a medical word or medical jargon which patient is not familiar. Make sure all the patient's questions are addressed. So you should inform all the address. It is difference between the interview and interrogation. Once you are communicating with the patient, it should have interview. It is not an interrogation. You are not interrogating anything who is reluctant to make a full disclosure of the information. You are asking a person is coming to you because you have the specialty, so you want to interview the patient properly. The setting of the interview also plays major role in healthcare practitioners, where the face-to-face doctor office or the hospital or clinic provide a good source of information, or the patient will comfortably elaborate his findings to you. So that is also most important. And the type of questions, which type of question you are asking, whether it is close-ended, open-ended, so that open-ended questions always allows for a wider response from the patient side. So we should we should encourage the patient to tell the history. Then comes your healthcare practitioner centered interview versus the patient centered interview. What is the difference between this? In healthcare practitioner centered interview means healthcare the doctor, the therapist is dominating on the patient. He is asking too much. When the patient is confused which question I should answer first. So this should not happen. So patient centered interview, in this you are allowing patient to one by one is speaking. So these are the examples like what brings you here today. So patient is saying I have chest pain. As a healthcare practitioner, you are asking how severe it is, when does it occur, what do you do to relieve it. So you're asking too much question. Patient is confused which one to answer first. So this is healthcare dominating. So it is called healthcare practitioner centered interview. In contrast to other interview, where you are asking a patient what else, that I have chest pain, then what else? I have been having a lot of trouble of sleeping, then anything else you want to share, then this allows the patient to elaborate or give more information to the therapist. Then after taking the interview, the charting and documentation is most important. If it isn't written, then it wasn't done, because the chart at the time it occurs if possible. Follow all the facility guidelines, or is the information is clear, logical from the patient? Is it true? It is non-judgmental, or record all the abnormal and normal findings from the patient which you are getting. So always documentation is most important after having a good effective communication to have further communication. Thank you. This was from my side. Communication in healthcare practitioners, which is a very ignorant part actually.
Yes. So, any questions? Any questions to Dr. Sajauddin? Any questions? Okay. Thank you very much, sir, for joining this event.
Thank you, sir. Thank you.
Yes. On behalf of the Organizing Committee of Physiotherapy Congress 2020, I want to thank you for insight presentation. Looking forward to meet you again, sir, next time. Unfortunately, we have left only 4 speakers, sir. There is a drawback. Everybody are giving their talk and they are going away from this event. Yes. Thank you very much to all the participants, those who joined this webinar, physiotherapy event from miles of distance during this period. Thank you very much for your patience during this part. To the participants, those who joined in this webinar. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, media partners who have come from different destinations around the globe to support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. Let us thank to all the association with this conference by your presence. A special thanks to Program Manager, Mr. Madhu, as well as Mr. Kevin Brown for his continuous efforts in this putting us together under one platform in this online event. We will join at same time as we join today and complete day 2 remaining speaker presentations. We will send you officially through email, electronic certificate as well as a handbook. Finally, we extend our appreciation to each of you for your participation in this online conference. Thanks again, sir, as well as madam. Thank you. Have a nice day. This is signing off, Madhu.